Have you ever experienced any difficulties because of implant fracture, screw loosening, or dislocation of abutment? The brand new KS system is designed to avoid potential issues for implant placement. With 1 to 2 paper drilling sequence, now it is ready to place implants. The KS comes with abutment holding system, which is located in the lower part. When the implant is connected to the abutment, it holds these two parts firmly without using a screw. At the moment of loading prosthesis, the KS system prevents dislocation of abutment, which may cause by gingival elasticity. Also, it is more convenient for clinicians because it does not require to see X-ray after loading. For conventional abutments, clinicians are required to select between mini platform and regular platform. However, KS abutment is compatible with all different diameter of implant, so the selection of prosthesis becomes a lot more easier for clinicians. The abutment screw of KS system is designed slimmer and the space is being used to reinforce the inner wall of the implant body. The KS system is aimed to reinforce abutment by thickening the walls and implant wall as well. In addition, the depth of connection between implant and abutment is increased. As a result, structure of the KS system disperses masticatory pressure effectively. By the reinforced structure, the external force which may affect on the screw stays minimum and eventually minimizes the screw loosening. As of the diameter of 4.0 implant, the KS system secures the degree of strength at 4.5 with the increased depth of connection, reinforced walls of abutment, and thickened implant body. Find your key solution.
Introducing the CAS kit, the crystal approach sinus kit that safely lifts the sinus membrane with a hydraulic lift system. The CAS kit reduces the chance of membrane perforation. The patented CAS drill creates a conial bone lid that keeps the drill edge from direct contact with the membrane. CAS kit ensures safer drilling by preventing sinus membrane perforation. Using the drill stopper makes it easier to adjust the drill depth. The CAS kit features drill stoppers in 1 mm increments. It is possible to control the drilling depth precisely by using the stopper, which ensures safer drilling without the risk of perforating the sinus membrane. The hydraulic lifting technique of the maxillary sinus can facilitate the blood supply of the surgical site. The CAS kit's membrane lifter is using hydraulic pressure to elevate the maxillary sinus membrane higher and wider. Consequently, it facilitates blood supply, which encourages the formation of new bone and the healing process. Try the CAS kit that reduces the risk of membrane perforation to ensure safer surgery. Introducing the Asset kit for narrow alveolar ridge split. The Asset kit uses expansion drills able to expand the bone buccally and lingually, even in the case of severe alveolar bone resorption. Eliminates the use of a mallet. A safer and easier buccal plate expansion is achievable when minimizing the risk of buccal fracture. During the final stage of implant placement, the implant can secure a strong initial stability in the narrow ridge without tilting. The Asset Kit allows regular size implants to be placed in narrow ridges with a low risk of buccal fracture. You can try it out. Introducing the 485 kit, the kit for placing short implants. The 485 kit has drills with round design apex, which minimizes damage to the inferior alveolar nerve when performing surgical drilling. The 485 kit allows you to place 4 to 8.5 mm short implants. Only 3 drilling steps are required when placing implants with the 485 kit. When placing short implants, try the 485 kit. MS implant. Introducing the MS implant, the one body type implant for narrow bone width areas such as the mandibular anterior region. There are 3 types of MS implant: narrow ridge, denture, and provisional. First, the narrow ridge is a one body type implant suitable for areas with narrow bone width or narrow interdental spaces. Second, the MS denture is an implant designed for overdentures. Third, the MS provisional is used when immediate placement of the temporary prosthesis is necessary. Try the MS implant in the mandibular anterior region where the bone can be very narrow. Introducing Osstem Implants Hysil Plus. Hysil Light Plus is excellent at reproducing fine area. Hysil Light Plus can reproduce 20 micrometer lines without any tears or distortion. The stone model poured from a Hysil Plus impression produces smooth surfaces and separates cleanly. Thus, the user can fabricate accurate and precise prosthetics. Hysil Plus is highly hydrophilic. Hysil Plus has a short intraoral setting time of 2 minutes and 30 seconds. Hysil Plus offers a sufficient working time of 3 minutes and 50 seconds. Hysil Plus has a high elastic recovery ratio of 96.5% or more. Experience Hysil Plus for accurate and precise impression taking. Introducing the upgraded T2 Plus with superior high-resolution imaging, ultra-high-speed scanning, and ultra-low radiation dose feature. The T2 Plus has a 0.05 mm voxel size, which results in superior high-resolution images. This enables a more accurate diagnosis compared to the T2. With a T2 Plus, patient waiting times can be reduced thanks to a faster scanning speeds compared to the T2. Images are acquired in just 30 seconds. T2 Plus low radiation mode allows for safer scanning with only 22% of the radiation dosage compared to that of the T2. The low radiation mode allows scans for children and pregnant women without any concerns. The T2 Plus offers various field of view sizes for facial imaging, implants, TMJ, endodontic procedures, and more. The T2 Plus allows for customized scanning based on the treatment. The T2 Plus includes convenient and easy-to-use 1-2 software, 1-3, and VSEP. Through consultation, treatment and implant planning will help increase patient acceptance rates. T2 Plus is available in 3 colors: white, blue, and red. You can choose the color that best matches the ambience of your clinic. Introducing the upgraded T2 Plus with clearer images, shorter scanning times, and lower radiation dose.
임플란트 유명한 게 좋을까?
뭐가 달라도 다르겠죠.
임플란트 세계적인 게 좋을까?
뭐가 달라도 다르겠죠.
치과 의사에게 사랑받는 게 좋을까?
뭐가 달라도 다르겠죠. 오스템 임플란트.
글로벌 치의학계의 미래를 선도하는 최고의 학술 행사 오스템 미팅 2025 서울. 오스템 임플란트 트윈타워 이스트동에서 진행되는 오늘 행사에서는 치과 일상을 즐겁게 하는 디지털 치의학 꿀팁을 대주제로 치과인 모두를 위한 다채로운 맞춤형 강연이 펼쳐집니다. 특히 대강당에서 열리는 오스템 미팅 심포지엄에서는 임상 적용이 바로 가능한 강연을 비롯해 라이브 서저리 토론 세션이 펼쳐집니다. 아울러 각 세션을 빛내주실 5분의 좌장을 모시고 임상에 대한 폭넓은 견해를 들어봅니다. 오전 세션에서는 허인식 원장의 원가이드 임플란트 수술과 디지털 워크플로우를 통한 스트레스 없는 치과 진료 실현, 박찬 교수의 무치약 환자를 위한 디지털 임상 치의학에 관한 구찰 강연이 진행되고, 더불어 오전과 오후 두 차례 선보이는 오스템 미팅의 하이라이트 라이브 서저리에서는 배정인 원장이 오스템 디지털 솔루션으로 가이드 수술부터 DR 어번먼트를 사용하여 임시 보철까지 완성하는 전학 임플란트 치료를 선보이고, 박정철 원장이 원가이드를 이용한 발치 즉시 식립과 LCR을 적용한 상악동 골 증강술을 주제로 생생한 라이브 서저리를 진행합니다. 또한 토론 세션에서는 손영희 원장, 박창주 교수, 김용진 원장이 원가이드 라이브 수술의 임상적 추적 관찰 결과에 대해 청중분들과 다양한 견해를 나눠봅니다. 마지막으로 오후 세션에서는 정주영 교수의 교정 전문의의 투명 교정 적응기, 최영주 원장의 효과적인 투명 교정 치료를 위한 꿀팁 강연이 펼쳐집니다. 오후 2시부터 3층 세미나실에서는 임플란트의 기초를 다져볼 수 있는 임플란트 세미나, 개원을 준비하고 성공적인 경영을 뒷받침하는 개원 세미나, 그리고 치과 기공사를 위한 치과 기공 세미나까지 다양한 주제의 강연이 진행됩니다. 또한 오스템의 다양한 제품을 소개하는 전시 부스와 80편의 학술 포스터가 준비되어 있으며 직접 현장을 찾아주신 분들을 위한 특별 프로모션과 다채로운 이벤트가 마련되어 있습니다. 오스템 미팅의 모든 강연은 오스템 TV와 유튜브를 통해 생중계되며 대강당의 본 세션은 영어와 중국어로 동시 통역되어 전 세계로 방송됩니다. 디지털 치과의 밝은 미래를 제시할 오스템 미팅 2025 서울, 지금 시작합니다.
Good morning. At this Osstem meeting 2025, I'm the moderator announcer of this meeting, Kim Yoo-soo. Before we start, thank you for your support for the Dental Staff Forum yesterday. It's 9:03 with the theme of Digital Know-how, Pathway to Effective Daily Dental Practice. Osstem meeting 2025 Seoul will open. Today, not only in the Osstem Maguk Twin Tower Auditorium, but also in the third floor seminar rooms, special lectures will be held. Seminars on implant, clinic opening, and dental technology are scheduled at 2 p.m. Dental, which has been popular in the dental field for long, has renewed itself as Osstem TV. The existing dental members can continue to use the dental ID without membership registration. All lectures and live surgeries in the auditorium and the seminars on the third floor are broadcast real time. Take note of the new Osstem TV. Osstem meeting is getting more and more attention from dentists as years go by. Today, live broadcasting in English and Chinese is also provided for all in the dental field. And we have special gifts prepared for people who are participating here. The lucky draw will be held at the end of the program. Samsung Galaxy Z Fold 7 or irrigator, oral care sets, and many more are prepared. Stay with us until the end. Next, various programs are organized in the Osstem Implant Magok Twin Tower. On the first floor, you will see 80 excellent academic and clinical posters presented in the Osstem meeting. A photo zone is set up with the Osstem Implant mascot Leoga for you to capture memorable moments, and your visit is welcome. On the first floor, the scalp diagnostic booth is available to diagnose your scalp type and to get solution for you. You can enjoy various drinks at the cafe. You can get a drink with a coupon you received when you enter the venue. On the second floor, Osstem Product Exhibition Hall is found. Osstem Implant's proud product lineups can be experienced when you visit there. An exhibition zone is installed at the right exit of this auditorium on the fourth floor. Various promotions and discussion with those in charge of products can be made. Make sure you look around the area with some snack and drink. Regarding the Osstem app, many people are wondering what that is. After lunch, from 12:50, Chairman Gyokche of Osstem will provide a special lecture. Through Osstem TV, you can view the lecture. And many people are participating in the popular stamp tour. They cannot be missed. Collect the stamps from 5 places on the stamp paper and submit it to the registration desk on the first floor. You will get some gifts. Next, the online event. First, for those who log into the Dano site to watch, coffee and dessert coupons will be given 1,200 viewers during the event. Do not miss the lucky draw application pop-up appearing before the start of lecture sessions. Lucky draw winners will be announced at the end of the session and receive text message for the coffee coupon. For those who watch the online until the end, Samsung Electronics Galaxy Tab S10 Beauty Stand White Light, including 2 Beauty's White Light Gel, Osstem Family toothbrushing kits and others are waiting for you. Please stay with us until the end. One thing to note for the lucky draw is that for all online events, you need to log in to Osstem TV. Do not forget it and register as a member in advance. Those who join us using mobile phone, you need to set the mode in the landscape mode so that you can participate in the pop-up event. And we have gifts prepared for participants in the hall. After lectures, on and offline, best questioners, 10 of them will be selected, and WAPIC irrigator will be provided to them. So let's get started with the meeting. To mark today's event, Vice President Hong Soo-yeon of Korea Dentist Association will deliver a congratulatory message. Please give a big round of applause.
Good morning, everyone. I am Hong Soo-yeon, and Osstem, to me, personally, is a very special company, and we go back a long way. And when attending the Osstem meeting, I had given a congratulatory in my personal capacity, but President Park Tae-gyun of the Korea Dental Association has given me a script to read, so I will read his words on his behalf. in the Magok headquarters, Osstem Meeting 2025 Seoul is being held, and I'd like to congratulate this meeting and thank you for the invitation to this special meeting. From 2004, Osstem Meeting has started. Osstem has become a very important forum, and it is a platform to share the clinical practices with the dental community worldwide. This year, we are going to deal with the digital tips, live surgery, implant, prosthetic seminar, and there will be many academic and hands-on lectures so that the dentists will be able to see for themselves the development of the digital practice in the dentistry. Osstem implant is present in 31 countries and is providing supplies to more than 90 countries. And Osstem implant is Korea's representative company. In 2024, the revenues were higher than 1.3 trillion, and it is being loved by the dental community throughout the world and is growing by leaps and bounds. And there are many academic support programs and also scholarship programs, and there has been a lot of philanthropic activities that it has contributed in and is enriching our lives. I hope that this will enhance the level of the expertise of the dental community and also contribute to the well-being of the citizens. And I wish you all the best for Osstem implant. At today's meeting, 2025 Osstem Meeting Seoul, I would like to thank Chairman Choi Kyu-ok and CEO Kim Hae-sung and all the management and employees for all your hard work. Thank you very much. And Osstem implant, leading the dental culture, I wish you the best. Thank you very much.
That was a very hopeful message for Osstem meeting. That was the start of Osstem meeting. Thank you, Vice President Hong. At the Osstem Implant Magok Tin Tower Auditorium, Osstem Meeting 2025 Seoul is broadcast live online. And for online viewers, this is the first event. Please check the pop-up window on the Osstem TV and apply for the lucky draw. The winners will be announced at the end of each session, and they will immediately receive the text message with a coffee coupon. One thing you have to remember is that the longer you watch, the higher the chance for you to win a coffee coupon and dessert coupon. So keep that in mind. Keep watching us. Now it's 9:13. Throughout the world, the dentists are joining us at Osstem Meeting 2025. Let's start the first session.
The first session will be moderated by Professor Kwon Keung-nok of College of Dentistry at Kyunghee University. He has served as the Faculty of Dentistry at the University of Geneva in Switzerland, at the Harvard School of Dental Medicine in the U.S., served as the Dean of the College of Dentistry at Kyunghee University, President of the Korean Academy of Prosthodontics and CADE, and currently the President of Korean Academy of Dental Science, and teaching at the College of Dentistry at Kyunghee University. Hello, Dr. Kwon. Thank you for that introduction. Hello, everyone. Osstem Meeting 2025 Seoul. I am the first sessions moderator, and I would like to thank you for your participation and also thank you for inviting me as the moderator. And I'd like to introduce to you the first speaker. The title is Achieving Stress-Free Dental Practice with Digital Workflow, centered on One Guide Implant Surgery. And from Ha In-shik Dental Clinic, Dr. Ha In-shik is here with us. Please welcome him with a big hand. Hello, everyone. Through digital workflow, how we can achieve stress-free dental practice. That is going to be the title of my talk, and I am Ho In-shik. Nice to meet you. So this is the order of my talk. What causes us stress in our clinical practice? And second, I'm going to talk about how the digital dentistry can solve these problems. And lastly, I'm going to wrap up with a conclusion. So what stresses us out? It's probably the difficult treatments or patients with whom communication doesn't go smoothly. And so let's first look at the case. A woman in her 40s with severe periodontal disease, maxillary anterior teeth were highly mobile, labial frenum extended toward the palatal side with a low vestibule. The oral vestibule was shallow. The bone around the maxillary anteriors was largely resorbed. Frenum position abnormal, maxillary anterior significantly proclined. So multiple problems. The panoramic view shows advanced periodontitis in the maxilla and the extensive bone loss. We performed a labial frenectomy, and immediately after extraction, we placed implants and carried out bone grafting. And after about 3 months of healing, we completed the prosthetic phase as follows. And about 5 years have passed during the pandemic, COVID-19. In the meantime, the patient could not visit regularly. But when she did return in 5 years, the moment she entered the hospital, you could sense that on her face there was this discontent and dissatisfaction. And what was her problem? For 5 years, the patient heard from her friends such comments like, "Why is your mouth like that? You look like my grandma." And that's the comment that she heard often. And she was working in the beauty service industry. And because of her appearance, she must have undergone severe stress. And this is the second challenging patient. So he presented for implant placement in the maxillary right molar region, but he could not get the implant. 2 years ago, there was the maxillary sinus lift and placing implant, but the implant migrated into the maxillary sinus, and he could not have that problem solved. So he went to a clinic to get this removed by an oral surgeon. But after that was removed, for 2 years, he could not get any follow-up treatment, and he could not understand the reason why. And so this was the panoramic image at presentation. We see that the bone appears insufficient in the maxillary right region, but in that state, you could get implant placement. But according to CBCT, the bony window superior to numbers 15 and 16, you could see that it was unhealed, and this was very large. And so 2 years have passed, and the bony window had remained unhealed, and so this did not look very happy. By removing the implant, they have opened the window even further, and it has exceeded the critical size defect. And in order to get that implant out, the window was too superior. The position was not favorable. And so the patient went to a university hospital, and that hospital had advised to extract the second premolar and place implants at teeth numbers 17 and 15 and restore with a bridge-type prosthesis. And what choice did this patient ultimately make? Well, no patient shows up determined to make life hard for the dentist. It's just lack of communication or lack of explanation. And so it was not possible to solve the problem right. not having enough clinical experience. And so I'd like to walk you through the problem-solving steps. First, why did this patient develop grandma-like lip wrinkles? We compared her initial pre-extraction with the post-prosthesis photos. To improve the proclined anterior teeth, we intentionally designed the prosthesis with a reduced overjet. But the problem was the vertical dimension had collapsed and the lip support had also sunk. The cause of the problem was clear, and we set out to correct that. To improve her lip wrinkles, we pulled up the 5-year-old design file and redesigned the crowns to change the external form. We reinforced the buccal contour of the prosthesis to improve lip support. We also adjusted the overjet toward the pre-treatment relationship. So we could see that this overjet was modified to approximate the pre-treatment state, and after removing the existing crown, we designed a new provisional and fabricated with a 3D printer to compare the change in lip support. There was improvement in lip support, but the patient wanted more. We determined that this could not be addressed by the crown alone and decided it would be better to remake not only the crown but also a customized abutment. And so we newly designed a customized abutment and crown as shown. And we fabricated the new crown using a DLP 3D printer and observed the condition. This shows the placement of the new abutment and provisional crown. Above all, the key point is the change in lip support. It showed a considerable change compared to before. At this level, the patient accepted the altered appearance, and we proceeded to fabricate the final restoration. We fabricated the prosthesis in full zirconia. Based on the contour of the provisional, we completed the final restoration as follows. This is the appearance of lip support after delivery of the final restoration. The patient had wanted a bit more improvement, but in my thinking, looking at the maxilla and mandible, the structure and the vestibule location and the frenum, additional surgery, changing and making further improvement was not feasible, and the patient accepted that explanation. And this is the second patient. The patient had previously had an implant displaced in the maxillary sinus. A bony window remained without complete healing. And we determined that if a lateral window was created between the maxillary area and the second molar, a sinus bone graft would be sufficiently feasible even in the current condition. So we performed the maxillary sinus lift and bone graft as shown, and I think the xenograft was used. As shown, the grafted bone is well positioned in the maxillary sinus. Numbers 16 and 17, we see that the bones are well placed. And 3 months have passed, and the grafted bone had stabilized well, and inside the maxillary sinus appeared healthy. And the guided surgery plan was set up. The implant is planned to be placed at the exact center of the desired prosthetic design. We partially reflected a buccal flap and placed the implant. And the 2-month healing image shows ISQ values higher than 80, which is very high. So we waited 1 month more, and at 3 months, we performed an intraoral scan and proceeded with the final prosthesis. Here are the final design and the lab work. We fabricated customized abutments and the final prosthesis simultaneously, and we completed delivery of the final prosthesis. However, at the 1-week check after delivery, the patient had unexpected reaction, and so I was a bit bewildered. The patient said that he could not enunciate and regretted getting the treatment. And so that was his comment. And so this was unexpected and was at a loss as to how to react. Faced with such post-treatment dissatisfaction, we, as clinicians, generally respond in 2 ways. One is we either persuade the patient or we listen and empathize and let the patient persuade us. If the patient's request is clearly unreasonable or there is no clinically better alternative, then we should persuade them with all the documentation. But if the patient's position is sound, then I think we should listen carefully and try to reflect it in the treatment plan. So with the first treatment, I was the one persuaded because her concerns were understandable. And clinically, there was room to improve the current situation. But as for the second case, it was different. In my thinking, I explained the situation, and the mandibular implant position and prosthesis was affecting in a great deal. And it was placed more to the buccal, and there was limitation in getting that to the buccal side, and it had only been a week and he did not have time to adjust. So I explained, and he understood that it was the best for the time being, and so that was the end of that. So we should strike a balance and try not to overwhelmingly push the patient to persuade him to see my way. We just need sufficient documentation to persuade the patient, and it will speak for itself. The second major source of clinical stress, when ambiguity and uncertainty make it hard to establish a treatment plan. That's when we are stressed out. If we don't absorb that stress, then it will simply be transferred to the patient. So this is another case example, a woman in her early 40s with poor periodontal condition and a history of immune-related disease. Severe horizontal and vertical bone loss, low vestibule, and little to no keratinized mucosa, presenting a multitude of difficult challenges. And so, in this condition, a prosthesis with normal overjet and overbite looked unachievable. The maxillary sinus was highly pneumatized with severe vertical and horizontal bone loss, and this was obvious at first glance. What should have been the treatment plan B? And second example, the patient wanted to replace an old prosthesis spanning the anteriors to the right premolars. His wish was that the teeth will not be as long. It didn't matter if it was implant or just a bridge using his teeth, but he just didn't like the long prosthesis, and it didn't really matter what kind of prosthesis was used. But when the pen base is long, if it is presenting the same core challenges whether we choose implants or a bridge. So either way, it was difficult. The existing prosthesis splinted 5 teeth into a single unit, and there was vertical and horizontal bone loss around the incisor and canine areas. When a treatment plan doesn't immediately come to mind, a digital workflow plays a crucial role. And so the treatment process for the first case, the patient had severe periodontal disease, and the patient had lost many maxillary molars. She was a relatively young woman in early 40s with systemic immune-related issues. There was bone loss, horizontal and vertical, and the vestibule was very shallow. And the alveolar and the vestibule were positioned similarly, and keratinized mucosa severely deficient. Where should we begin? First, we tried drawing a prosthesis that corresponds to the ideal occlusal relationship and located the appropriate position of the implant in the guided software. And if we position the implant at the center of that planned restoration and secure an appropriate pre-implant soft tissue dimension, where would the implant end up? Wouldn't that place the implant inside the maxillary sinus? If so, what should we do first? We must first create bone so that implant can be placed in that position via a sinus augmentation. We performed maxillary sinus lift using the Osstem, and we repeated the same sequence on the contralateral side, first designing the ideal prosthesis. And we determined the implant position to fit that prosthesis as shown. A sinus augmentation is likewise required on the opposite side. And on both sides, bone grafting was performed with Osstem's xenograft. And approximately 1 year passed. Considering the patient's systemic health, the timing of implant surgery was decided. And there was a bit of a delay than we had expected. We designed the prosthesis first to fabricate the surgical guide. The implant positions in the maxilla and mandible were determined according to the prosthetic plan. And for the maxilla, as you can see, we planned additional bone grafting via a crestal approach because we needed more bone. However, this patient presented another issue. According to the surgery guide, the intended implant positions were considerably muckle to the MGJ, indicating a lack of attached keratinized mucosa, and the vestibular depth was very shallow. After flap elevation and implant placement, a palatal soft tissue gap was noted. We created a pedicle graft from the inner surface of the palatal flap to fill the soft tissue deficiency on the palatal side. Pedicle graft was very useful because a pedicle graft retains its posterior vascular supply. Its likelihood of survival is substantially higher than that of a free graft. Post-healing appearance, you can see that peri-implant soft tissues healed well and newly formed keratinized tissue was observed. The contralateral side was managed with the same guided procedure, and the implant could be placed with no additional bone graft. At the second molar implant site, keratinized mucosa was likewise deficient. So as on the opposite side, pedicle graft was used to close the soft tissue gap. After healing, the peri-implant soft tissues showed relatively good resolution. And in the right mandible, there was a dual problem. The inferior alveolar nerve ran very close beneath the plant site, and the overlying soft tissue was very thin. So since the soft tissue was thin in peri-implant mucosa soft dimension, we could be needing more of that, and so we could have higher likelihood of peri-implantitis. So we planned an Osstem TS extra short implant. And so we addressed the soft tissue deficiency by increasing the soft tissue thickness above the implant. And so we were able to get a more dimension to avoid peri-implantitis. We performed a connective tissue graft to create sufficient mucosal tissue, and we have adequate soft tissue thickness. And we proceeded to the definitive prosthesis. And we designed and customized abutment and prosthesis. We finished. So what had seemed almost impossible at the first visit ended with a near normal overjet and overbite. From the very start, a digital workflow let us define the end goal precisely and execute the plan. And so this was what made the result possible. This is the final panoramic image. Treatment for the 30s region will likely need to follow up. For this kind of patient, this must not be the end of treatment. Initially, we scheduled recall and supportive periodontal therapy every 3 months. But you can see that it's evident that maintaining the current status is challenging for the patient. And peri-implant mucositis and peri-implant implantitis likelihood was high for this patient because of the physical condition. And we can see that the plaque control is not being done well. So we reduced the cycle from 3 months to 1 month. And plaque control was used aggressively. And we were able to follow up 1 month and try to maintain the patient situation. And we were able to preempt peri-implant mucositis and implantitis before it sprouted. And now, case 2. How should we deal with this long pontic problem? This is the situation after removing the old crowns. And at first glance, there appears to be no vertical deficiency and only a severe horizontal defect. But in reality, however, these cases combine both horizontal and vertical deficiencies. In the pontic area, we referenced the original prosthetic contours, but for the pontic, we adjusted form and length in anticipation of future vertical and horizontal ridge augmentation. So the template is very important. The provisional was made first to reflect the intended position and external form of the final prosthesis, because these become the reference for the vertical, horizontal ridge augmentation. And so this is the provisional using the 3D printer. And based on this, we had done the vertical and horizontal ridge augmentation. And to keep the procedure as minimally invasive as possible, we performed bone grafting with a tunneling technique, and the graft material was xenograft. It was less absorptive. And we chose this approach to preserve the existing vestibular depth as much as possible. And the conclusion is, well, I think we were too ambitious. After post-op, we achieved some horizontal reinforcement, but vertically we did not reach the desired level. So what we need to do is horizontal augmentation. It could lead to vertical disaugmentation, because if you increase the volume horizontally, then the volume vertically will be inevitably reduced. And so the two have to be looked at together. So that was the conclusion. And during healing, some grafted areas developed infection, so we fell short of the result that we had wanted. Next, we adopted for a method that provided a more reliable outcome using Osbuilder and tenting screws. Together with xenograft and allograft, we carried out vertical and horizontal augmentation. Because we achieved a substantial increase in soft tissue volume, a periosteal releasing incision was unavoidable. We shortened the provisional to avoid compressing the tissues, matching the newly increased vertical and horizontal dimension. So overcorrection is recommended because of the shrinkage. After 3 months, we rescanned and remade the provisional. And with the vertical and horizontal gains, The ponte contour now looked more natural. And with a guided design, we planned implants at the lateral incisor and canine positions. And after removing the os builder, we placed the implants at the lateral incisor and canine positions. Following healing, we proceeded with the intraoral scanning, and we designed the final prosthesis for both natural teeth and implants. And the final prosthesis were delivered. So compared to the pre-treatment state, there was marked improvement and the patient was highly satisfied. And he even referred a friend with a similar problem for treatment. So today's conclusion. How can we overcome stress when coming face to face with either nightmare patients and patients with complex treatment plans? We first have to have meaningful communication with them. And sometimes they can persuade you, and other times you must persuade them. But listening is very critical. So we must empathize and sometimes let the patient persuade them when they're making sense. But the problem occurs when they overwhelm you, even when they should be really listening to you. This does not lead to a good outcome. You need to be attentive but assertive enough when need be and reflect the patient's requirement in actual clinical practice to a reasonable level. And you have to have real problem-solving skills. And in that sense, digital workflow could play a big role. And at the center are surgical guide design skills and prosthesis design skills. It would be wonderful to do all these directly, but that is easier said than done. And so you could rely on the lab, and even if you don't do it yourself, you still need to have sufficient understanding. A complete understanding and mastery of both software systems is not an option. It is essential in order to achieve your end goals. And without that understanding, you may not be able to understand the patient's needs and just consider them as difficult patients. You need to listen well, and you need to have the problem-solving skills. That would be my takeaway. Thank you. Thank you. Let's give him another round of applause. And so, digital workflow could reduce our stress in our clinical practice. I know you have many questions, but please wait until the Q&A after both presentations are over. And we are also taking questions online. I hope that there will be active discussion and Q&A from the online participants as well.
The second lecture will continue. Professor Park Chan from Jeonnam University Dental School is going to talk about a review of digital clinical approaches in the treatment of edentulous patients. Please welcome him with a big round of applause. Good morning. My name is Park Chan from Jeonnam National University. Thank you very much for inviting me to this 2025 Osstem meeting Seoul. And Professor Kwon Kung-nok is my respected mentor, and it is my honor to share this space with him. I will talk about a review of digital clinical approaches in the treatment of edentulous patients. I led my career in the Jeonnam National University Dental School. Currently, I had the department some slides from my 2019 lecture to indicate that digital denture will be in mainstream for PFM, composite resin dental implants. This came true now. The technology has advanced so better than I expected. The photo on the left was taken when I attended the International Dental Equipment Exhibition in Germany this February. The image on the right, drawn by ChatGPT, showed a much more advanced form after just a few months. This is a remarkable advancement of technology. In the AI-generated picture drawn a week ago for this lecture, it is almost like I had come from the distant future. In this era of such rapidly advancing digital dentistry, do you use digital dentures a lot? For dental labs that do a lot of analog work, it may be welcome. However, as far as I know, it doesn't seem to be widely used among dentists because, as shown in this slide, although it appears that many digital methods are being used, in reality, the clinical procedures for dentures in the dental office are not very different. That is why it doesn't seem to provide a significant benefit. Nevertheless, many of you here probably sense it vaguely, but someday dentures too will inevitably be carried out digitally. I hope this lecture will be of some help to you from that perspective. But if you view dentures not merely as dentures but as the starting point of diagnosis for a full mouth treatment, then the digital denture lecture may prove to be more helpful. So I always emphasize full denture tooth arrangement to the residents I teach. When diagnosing patients who require full mouth reconstruction, I always instruct them to first carry out a tooth arrangement directly before proceeding further. So although I lecture on digital dentures, in reality, I base my diagnosis more on analog dentures. Today, I'm talking about digital dentures, but I want to emphasize that principles and fundamentals are what matter most. Before we begin, I would like to say one thing. The digital denture I will be discussing today is not the hybrid type I showed earlier, where the clinical procedures follow the traditional method, but the fabrication is done digitally, but rather a concept aimed at a completely digital denture as shown below. This is not to say that the above method is insufficient or not a true digital denture. On the contrary, I believe it to be even better than mine. However, I view digital not as an end, but as a means, prioritizing practicality and ability to deliver results to patients quickly above all. From that perspective, I will explain my way, and I ask for your understanding. This is the contents. Let's take a look at recent review papers on digital dentures. It is a 2025 JPD paper. It shows that digital denture fabrication can be more cost-effective than the conventional method while providing a similar level of patient satisfaction. Many papers evaluate the digital dentures from the perspective of efficacy and satisfaction. This shows the reality of a digital reality in 2025. Digitally fabricated complete outcome, complete dentures are more cost-effective than conventionally fabricated dentures. There are various impacts of conventionally and digitally fabricated complete dentures on PROMs. This is the reality. If we cannot, however, considering the practical practices, I think the conclusion of this paper is more appropriate. Although Digital dentures are not very good in muscular function or production. They are comparable in terms of overall satisfaction. This is a case. There are edentulous patients we encounter regularly. As you can see, the edentulous patients often present with flabby tissue in the anterior maxilla, a condition known as combination syndrome. The patient had a complaint of extreme pain, particularly with his mandibular denture. The mandibular oral cavity revealed numerous sore spots. Large lingual thoraces were present. This suggests that this patient would not be satisfied with a denture, whether analog or digital. This problem could not be easily overcome with conventional methods, let alone scanning. The patient complained of pain, a lot of pain, particularly in the left posterior area. So this is a typical case where denture is not properly used. So the denture base continues to shrink in size due to pain, and the denture becomes messy due to repeated relining. I use digital dentures for all my edentulous patients except for special circumstances. Capturing patient information through scanning is challenging. In analog, capturing functional impression is not that difficult. I mentioned function impressions. Even in the maxilla, where analog methods do not require a lot of attention, scanning is challenging. Let's take a look at the scans taken of this patient. You can identify the problematic areas. In my experience, the most challenging aspect is here, especially when the maxillary tuberosity is very convex. It's difficult to capture the buccal vestibule fully. It also has a slight undercut, making it crucial for retention. And with the current scanner tip shape and size, it is difficult to overcome. Scanning of this patient appears to be good. The previously mentioned issues can be overcome by controlling the patient's opening and closing of the mouth to some extent. However, even areas that appear clear on the scanner screen are a very different story when using general purpose software. What do you think? Can you see? It looks like the alginate impression has been pushed around or torn. It looks like that. As a result of these scans, when you actually work on the dental CAD, many errors occur and the design does not proceed properly. So I will explain the scanning using the video. The scanning that I'm doing. I always begin scanning from the front of the patient. So that is my principle. And in the video, my face is cut off, but during scanning, I always focus solely on the patient's oral cavity. So I don't look at the scan screen to make sure that edentulous region is scanned properly. I just focus on patient's oral cavity. So I just pay attention to the sound during the scanning. I avoid excessive scanner movement. The scan image can be torn if you have excessive scanner movement. So the scanner tip is moving just like a flowing water to facilitate scanning. In the maxilla, there is palatal area, buccal or labial size can be challenging. So if you scan it excessively with excessive motion, that would create more errors. So when scanning is not properly done in that area, I don't use excessive scanning motion. I complete it in a simple way. So as you can see in the video, the undercut in the front is not properly scanned. So I just finish it that way. So it's difficult to capture the scan in one go, especially in this area where there is an undercut before it. So this is why excessive scanning motion in this area often results in messy and broken scan time. I avoid excessive motion in this area, so it takes just 1 minute and 40 seconds for the upper. And in the mandible, there's alveolar ridge, and the scanner tip is positioned superiorly. The buccal shelf can be scanned pretty easily. The buccal shelf can be easily taken. That way, we can secure enough retention for the denture. On the lingual side, there's a lingual frenum. The tongue is positioned behind it, so scanning is not difficult. And in the center, mylohyoid ridge is present, which is lifting the tongue. The muscle is there, so it is difficult to access the area because of the torus, but it is well scanned. So mylohyoid muscle mentioned earlier is positioned relatively inferiorly in the front region and more superiorly toward the back. This is anatomically pushing the tongue to the opposite side as you enter. So scanning the front lingual frenum, position the scanner tip deeply, pushing the tongue to the opposite side as you enter, and then slightly go upward as you scan. This will allow for smooth scanning at least up to the front and central portion of the lower lingual side. And retromylohyoid fossa is present at the posterior region of the tongue, which is a challenging area. However, one thing is clear in my experience. The important retromolar pad area is definite anatomically, so scanning can be done relatively easily. The scanning in the mandible, when I was not very skilled, this is an old video, so you can learn some lessons from my mistakes. So it starts at the posterior region of quadrant 3, and retromolar pad should be accurately registered. So retromolar pad should be accurately registered, but now it is not the case. You can see on the screen. So as I explained before, I need to solely focus on the patient's oral cavity. But here I am looking away from the patient's mouth, and the stitching cannot be properly achieved. In the mandible, a lot of resorption occurs, so alveolar ridge should be targeted. Buccal and lingual areas can be scanned rather in a balanced way. In the lingual area, you need to start from the front. But if you look at the scanning, I started from the posterior region, and the scanner tip cannot be positioned properly. So on lower lingual border, lower lingual area cannot be scanned properly in that way. The post-scan process involves determining the patient's exact CR center regulation and securing appropriate vertical dimension. Many doctors struggle with this, and let me share my method. Most reported cases, whether digital or conventional, involve the traditional recording base and wax rim process. It is the already proven method that I already use, and I believe this is the best. However, the additional process of creating these rims significantly reduces the advantages of the digital. This is my own digital denture workflow. You don't need to check it carefully. Creating a rim itself will require several steps in the workflow. Also, while this is not really a disadvantage of the rim, I'll explain the limitations of using the rim compared to the method that I will explain later. You are seeing now an incorrect bite. In reality, the image is distorted due to the scanner's faulty algorithm after only one side bite is scanned. So there's a distortion in the screen, and you can immediately identify the incorrect bite as it is displayed on the screen. But if there had been a wax rim, it would be difficult to identify it so easily. So I make the digital dentures without using wax rims. Although there's not much scientific evidence to back it up, I'm getting pretty good results, at least for dentures that are finished within a couple of hours on the day. It is used like this regardless of whether it is partially or completely dentureless. After bite taking, you can immediately check it by rotating it left and right on the cat. And if necessary, you can compare it with the patient's mouth. The patient was observed to have a sagging upper right tuberosity. This information can be intuitively and immediately confirmed, which is the biggest advantage of digital denture. While accurate diagnosis and observation are essential in clinical practice, in reality, many procedures are passed on to the dental lab. And this confirmation process offers significant benefits. And this is my method. I use the scanner's algorithm to capture occlusion. This is an example. I've copied a patient's denture and cut off the front portion. And if it is inserted, the posterior stop will cause it to bite at the VD and CR positions. If you scan for occlusion after scanning for the upper and lower, a scanner that has registered existing edentulous upper and lower morphology will be able to capture the occlusion. So this is what it is. The occlusion, taking occlusion can be made easy. You might think that the edentulous jaw has no special features compared to the jaw with teeth, but that's surprisingly not the case. In my experience, the open area due to the incisive foramen, frenum, and the shape of the alveolar ridge extends to the canine area. Capturing occlusion is usually possible. I fabricate the digital open trays. Due to time constraint, I won't go into detail today. However, the important thing is that the occlusion acquisition method used by scanners for fixed restorations can be applied to scanning for edentulous prosthetics. That's something you need to understand. Those of you who see this may have this question. While this approach will check the VD, will it actually capture the CR properly? You will also wonder how information about anterior tooth positions and occlusal plane can be transferred to the lab. And of course, if this screen is the only thing sent to a lab, that would be problematic. I can't explain everything today, but this is the digital open tray that looks like this. This photo will give you a general idea of how information is delivered. Patient's information is delivered. However, due to time constraint today, even if the anterior portion is opened for occlusion, I hope you understand that we need to find a way to convey relevant information. Due to time constraint, I will skip the lab process. The CAD process, material properties, and methods used in the CAM are all important. Digital dentures can be completed through printing or milling, and I often use a more practical printing method. This denture was printed as one body, and the outer gingiva was masked with resin to finish the job. It looks like the images of conventional and new dentures often seen in complete denture textbooks. It doesn't matter whether it's digital or analog. Analog dentures will be uncomfortable if they do not adhere to the principles. Even digital dentures can be made excellent if they can convey accurate patient information. This case clearly shows the S-curve shape of the lingual and demonstrates excellent retention. This case, another case, is a completed case in which the misaligned teeth on the left were corrected to look like the one on the right. It was completed, a 3D printed denture made without difficulties. Although the digital denture was made as a temporary, the results were no less than those of the final denture because the incorrect VD and CR of the old denture were improved. This patient was very pleased with the denture and even had an unplanned implant placed. Upper multi-unit abutments were connected, mandible. While I'm not a huge fan of All-on X, I think it's a very suitable case for demonstrating how the previously mentioned denture arrangement can be applied to full arch implant reconstruction. Printed dentures will require further long-term validation. Currently, I believe the dentures using milling blocks as here, which combine the teeth and gums, are the most complete digital dentures available in both strength and precision. There's a cost hurdles, but I hope that will be resolved in the future. Review of this lecture. Full digital denture fabrication has various limitations. A realistic goal should be the temporary denture quality. Especially mandibular lingual border scanning, maxillary posterior undercuts, mobile buccal borders require a high level of skill. And taking occlusion is very challenging, but due to the development of technology and tools, a lot of improvements would be achieved in the future. I've been interested in fabricating digital dentures since 2016. For nearly 10 years, I wrote a narrative review paper on digital dentures on the left while a visiting professor at the UCLA School of Dentistry in 2023, which contains everything I know, including the lecture of today. Please refer to it. I'm struck by the sheer number of edentulous patients around the world. While a visiting professor at UCLA, I traveled around the US and Mexico carrying only a printer and scanner, completing dentures in a day. The experience gave me a sense of fulfillment and pride. Even after returning to Korea, I want to continue this work, so I visit the foreign patients medical center in Gwangju once a month to make digital dentures. It's always a challenging work, and I often fail to deliver proper results. However, you can go digital very easily. This patient was completely satisfied with the lower retention, which was a concern. However, this patient also had some issues, as is in the left photo, with tooth exposure and occlusal plane. So we simply took a facial photo and redesigned it based on that information. So there's no need to start all over from scratch. Therefore, the time and cost involved are incomparable to analog methods. While it's not perfect yet, I encourage you to give a try to digital dentures. And if you encounter any difficulties along the way, let me know. Thank you for your listening. Thank you.
Thank you very much. We are now going to proceed with a Q&A. We have many questions coming from online, but we will first take questions from the floor. So having listened to the two presentations, any questions or comments, please raise your hand. I will call on you, and also you'll be given a microphone. While you're thinking of what to ask, Professor Park, we are in the same discipline, and I'm interested in digital. So in prosthetics, margin is a very important issue in crown, bridge, and denture margin, and it closes the margins. So looking at your work, setting the margin seems very challenging. So could you explain it?
I didn't want to talk about it, but that was a very observant comment. In the CAD process, teeth alignment is very challenging, but in reality, as Professor Kwon said, the margin area setting is the most challenging area. And currently, the dental CAD, the border sealing is not the denture form to be sealed is not really materialized. They can be modified to overcome the issue, and there are some suggestions, but they have limitations. But based on my experience, I don't think that can be a huge problem, because when you use scanning for impression taking, a certain area can be overpressed or underpressed, as described in the textbook. It is an impression taking without pressure. So existing alternate or VPS impressions, this can be superior to those. So in terms of retention, there can be some minus factor, but in terms of retention and stability, the three factors of dentures, the two remaining factors show superior results. Therefore, using it clinically would not pose any problems. Sorry, does that answer your question? Thank you for your comment, and I will ask the audience to ask questions. Any questions to Professor Ho?
Let me read out to you a question from online for Dr. Ho. It's from nickname Shu Shu Shu. If you extend overjet, I think it could help with the lip support. And in that case, is there any adhesion of teeth to the lips? I guess this question is coming from experience. I think you can think of it case by case. Personally, for the anteriors, whether it's natural teeth or prosthetics, finishing the prosthetics virtually, I think it could be risky, because on-screen prosthetics image and the actual temporary or final prosthetics, the situation may differ from the screen. So even if you use a face scanner, they have limitations. And so the lip adhesion or complications, I think you should preemptively adjust using the temporary crown. Yes, so Dr. Ho said that whether it's temporary or provisional, so you first do the fitting and then make decisions, because yes, anterior through the temporary crown, you could see the exterior and the contour, lip support issues. You can confirm beforehand, and if you're fully satisfied, then you can go on to the next phase. I think that's the textbook approach. Yes, that will reduce the stress, but I think it will increase the cost. Well, 3D printer, the cost is very minimal, and if you have a problem with the final crowning, then that will cause a severe issue. So you can prevent problems beforehand, and I think that cost will be justified. Thank you. And yes, we have a hand in the back, so please identify yourself.
My name is Jo Jong-ho from Incheon. I have a practice in Incheon.
You talked about the numbers 17 and the case where there were maxillary issues and you check the anteriors for the anterior, but for the posterior, how can you solve the problem? And you could be chewing over the tongue or the lip. And do you have any know-how for posterior compared to the anterior? There is not much benefit coming from a temporary crown except for occlusion. I don't think it is quite that necessary. The teeth arrangement and the maxillar horizontal and vertical positioning, the exact placement, the position is almost determined. So I don't think it's necessary to confirm that position using the temporary crown. I did not talk about it in my earlier presentation, but if there's inconvenience by the patient, you have to think about whether you should persuade the patient or be persuaded by the patient. And in this process of explaining, I have this full documentation from the image from the first presentation. So I try to tell the patient why this is the best that we can do, and most patients will buy that idea. And of course, they may not be fully persuaded, but they are content with that condition. So did that answer your question? Yes, we'll take additional questions from the floor.
For Dr. Cho. My name is Jo In-ho.
Dr. Ho, you talked about the patient who could not enunciate properly, and he had kind of frustrated you. Did you not use temporary? No, I did not use. So yes, I think temporary is very important. If you had used a temporary, then you could have detected earlier on potential problem with the enunciation. If we had used the temporary and if we had detected it earlier, then the final prosthesis could not have reflected that, because the patient's claim was it should have been more buccal oriented. So there was this issue with enough space. Yes. So then the prosthesis in the maxillar, if it tilts to the buccal side, then it could create problems. And we didn't have much room. And for the mandibular prosthesis, it was already skewed toward the buccal side, and I told the patient if in order to solve this problem, there was the need to recreate the mandibular prosthesis, and it was just a week after he got the prosthesis. And our brain has to have the time to process the new positioning of the prosthesis. It takes several months. So if he got a new prosthesis, then he would go over the same cycle again. Yes, I agree with that. But as for enunciation, usually the patient will get used to it and that will be solved naturally. So it was just a week. So did this, was this solved? After that, we did not get any more complaints from the patient. Thank you. I have a question for Mr. Park Chan.
Do I ask too many questions? Sorry about that. When you perform scanning, also lower border of lingual side is very challenging. What is the position of the tongue of the patient? When scanner tip is touching the tongue, it is pushed to the opposite side. Do you make the patient lift the tongue? No, I don't force excessive motion. Is there any overextension issue? I don't think we have that. I don't think scanning is performed that well. The one who is wearing a mask. Please identify yourself first. My name is Chung Eun-hyung. I have a practice in Ilsan. Dr. Park, thank you for the wonderful lecture, digital denture fabrication, and it is worn by a patient when you observe it. Do you find that some things that need to be modified, reduction or adding can be necessary? The reduction can be made easily, but how do you add something on it? Patient information is accurate. If the information of a patient is accurate, digital denture do not need any modifications. That's given because there's no errors in analog. If there is any problem, the acquired information from my side is not correct, and after acquiring it, when denture is made, the patient information is provided again to review the case and make modifications. But I've done this many times, so information delivery is not challenging, and I don't encounter many cases where modifications are necessary. In the last case, sometimes something goes wrong completely. Then I use the copy denture for relining and rebasing. The analog techniques are not used. Good morning. My name is Jo Young-jim. I'm from Seoul Prigipun Dental Clinic. Thank you, Dr. Park, for the presentation. I want to check one thing. I am interested in digital dentures, but I have not done anything. So I wonder whether my thinking is correct. Overextension is something you want. That means alternating impression taking without pressure. When you scan with a scanner, the maximum extended scans is something you want to achieve. In actual design, the determination of the border is based on surgeon or lab technician's experience in the database. And then you make a determination as you accumulate experience in cases. And in your experience, you get the feedback from the patient that they use the dentures without difficulties. Is that the right approach? Yes, that's correct. Overextension is something I want. Maybe that's not a correct expression on my part. For the last 10 years, I performed scans, and sometimes they didn't work pretty well. That's why I made that remark. Even though I delivered the correct patient information, that should be realized on CAD, but compared to the advancement of CAD, the removable devices do not catch up with it, so they need to be complemented to make a more complete denture.
Do we have additional questions? Having some concerns about the Q&A, we have talked about making and taking, but we are in the process of making. For digital dentures, I think we need more research, and my concern is temporary denture, but the price is higher than the final. So it does have benefits, but if we can solve that economic side, the cost issue, then I think it will be very helpful. Professor Park, intraoral scanning could be used to make this easier. So he's trying to find that solution. So he is thinking much more than what we are thinking. And I think this requires time. Yes, and another question? Hello, I am from Puyo. I'm Iroon.
Regarding digital denture, my question is the existing denture is copied and used as an individual tray, and I copy the impression taking to make the denture, and when delivery, suction milling can be observed in the mandible due to lack of alveolar ridge. But after a week, that disappears. So what do you think that caused that phenomenon? So do you always experience that? Yes. When I fabricate digitally, it happens all the time. I don't really have that experience. A soft reliner is something you mentioned. The reliner material, Exadenture or VPS. Do you use the material? Do you still have the problem? I want to copy the functional impression. Do I need to use rubber? I sometimes do that for soft relining. I never take impressions, so that needs to be modified. I'm not saying that's definitely the cause of the issue, but it just dawned on me.
We have about 5 minutes left. Any questions for Dr. Ho? I want to hear some of your trade secret in diagnosis. You use the program, the digital program, and during surgery, you use one guide. And so when the patient comes in, it's a patient with bone defect, and you have to do bone grafting. And so what would be the sequence? So using what and doing what for bone graft, and you use mesh or not, or soft tissue, your own know-how, just a simple case procedure, please? Oh, that's such a broad question. Well, just a simple example. Well, the current trend these days is try to minimize the steps. So in the beginning of my practice, when there was no bone, there was bone regeneration and implant placement. But what we do nowadays is for hard or soft tissue management and implant placement, they are done at once. In the beginning, it was difficult to do it simultaneously. When we didn't have enough soft or hard tissue, then depending on that, the teeth had become confused. And so the position of the implant placement was not good, but as to the position of the implant placement, it has become much more accurate. So it's not dependent on the tissue management. So there has been a lot of change in the pattern of soft or hard tissue management. And so with the guided surgery, the surgery pattern has changed, and unnecessary surgery steps have been reduced. And the time it took, it used to be twice or three times, but now we can do it in just single take. And so since I have my own practice, I don't try to, I try to give easier time to my patients. I have to have my patients come more often. And so what is the simplest way to achieve our end goal? So depending on the end goal, there are steps that are essential. Of course, I will not skip them, but with the introduction of surgical guide, we were able to make the procedure very much simpler and streamlined. Thank you. You are using digital very well. So one final question, and we will wrap this up. Any final question from the floor? If you ask good questions, then you get to have free coffee coupons. Hello, I am from Yonsei University Doremi.
Dr. Park's lecture shows some bite taking, and you use existing denture, and it is printed and the bite is taken after extraction, still temporary is not available. How do you take the bite effectively? I showed you the copy denture. Actually, for that lecture, that is the picture I showed you. Actually, that is not available when patient comes. So the tray that I showed you was used, and putting a putty on top of it. Due to constraint time, I didn't talk about it, but with the closed lips, and you measure this length, tip of the nose and tip of chin, and the mouth is closed. Then with the CR taking would be completed. It requires experience on the part of dentists, and the patients often protrude the chin forward, so the anterior region is open. The scanners, according to the scanner's algorithm, the occlusion can be taken. And on the CAD, you need to compare the image to the patient mouth. Does that answer your question? This concludes the Q&A session. Before that, 2 good questioners are selected by me. Dr. Jo Jung-ho, who asked the first question, and online, the nickname Shu Shu Shu, gave us very good questions. So 2 speakers gave you very good lectures, and let's give them a big round of applause. So this concludes the first session. Thank you.
Thank you, Dr. Ho In-sik and Professor Park Chan. They have given us their lectures. And thank you, Professor Kwon Keung-nok, for your moderator role in session 1. And in the process of the lecture, the LED captions, the subtitles are on the screen. Osstem AI interpretation service is providing these upgraded services. Did it help you better understand the presentations? Yes, in the following lectures, we will continue to have the AI produced subtitles so that you can capture the points from the lectures. And so we are going to have the lucky draw for the coffee coupons. If you leave, you cannot confirm. We have 300 people who will be winning the coffee coupons. We will begin. Yes, we have 300 people who won the coffee coupon. The names are on the screen. Thank you and congratulations. Maybe it's difficult to check whether your names are here or not. So we will be sending you text messages. And please check the notice bulletin on the Osstem website. And we are also getting your surveys on the lectures. For the offline participants, we are going to send you text messages, and please click the link in your text message and complete the feedback. And we will be giving you chicken gifticons for 200 people. We're now going to take a break. And we have exhibition booth and refreshment to the right of the lecture hall. And we have poster sessions on the first and second floor. Please visit these booths, and we will be back at 10:50 with the next session. So please be back on time. We will begin at 10:50. Thank you.
ever experienced any difficulties because of implant fracture, screw loosening, or dislocation of abutment, the brand new KS system is designed to avoid potential issues for implant placement. With 1 to 2 paper drilling sequence, now it is ready to place implants. The KS comes with abutment holding system, which is located in the lower part. When the implant is connected to the abutment, it holds these two parts firmly without using a screw. At the moment of loading prosthesis, the KS system prevents dislocation of abutment, which may cause by gingival elasticity. Also, it is more convenient for clinicians because it does not require to see X-ray after loading. For conventional abutments, clinicians are required to select between mini platform and regular platform. However, KS abutment is compatible with all different diameter of implant, so the selection of prosthesis becomes a lot more easier for clinicians. The abutment screw of KS system is designed slimmer and the space is being used to reinforce the inner wall of the implant body. The KS system is aimed to reinforce abutments by thickening the walls. An implant wall as well. In addition, the depth of connection between implant and abutment is increased. As a result, structure of the KS system disperses masticatory pressure effectively. By the reinforced structure, the external force which may affect on the screw stays minimum and eventually minimizes the screw loosening. As of the diameter of 4.0 implant, the KS system secures the degree of strength at 4.5 with the increased depth of connection, reinforced walls of abutment, and thickened implant body. Find your key solution. Did you know pre-irrigation on implant may improve clinical prognosis? Osstem implant provides guidelines for how to pre-irrigate an implant before you placing it. Before placement, irrigate the implant with saline for 5 seconds to avoid intraoral bacterial infections. Irrigating the implant with saline covers the surface with water. This temporal water film covers the surface of implant. The bacterial attachment is decreased because the oral bacteria contacts the barrier and diluted by water. According to the research, the degree of bacteria attachment is decreased by 28% when the implant is pre-irrigated compared to not pre-irrigated one. It is applicable to not only SA implant but also CA and BA implant. Pre-irrigating an implant may reduce the attachment of oral bacteria. This procedure may be helpful to avoid bacterial infections. Unlike other implants, the soy implant is in wet condition. The surface of soy implant is already coated with the substance, so please use it as is. Although the amount of coated substance on the surface of implant may be reduced through pre-irrigation, it does not affect on the stability of implant. By pre-irrigating an implant before placement, the risk of oral bacteria infections may be reduced. It does not affect on the stability of implant. Increase the success rate of implantation. Introducing One Guide for Sophisticated Surgery, wide range of clinical indications and excellent convenience. One Guide is convenient to use. With an ultra-simple drilling technique, the implant can be placed at the plant site in only 3 drillings for shortened surgery time. One guide also offers high precision. The site, direction, and depth of implant can be precisely planned using digital method and used to manufacture a one-guide template. This allows the implant to be placed as planned. One-guide template holds the drill to help maintain a precise path even during high-speed drilling. The stopper is in contact with the top of one guide to enable precise control of drilling depth. One guide is particularly useful for surgery in the posterior region. In addition to the basic closed-type hole, open-type hole can be selected for designing. This function allows a drill entry through side and posterior teeth with insufficient vertical space. Open-type hole helps to secure additional vertical space. One guide can be used for various clinical purposes. One guide kit for cases of single to fully edentulous. One CAS kit for maxillary sinus lift surgery. One MS kit for the anterior region with narrow bone width. One 485 kit for short implant in mandible molar. These 4 dedicated kits are available for a wide range of clinical cases. Improve the convenience of digital implant surgery with one guide. It is simple and precise.
Introducing the One Guide Bone Anchor and Implant Anchor, which are used to fix implant guide. The One Guide Bone Anchor can be used in cases where it is difficult to anchor a template, such as completely edentulous cases or patients with insufficient remaining teeth. You can also place it vertically in the bone and anchor the template at the position you have planned. The One Guide Implant Anchor can be fastened to an implant already placed in the patient's mouth, which helps anchor the template much more easily. If you need to prevent the One Guide from shaking and secure it in position, try using the One Guide Bone Anchor and Implant Anchor. Introducing the One CAS kit, the Digital Sinus Surgery Kit. If you use the One CAS kit, you can digitally pre-plan the exact implant position and drill length required for the sinus surgery. Place the One Guide template first. Then, use the drills with rounded apex together with the stopper in order to perform safe drilling. You can also perform hydraulic lifting and bone grafting while the template is still in the mouth. Try the One CAS kit for safe and precise sinus surgery.
Introducing the Trios 4, an intraoral scanner which scans and digitally replicates the oral cavity in 3 dimensions. The Trios 4 is extremely precise and offers fast scanning. It automatically eliminates unnecessary areas such as lips and cheeks during the scanning using the AI scanning function. Even the novice users can scan quick and easy. The Trios 4 is an integrated wired and wireless scanner. It is easily used wirelessly at large dental clinics. If the battery runs out, clinicians can continue using the Trios 4 by plugging in its power cable. The Trios 4 helps diagnose dental caries with its fluorescence scanning function. Also, the clinicians can track changes with dental caries over time. The Trios 4 can record patients' occlusal movement. The patient-specific motion function allows clinicians to record occlusion according to the movement of the patient's temporomandibular joint. Experience the Trios 4. It can be used in a variety of treatments. Great unit chairs designed for dental treatment must be convenient for the clinicians to use, feel comfortable for the patient during treatment, and they should also be easy to clean and maintain. I would like to introduce K5. It's both a stylish and convenient unit chair. In case the backrest tilts downwards, the leg rest goes up. The tilting function prevents the patients from slipping down. It is convenient for the clinicians to carry out treatments and provide comfort for the patients to receive treatments. The K5 also has a wireless foot controller designed to offer an even more convenient treatment experience for the clinicians. Handpiece RPM can be easily adjusted by turning the foot pedal left and right, making treatment. The sterile water supply device suppresses formation of bacteria and biofilm in the water line of the unit chair. Always using clean water during treatment makes it much easier to reduce the risk of infections. Let's go over K5's key features again. The patient does not slip downwards thanks to the tilting function. When the backrest tilts downwards, the leg rest goes up. Second, the wireless foot controller makes treatment much more convenient for the clinician. Third, DWCS suppresses bacteria in water line to supply only clean water during treatment. Try the K5, a unit chair designed to add both convenience for the dentist and comfort for the patient. Introducing the upgraded T2 Plus with superior high-resolution imaging, ultra-high-speed scanning, and ultra-low radiation dose feature. The T2 Plus has a 0.05 mm voxel size, which results in superior high-resolution images. This enables a more accurate diagnosis compared to the T2. With a T2 Plus, patient waiting times can be reduced thanks to a faster scanning speeds compared to the T2. Images are acquired in just 30 seconds. T2 Plus low radiation mode allows for safer scanning with only 22% of the radiation dosage compared to that of the T2. The low radiation mode allows scans for children and pregnant women without any concerns. The T2 Plus offers various field of view sizes for facial imaging, implants, TMJ, endodontic procedures, and more. The T2 Plus allows for customized scanning based on the treatment. The T2 Plus includes convenient and easy-to-use 1-2 software, 1-3, and VSEP. Through consultation, treatment and implant planning will help increase patient acceptance rates. T2 Plus is available in 3 colors: white, blue, and red. You can choose the color that best matches the ambience of your clinic. Introducing the upgraded T2 Plus with clearer images, shorter scanning times, and lower radiation dose. Selecting the right bone material by comparing it to the patient's existing bone quality and conditions is crucial when expecting the satisfactory result from the GBR. Defects may occur on surgical sites such as the anterior maxillary sinus and ridge, which will require bone graft materials that facilitate the process of forming new bone osteogenesis while maintaining the bone volume. With that said, here is the Osstem Implants Xeograft EOS with phenomenal volume maintenance and osteogenesis. For bone graft materials, it is important to have a faster remodeling feature. Similar to the human bone, EOS particles have a cancellous pore structure. The structural property of EOS, when fully saturated with blood, significantly contributes to the process of new bone formation. The success of bone graft material must be verified with various clinic cases. EOS is designed to graft bone in a socket after the tooth extraction, and the treatment of peri-implant defects with guided bone regeneration.
EOS can be applied to the sinus lift to place the implant in a maxillary sinus and to augmenting and reconstruct of the alveolar bone. It can be used to treat and prevent various bone defects. A bone graft material must be easy to use in a variety of surgical situations. EOS collagen plug contains 10% of bovine type 1 collagen. It is specifically designed for post-extraction socket augmentation to maintain the volume and allows for better aesthetic and implant placement. The surgical can cut and reshape the plug to better fit the
Osstem Meeting Seoul 2025, the highlight of Osstem Meeting, live surgery. We have 2 live surgeries, one in the morning and the other in the afternoon. The first live surgery will be moderated by Dr. Kim Kyung-won from Osstem Implant Dental Education Research Institute. He graduated from Seoul National University College of Dentistry, residency in oral and maxillofacial surgery at SNU Hospital. Professor of OMS at Chungbuk National University College of Medicine, visiting professor at the University of Texas School of Dentistry, research professor at Rice University. OMS currently serves as the director of Osstem Implant Dental Research Institute and as director of Twin Dental Clinic. Please welcome him with a big hand. Hello, Dr. Kim. Hello. Yes. Just as was introduced, I am Kim Kyung-won, and I'm the director at Osstem Implant Dental Education Research Institute. We have started the Osstem meeting since 2004, and we always had the live surgery. So we have 20 years of history, and we have 2 meetings in Korea and another one in world meeting. So we continue to have live surgeries, and it was mostly oral surgeons or the surgeons. And in my memory serves me correctly, in 2008, during the world meeting in 2008 in Moscow, prosthodontist had done the live surgery, and there will be a discussion. So this is going to be the second live surgery by a prosthodontist, and Dr. Bae Jung-in will do live surgery, full arch implant therapy with Osstem digital solution from guided surgery to immediate DR provisional prosthesis. Let us first look at the pre-op treatment plan. Hello everyone, I am Dr. Bae Jung-in. It's an honor to lead the live surgery session at the Osstem meeting. I'd like to share with you what I focused on in preparing for live surgery. For your reference, I'm a prosthodontist, so what I'm going to show you is closer to basics of guided surgery rather than a fancy surgery. From 2017, I have personally designed and made one guide in my clinic and performed more than 4,500 surgery cases using tailor-made one guide. Based on my experience, I'll explore the potential of standardized workflows to reduce clinician-to-clinician variability. First, an efficient digital workflow for edentulous treatment and the prosthodontic information and insights gained from the top-down approach. I'll also share clinical insights obtained by personally designing the surgical guide and some practical tips and tools for enhancing accuracy. And lastly, simplified immediate full arch provisionalization using Osstem DR abutments. Patient profile is as follows: 66-year-old male, no specific systemic disease except for poor oral environment. He had wanted a denture with all his teeth pulled out, with the anterior bridge removed. The abutment teeth show malalignment and extensive caries. Except for number 17 and 33, there is considerable teeth mobility. Luckily, no deviation in the lower jaw movement, so the patient's centric occlusion was used as the reference for the treatment plan. Performing guided surgery for edentulous patients means the following three challenges. So in your standardized protocol, you need to counter these challenges. First, let's look at the teeth arrangement. Due to significant variations in the remaining teeth and alveolar bone, making intraoperative decisions on implant positioning is very difficult. For tooth arrangement, we first perform scaling. Although in edentulous treatment, tools for establishing the occlusal plane are the wax rim, if it can be supplemented or replaced with a facial scan. Photographs can also be integrated. Making use of Camper's plane and intertragal line is highly helpful for orienting the occlusal plane. Here is the completed tooth setup with big positional difference from the residual dentition. The tooth setup is brought to the implant studio to use as reference. Remaining teeth allows alignment of CT and oral scan, but due to possible teeth mobility, the marker was attached to the gingiva. And the maxillary view and the final treatment plan. Operator directly designing the surgical guide is the best way for making specific the diagnosis, treatment, and placement plans for now. The mandible will receive 6 implants and restored with 3 segmented bridges. Post-op photo of the mandible, full arch splinted screw-type provisional bridge was made in the maxilla, 6 implants in the 642, 246 positions, and restored with full arch splinted bridge. No additional procedures such as bone grafting appear necessary. Estimating the relative bone density, primary stability not expected to be an issue except for around 26, and over-drilling may even be indicated. The figure shows the fixed full arch bridges post-op. No matter how good the designed guide is, positioning is difficult in edentulous cases because the soft tissue is mobile, almost like a denture on flabby tissue. Depending on the ridge morphology, this varies, but guide positioning in the edentulous jaw is inherently uncertain. If the guide is misseated, all implants can be off, making the guided surgery worse than not using a guide at all. The common method is, as shown on the left, position the guide using the patient's occlusion. I prefer the method on the right, which is placing mini implants and using them as positioning reference. And this patient has residual dentition, so that can be used. First, in the mandible, we will extract only the retained root at number 34, then seat the guide on the remaining teeth and place the initial 4 implants. Take the guide out, extract 2 more teeth, and use the 2 remaining teeth and pre-planted implants for anchor for guide positioning. And for the maxilla as well, we plan a flapless procedure using 2 guides, pre and post extraction each. We have addressed the 3 prerequisites so far. However, in actual guided surgery, unexpecteds can come up and the implants may deviate from their planned positions. Guided surgery is essentially a blind technique. Since the operator does not have direct visibility under the guide or into the tunnel, he must mobilize all senses during surgery to read the signs. The warning signs detected are important clues, indicating whether the surgery is going well. And now let me show you the warning signs to watch out for according to the surgery sequence. First, guide positioning. When the guide is tooth-borne, confirm it is fully seated. Check for gaps. In edentulous cases, verify whether positioning reference is appropriate. If none, at least confirm even tissue contact. Mispositioning of the guide will invalidate subsequent steps. Second and third, assess drilling resistance. If it's too high, see if it is in the wrong direction. And if that is not the case, the guide hole may be too tight or there may be debris. Or it's just that the bone density is high. Too much force may fracture the guide or the drill. And so this could be very risky. Incremental drilling is recommended for high bone density. For example, for a 5x10 implant, do not jump straight to the diameter 3.5 at 10 millimeters after the initial drill. Incrementally drill at 3.5 in sequence, 6, 7, 8.5, and 10 millimeters for better cutting efficiency. You may suspect drill deviation into cortical bone if resistance is excessive and implant's primary stability is over-tight. To the contrary, if the resistance is minimal, the bone density may be low, or the drill may be slipping along the sloped bone, extraction socket, or sharp ridge. Fourth, drill or guide deviation during drilling. If there is lateral movement or if the guide itself moves, then it may be because of positioning error or loose guide hole. Comparing the two conditions, much more accurate surgery is possible on the right. When the edentulous span is long and when there is lack of support, retention, stability, and guide rigidity, then the guide may move or bend. For large tissue support, design the guide to maximize tooth coverage and reinforce rigidity as seen on the right. Differences in bone density around the plant site may cause the drill to wobble. Repeated short strokes with much irrigation is recommended. Deeper installation lowers sleeve contact in one guide, reducing barrel and guide plane contact. Each shows guides with low and high drill deviation, and there is higher risk of drill deviation. To prevent slipping along the sloped bone or extraction socket, you need to elevate the sleeve. In our plan, this applies to numbers 12 and 22. From the default sleeve on the left, it was elevated to 1.5 millimeters. You now need to use an 11.5 millimeter drill and place the implant 1.5 millimeter deeper to match the initial axis. If the driver cannot be disengaged easily after final placement, it's a sign of implant misalignment. You may need to back out and perform additional drilling. To sum up, since guided surgery is a blind technique, you need to be mindful of the warning signs and beware and respond accordingly in the OP room. These are the new tools I will be using today. First, new initial drill. It's a one-piece drill with the flattening drill and has the lance drill tip. And second is the new side cut drill. It's Lindemann type and has good side cutting performance, thus reducing drill deviation. This is the drilling sequence. By replacing the first 4 drills with 2, I can save time. And thanks to the side cut drill, this will help with the accuracy. This was it for the pre-op lecture. I will discuss DR abutment in the OP room and again in the afternoon. Thank you. Thank you for the pre-op lecture. Yes, Dr. Bae Jung-in, are you ready? Hello, I am Bae Jung-in. Yes, I will begin. For this surgery, 2 guides have been prepared, and my right hand is holding the guide that is to be used for the surgery. As for this guide, it's not made in Osstem Center, but it was made in our clinic. And we check for any issue and the initial drill, whether it fits. So we have to check whether it's a good fit. And to have accuracy, I wanted to go for a tight fit, and we don't see it wobble. And what we need to check next is whether the guide has a good fit in the patient's mouth. And since we have teeth, when we put this on, the gap, the teeth, tilt your head a bit, thank you. and we don't see any gaps, and we see that it's a good fit. And another tip that I want to show you is looking at this guide. It's the maxilla. It does not cover the palatal, and the palatal will swell after anesthesia. So I opened the palatal, and this is how I made the guide. And we will begin the surgery. Number 16 is where we will begin. And for guided surgery, if you want to complete it fast, you could drill everything and then you could place all at once. But if you want to be more cautious, you should drill and place one by one. And I am going to take the latter approach. Let's see the report. So this is the total report on the top. After the guide is designed, the PDF file opens, and the employees have this on screen, and they prepare what implant to be used. And go to number 16, please. Thank you. So we will use 5 by 8.5, and the drilling sequence will be streamlined. And looking at the report, we can see the bone, and it's closer to flat, so we could use the short drill sequence, nothing special. But looking at the mandible, we see that the bone density is low, so we will under drill. And now the surgery screen. There will be a lot of water. Please open the mouth wide. First drill, the new initial drill. Flattening and initial integrated into one. We will begin. So we will check. So flattening together with the initial, and it's the lance drill tip. And it has been approved, and this drill will be released as an optional tool by the end of the year. And next is the side cut drill, which is also a new drill. And the initial drill will determine the path. So the side cut drill that has good side cutting performance, that if that is used, it will be helpful. And it's 9.5 millimeters, so it will not go in full depth. And so we could replace it with the earlier drills, and the approval process has also been finished. And 3.5 by 8.5, the working distance, and we irrigate before the drilling. You don't drill just at once, do short, frequent strokes. And irrigate after the drilling is done also. And we do 4.5 by 8.5. So pumping action is preferred, and this will also help with irrigation. We could use additionally 5 by 8.5, but because of low bone density, we under-drilled. And the implant is going in. Luckily, we will have good initial stability. You sometimes have to worry about whether you need to do additional drilling. We will drill some more. And there you could lose the stability if you do full drilling. So I drill with 5 by 7.0, one notch lower. So the final drill, because the bone quality is suspicious, we have a shorter drill for the final drill. I don't know if you can hear, but in drilling, the drilling mode is spoken by the employee. So it's to prevent any issues. So it's a promise within the surgery room. So 70 to 80% placement, then it will prevent the device from being stuck. So with the implant driver, you get the final position. And the depth is, it's in full length. And the drill is disengaged without much resistance, so we can see it's been done well. So number 16 done well. And let's look at the report for the next one. Number 22, there's some things to watch out for. It's on a slope, so there's possibility of drill deviation. Could you scroll down? And it was mentioned in the pre-op, 3.5 by 10 is the plan, but if that is the case, then could we go up to number 22? The sleeve may lower, then it could have the drill deviate. So APEC, we could design the longer implant, and the sleeve will become much longer than that, and the guiding plane will become longer, and we could have better and more accurate drilling. 3.5 to 10 placements, but drilling 11.5, and it will be deeper than the guide, and flattening drill will be used separately, different from number 16. And back to the surgery screen. Yes, number 22, let me begin drilling. This is a flattening drill. When using the initial drill, there was possibility of deviation, and we wanted to reduce that. So I do the full drilling, and then the initial drilling. So this is the initial drill. And side cut drill. Yes, it used to be the pass drill, and we made improvements to come up with this side cut drill. And like the pass drill, side cut drill, you first use the short drill. Working length is 11.5, so I will use this drill. Number 12, offset was 10.5, and in order to have longer sleeve length, it was longer by 1.5. Yes, it's 22, not 12. Thank you. Yes, 11.5 drill. And the bone density seems very high, and with the placement, we may have to over drill. But we will place the implant for now, and this implant is 3.5 by 10. The drill was 3.5 by 11, but the implant was 3.5 by 10. And as was expected, bone density is very good, so it's not going in as much, so we need to do additional drilling. Dr. Bae, is checking the bone quality at the tip of his fingers, it seems. So yes, surgical report and the drilling sense, and there's this map. So I refer to that. And for additional drilling, I use 4x10, so it's shorter, not using the 11. Yes, it's going to be drilled to 8.5 from implant. And I think it would be good to drill some more. In the afternoon, it's going to come up during the discussion, and getting the Hounsfield accurately from cone beam CT, that will not be accurate. So he's using all of his senses to get the bone density.
Is that a compliment? Of course it is. Prosthodontist is performing the surgery pretty well. So it looks like it reached the placement depth, but it is 1.5 millimeter deeper, and this irrigation hole is 2.5 millimeters. So Dr. Bae designed all of that so he can control that accurately. So it is placed deeper than the guide, and it is inserted pretty well. Report of number 24, and number 26. If you look at them together, there's a no-sloped bone, so short drilling sequence will be used. But for number 26, around the implants, very low bone density is observed. So two-step under drilling is to be performed, and I'm going to place implants in 24 and 26. So I'm inserting the implant in 24. A flattening drill will not be used separately, so the improved initial drill is to be used. The guide is well designed, so you can even do surgery with your left hand. Dr. Bae, I didn't know that you can use both hands. The newly designed initial drill, it is lens drill, and at the end there is a blade, so bone cutting is facilitated. I'm not using my left hand, but I'm trusting the guide. That's why I can use my left hand. The side cut is used as the first drill. As I said before, the first path is very important. So if the guide doesn't fit, if I use my left hand, the guide would be shaky, but there's no mobility at all in the guide, so I can use my left hand to do the surgery. Number 24, 4x10 is to be inserted. In number 24 site, the bone looks hard, so I'm going to over drill intentionally. So do you drill up to 4.5? 4.5 by 8.5 on one step under drilling. You originally planned 4x10, and now you are drilling 4.5 by 8.5. So it is drilled on 4x10, and now I'm going to do 4.5 by 8.5. So based on your experience, the drill is selected in the afternoon during the discussion. The cone beam city will be discussed in terms of bone quality, and surgeons will discuss on that matter in the afternoon. So 4x10 implant is being inserted. As you can see, it is inserted 1 millimeter less, and I'm going to tighten it by hand. Over drilling was done beforehand, so it was appropriate to do so. It depends on surgeons, but by engine, I drill 80%, and that can prevent the instrument to stuck in the area. I'm going to insert at number 26, which has the lowest bone density. So two-step under drilling is to be done. Please open your mouth. Drilling in 26. So at the beginning, a side cut is used. So the side cut was developed for the interior or for the slope, and Dr. Bay is using it properly. If bone density, if the bone density is hard, then it can make some deviation, but it works fine here. For number 26, please give me an implant. 5 by 8.5 implant is planned. Two-step under drilling is planned. So I'm going to drill a little more. Immediate prosthesis to be fabricated, so I need to secure the stability. That's why I'm careful here. A prosthodontist is performing the surgery really comfortably, unlike other prosthodontists. Please open your mouth. I'm not looking down on the prosthodontist. He is performing surgery really comfortably. I envy him. During the live surgery, you get really nervous. .5 millimeter under drilled, and I'm going to tighten it. A bicortical fixation is achieved providing sufficient stability. Initial stability looks sufficient, and we worried about the bone quality at the beginning. So the first guide using placement is completed. The second guide is to be used for the placement. These two teeth will be extracted, number 12 and 13. Bone quality and cone beam CT will be discussed in the afternoon. Dr. Ho is here, and CBCT bone quality is going to be discussed, and he's going to make a good remarks on that. Prosthodontist is really good in extracting teeth. So after extraction, the second guide is inserted. Now it is fixed pretty well, but still shaking a little bit, and implant anchors are going to be used. Regular anchor, please. So using the placed implants, the vertical anchor is using the placed implants. And over the placed implants, vertically, the surgical stent is stabilized. So stabilizing the stent is very important in guided surgery. So now they are tightly put in. For number 12, it is an extraction socket, and sleeve 1.5 is raised, and the flattening drill is to be used first. Oral surgeons do not use flattening drill first. The tissue punch is done first, usually. Side cut drill is next. Next, 10 millimeter will be placed, and I'm going to use 11.5 millimeter drill. As you explained before, number 12 and 22, intentionally 1.5 millimeter deeper is what is planned. Here, the bone is not hard, so I'm not going to do over drilling. 3.5 by 10 implant, please. As you can see, during surgery, the tactile sensation for bone quality is felt. Maybe some more drilling. What I want to emphasize is that you have to sufficient irrigation, and you have to divide the drilling into multiple times. .5 millimeter deeper design. Sleeve is raised by 1.5, so it is placed a bit deeper. So when it is the place deeper, sometimes entrapment can occur, but it comes out pretty easily now. And the last implant for number 14. I don't need to look at the report. So newly designed initial drill is used. He's really comfortable in performing the surgery. It doesn't require any further explanation from me. Side cut drill is used for the first time here. For number 14. The bone is quite hard here. 4 by 10 is to be inserted. Open your mouth, please. Here, 4 by 10 implant is planned. So over drilling by one step, 4.5 by 8.5. So I believe a very good stability can be achieved. You plan 4 by 10, but up to 4.5 by 8.5. The size is bigger, but the length is shortened. So it is under drilled by about 1 millimeter, and the rest I'm going to use hand tightening. All implants are placed. 6 implants are placed within a short period of time. Oh, that's wonderful. Surprisingly, you are performing this surgery very comfortably. So I will invite many prosthodontists to do the live surgery, including Dr. Kwon. Surgery is finished, and now a prosthetic process. Implant placement is completed. Please give a big round of applause. That was a pretty good job. In the anterior region, DR 4.0 by 4. 4.0 by 4. Osstem made this cementless DR system, and in the afternoon, the prosthetics will be shown and explained by Dr. Bae. Now, DR abutment is being connected.
And now 5.0. Torque wrench. 6 DR abutments are being connected with hand. And 36 DR abutments. 30 newtons, not 36, 30 newtons. Driver. Abutment. Abutment is non-X. Was it 4.5? When surgeons do the surgery, we hand this over to the prosthodontists, but Dr. Bae is doing all this from surgery and to this stage. And we make sure that the connection is good. This is 4.5, right? And the next one is 4.5. Could we check for 4.0? And now hand me 5.0. And before we insert the last one, 5.5, let's do the ISQ. Give me 5.0 and ISQ. As for the DR abutments, they're convenient because when they're connected, you could measure the ISQ. The score will be lower, but it will be lower by about 10 points. And give me the smart kit. Yes. With the DR abutments attached, ISQ measurement is being taken. ISQ 66. Let's take another measurement. So it's lower by about 10, did you say? Yes. It comes out 66, so it will be in the ladder of 70. At the implant level, that measurement would be the case. So from his experience, he has this know-how. So 4.0 abutment, how many millimeters is this? Yes, this is connected. If the hex is not correct, then I will do it again. And we had left the two extractions. We cannot get the bites, and when we had the bites, so we will do the scanning first and then do the extraction. Can we use the scanner? Yes, we'll just do the maxilla. We will just be showing you the maxilla. Could you show that? Yes, temporal. For the temporary prosthesis, he's doing the scanning. There was not much bleeding. Very good environment for scanning. And as you can see here, I am using a wireless scanner. And let's look at the screen in the surgery room. You could just look at the screen without the card because this is wireless. Could we change to black and white? Open wider, please. So we should scan in all the corners. Why did you switch to black and white? And evaluating the scan, black and white is much more convenient because if you have color, you don't know, if this is discoloration or if there's a gap. But with black and white, you can tell if there are any gaps. If you use wireless, you will never go back to a wired scanner. It's that much convenient. We will wrap up in about 4 minutes. Okay. Yes, the scanning is almost complete. I don't need to show the mandibular scan. Yes, DR provisional prosthesis. To do that, the maxilla scan was done, and the rest of the teeth will be extracted and complete the surgery. Does this hurt? It's okay, right? Yes, complete. Yes, a big round of applause for Dr. Bae. It was very stable. And we will go ahead with the Q&A. First,
Please give Dr. Bae a big round of applause who performed the surgery. So we'll take questions from the floor. Let's wait for Dr. Bae to arrive. And please raise your hand if you want to ask questions. And microphone will be delivered. Wait a minute, please. Dr. Bae is connected. My name is Kim Myung-nae. I majored in oral surgery. That was a good surgery. A DR KS3 system. I understand that it is used for single cases. And are you going to do multi-unit? The provisional plan is to connect all implants, and one piece of splinted bridge will be made. Individually, DR abutments are not really used for single cases, and it has advantages when it is used in multiple cases. I just use them in single cases, not for multiple cases. The company says multi-unit doesn't have high accuracy because of the sensitivity to coupling. It's not the case. So you have a similar experience other than this. For single cases, my routine is that the general cement type abutments are used. For multiple, Osstem DR and multi-unit abutments are used. For single cases, the DR abutments are solid abutments. So if you use it in single cases, abutment is connected to so joint stability in the joint area is questionable. A link structure is in hex anti-rotation. In single cases, maybe this is contrary to what the research center says. It can have some rotation problems. So single cases need to be studied more. As the Osstem tissue level implants have the form similar to cases using DR abutments. I'm surprised. DR single cases have never failed in any such cases. The access hole at the top, filling the access hole is challenging, but I've never thought about multi-units for DR. In your surgery, DR abutments are used 2 or 3 millimeter height. In your case, after extraction socket, if you use it, the soft tissue and the fixture levels have some gaps. So you need to make a delicate decision whether you use a 2 millimeters or 3 millimeter height. 2 or 3 millimeters. So how do you determine that? What I determine is in the anterior region, 4.0 height is used. No, diameter. GH, gingiva height. I designed the guide, so I know I estimate the height. In the premolar area, the diameter 4.5 is used. 4.0 diameter for the anterior region, because I use a DR in the premolar area, 4.5, and in molar area, 5.0. And the GH is controlled depending on the placement depth. Thank you for the answer. Good question and good answer. Do you have any other questions? So please raise your hand.
Yes, Dr. Jang Dong-won. Thank you, Dr. Bae. I knew you were very good, but you were so calm and stable. I was very much impressed. And this is a question for Dr. Bae as well as the Osstem implant. Dr. Bae, you were very good. So in drilling, so you were able to identify bone density as if you were like AI. So I should use short drill or long drill, and you're able to make that decision. But that's very subjective. perspective. So looking at the surgery, other surgeons may come across different challenges. So, so you have done 4,500 surgeries, and including Dr. Bae, those people who have used the guided surgery, maybe you could you have your own protocol. So under this bone density, under drill or over drill. So you must have your own know-how, and maybe you could create a protocol for the other surgeons to reference. So it was a question / recommendation or suggestion. As for stability, as for the guided surgery, through the guide, you have the guide that stands in the middle. So compared to just hand drilling, you lose some of your tactile, but D1, D2, D3, D4 bone quality and the CBCT, there is not direct correlation, but bone quality, the closer to black, the bone density is lower. So you may have to do under drilling. You can never go back when you over drill, but if you under drill, you can always go back. So you start with under drilling to be on the safe side, and if the implant does not go in as deep, then you may progress with further drilling. But with full drilling, you may not get the stability. So one shorter drill. So that's the kind of know-how, and you can make these decisions in the operating room. And as was mentioned by the Professor Jang Dong-won, from the surgeon's perspective, a tactile sensation was used to place and take out and drill in different depths by Dr. Bae, and this requires a lot of know-how, and maybe we can discuss it during the discussion session. I think different doctors will have different opinions, and we'll take the next question from the floor.
Dr. Park. My name is Min Seok. I majored in images. A question regarding surgery in the maxillary sinuses. Bilateral sinuses have some inflammation, and you must have detected it. So do you use medication for the patient? Clean sinuses versus sinusitis patients. When you plan the treatment, you invaded into the sinus slightly. So what happened? So it's my personal preference. Bone graft. If you have bone graft in plan, you need to consult ENT doctor, and you need to make the patient take ENT medication before surgery. In this patient, the bone graft is not to be done, and bicortical fixation is to be achieved. So treatment in the sinuses was not made in advance. And if I may add, Dr. Ho, as Dr. Ho said, in the radiology, because of thickening, the inflammation is observed, but not an issue if you do not do bone graft. The sinus cavity can be penetrated into, according to some, but the implant is to be placed 2 millimeters below the sinus. If you protrude 30 millimeters or more, the sinus membrane would be exposed in the sinus, and calculus would be accumulated. As Dr. Bae said, the bicortical penetration, slight penetration into the membrane is made, so you do not need to be worried about the sinuses. Poster panorama, can you put that up on the screen? So as planned, the implants are very properly placed. Maybe we can take one more question from the floor. The abutments are all connected without interference with the bone, and healing caps are inserted, serving as healing caps. Any other questions? Any online questions?
As you can see, because of the nickname Nelson 21, what Newton for engine torque and hand wrench? What Newton? For engine, it was 40 Newton. So if it's within 1 millimeter, then I tighten with hand, and if you need to do more, then I drill. Thank you. And maybe we could take one more question from the floor. If not, then, from a surgeon's perspective, this was such a perfect surgery and it was very stable. So we hope to invite more prosthodontists to the live surgery sessions. And let's give Dr. Bae another round of applause. And so lastly, we will select the best question. He was a surgeon, but he is interested in prosthetics. Dr. Kim Myung-rae, thank you for the question about DR abutment. And Professor Chang Dong-won, thank you for your excellent questions. With this, we will end the morning live surgery session. Thank you very much. Thank you. Thank you, Dr. Bae, for your live surgery, and thank you, Dr. Kim Kyung-won, for serving as the moderator. This concludes the second session. And after the fourth session is over, we will invite Dr. Bae once again to look at the provisional prosthesis delivery. It is now 11:50, and 1 hour later, we will begin. We have lunch until then. Please enjoy your lunch and please visit booths, exhibitions, and events throughout the venue. And on floor 3 from 2 p.m., we will have seminars for implant and clinics and labs. Please be with us until the end of the afternoon session. And after lunch break, we will have a coffee coupon event. So please join us, and we will see you back here at 12:50. Thank you.
TS Multi-TI base enables digital implant restorations for edentulous patients. Using the TI base with a multi-abutment and multi-angled abutment enables creating a single unit prosthesis even in an edentulous case. Using a multi-scan body, the surgeon can select from a dedicated library to 2 digital scanning options, TI base, long or short. To ensure a proper fit and eliminate any possible errors, the prosthesis must be seated in the mouth before being cemented onto the TI base. Try our simple and accurate TS Multi-TI base.
Introducing One-Fit Abutment, custom-designed abutment by Osstem Implant. One-Fit Abutment has the basic titanium abutment as well as gold-color titanium-coated abutment for production of aesthetic zirconia and ceramic prosthesis. Manufacturing request is simple and convenient with 3 options of impression body, intraoral scan, and design file through an online order system. The product offers various design options for customization based on patient oral cavity and implant placement conditions. Try One-Fit Abutment, custom-designed abutment by Osstem Implant.
Introducing the 1485 kit, the implant surgery kit for mandibular posterior region. The 1485 kit is used for implant surgery in the mandibular posterior region with vertical bone resorption. The implant specification and position can be elaborated with digital planning. The surgeon can prevent damage to the inferior alveolar nerve even when the residual bone height is low, in case the surgeon places a one-guide template and performs drilling with the 1485 kit's round design drills. Also, the 1485 kit helps you to place from 4mm to 8.5mm short implants at proper depth and avoid any damage on inferior alveolar nerve. Try the 1485 kit when you need to perform a surgery in a mandibular posterior region. Introducing the Scan Healing Abutment, which helps you to take implant impressions without removing the healing abutment. You can use the dedicated carrier to fasten the Scan Healing Abutment in the correct hex direction more conveniently. The Scan Healing Abutment is available in different lengths. You can choose the right abutment for each patient's implant surgery case. When using a CAD program, the unique shape of its upper surface helps you identify the abutment's length. You can also create custom abutments with our official library. If your clinic does not have an oral scanner, or if you are having issues with scanning, you can take a rubber impression as an alternative. Experience easy implant impression taking with the Scan Healing Abutment, which combines the functions of a healing abutment and a scan body.
임플란트 유명한 게 좋을까?
뭐가 달라도 다르겠죠.
임플란트 세계적인 게 좋을까?
뭐가 달라도 다르겠죠.
치과 의사에게 사랑받는 게 좋을까?
뭐가 달라도 다르겠죠. 오스템 임플란트.
Did you all enjoy your lunch? Yes, the lunch boxes were quite wonderful. We had like 4 kinds of meats for side dishes. So on a full stomach, let us not fall asleep, but with full energy, because if we use our brain, we can burn up the calories. Let's participate in the afternoon session in full earnest. Osstem Meeting 2025 Seoul. I say my greetings for the afternoon session, and there are many events for offline lucky draws and souvenirs. After the event is over, we are going to have a lucky draw, so please stay with us until the end and be the prize winner. Samsung Galaxy Z Fold 7 Wapic Water Flosser and Osstem Family Oral Care Kit. We have many presents, and once again, we have had Dental TV, and now it has been changed to Osstem TV. And the existing dental members, you don't need to sign up. You could continue to use the same ID and access Osstem TV. In the lecture hall, we are having all the lectures and live surgery. And on the 3rd floor, in the seminar room, we have the lectures, and they're being streamed live through Osstem TV. And we ask for your support. And now for the online events. For the online participants who are logged on to Osstem TV, we are going to give out coffee coupons and dessert set coupons to a total of 600 participants. Please don't miss the pop-ups on your Osstem TV. And for those of you who stay with us until the end, the online participants, you get a chance to win Samsung Galaxy Tab S10 and Beautis White Light Dental Curing Light, including 2 gels, and Osstem Family Oral Care Kit. And for those of you who are participating in the events, for the online participants, you have to log in to Osstem TV to be eligible to win the prizes. Do not forget that, and please sign up and log in. And for those of you mobile viewers, please use it in a portrait mode, not landscape, so that you can have a chance to win in these pop-up events. And after the lectures, we will be having the Q&As, and we will be selecting best questioners. So we will be giving out the Wapic handy oral flossers for 10 of you, and we will contact the online best questioners. So please post your questions online. And please check the second event pop-up on your screen. Don't miss it and get a chance to win your coffee and dessert coupons. And the results will be announced after the 3rd session is over, and you will also get the coupon link through your SMS text message. And now we will begin the afternoon session. And Chairman Choi Kyu-ok of Osstem Implant, our dental clinic, together with our patients, Osstem, he's going to give us a greeting. So please give him a warm round of applause. Good afternoon, everyone. Did you all enjoy your lunch? Yes, so, it's that deadly hour, but I have to keep you awake, and I'm a bit concerned myself. And I've been doing TV commercials for some years, and the reason why I did that was back then at the dental clinics, what they said was foreign product, how much, and Korean product, how much. So the prices were different. No matter how good the Osstem products were, they were just Korean made, and Korean made products were treated as similar. And Osstem users said, we need a differentiating factor. Please differentiate you. And Osstem, what you should not be treated this way. So what I made was the TV commercials and the effect. So Osstem and non-Osstem for implants, and Osstem and foreign products. So I wanted people to remember Osstem instead of Korean made. So I've been doing TV commercials, and now everyone remembers Osstem. But in the middle, there were some challenging times because they said, the ad should be suspended. But then there were people that were saying you should not suspend the commercials. And so we're everywhere and everyone is accepting this. And this is about not the Osstem product, but to the dental clinics and the patients, how to make the dental clinics more approachable. So this is what I came up with. So to the patient, they informed the dental clinics that are open so that they can get treatment, and they are informed about the dental clinics that have the departments where they can get treatment, and the job applicants are informed of which dental clinics are hiring, and common sense knowledge is provided to the patients so that it can contribute to oral health. And this is the medium. One is osstem.com. You could log in to your PC, or there is an app. So we have web-based and app. So from the patient's perspective, they can know when dental clinics are available and open, and they know which dental clinics provide the services that they need. And they can have 24/7 communication, and there won't be any time zone difference. And so foreigners can also use the service, and people can find out which dental clinics are hiring. And this will be a platform to disseminate common sense knowledge. Let's say it's late in the evening, around 9 p.m., and you want to visit a dental clinic. And so it was very difficult to know. And let's say it was a Sunday like today, and you want to find out which dental clinic is open. And it was difficult to find that information. So at a late hour, you cannot call up, or you could not Google it, or you could go in different websites for dental clinics, but it was difficult to get into contact. But now with Osstem platform, we have a single point of contact. And so what project or what business we want to do is this Osstem platform business, and this will enable all the services that I just mentioned. So you log into osstem.com on your PC. Osstem.com is the website URL, but if you log into osstem.com, then the landing page will be this map. So which dental clinic is open at this hour. So even if it's 9 or 10 p.m. or if it's at the weekend, you could find out which dental clinics are open. And the clinics that are not open will be grayed out. And so, you could zoom in or zoom out. And if the dental clinic is far away, since it can track the IP address, if it's far from where you live, then the map will automatically adjust the scale so that the clinic that is open will be visible on your screen. And you could set the time to tomorrow or even the next weekend. And, you have to call up the clinic in advance to check whether there will be open or not. But if you log into osstem.com, then, you will see which clinics are open, but then you could input the designated time and date, and then this will show which clinic will be open. So it's the Korean Thanksgiving in a few days, and so you want to get treatment right before, and you want to select the hospital which provides treatment at a certain hour, and that will show up on the screen, and then you can call that hospital up to get an appointment. And you could adjust the scale, and you could zoom out so that you can see more clinics on the map. And let's say you want to take out your wisdom tooth, and so you're usually referred to a bigger hospital, and then you Google it up and you call it up, and then the hospital will tell you go to a bigger hospital. So this is the common route. But if you come into osstem.com and say Google and search for wisdom tooth, then all these clinics will be shown where wisdom tooth extraction can be done, or you have other conditions, like you get these sounds from your bite or your chin hurts, so you put in your symptoms. So you could put in the name of the department, or you could type in your symptoms, then this platform will find the right clinic for you. Let's say you cannot open your mouth properly, then certain clinic will show up which is able to treat that condition for you. And what about booking? You have to make the appointment at the hospital, or you have to call up the hospital. But from now on, through Osstem.com, you could select a certain clinic, and you could click it with a mouse and click appointment or booking, and then you could send a chat through this pop-up. You had to have this made through a phone call, but now anytime you could leave this text, and the receptionist will be able to see it the next morning they come to work. Or there could be a designated person or a doctor who's responsible, and they will be able to get back to you and set up the appointment. And so the booking is made. And another headache for dental clinics is hiring. And so from the staff's perspective, if you are searching for a job, you go to a job site. It could be dentaljob.co.kr, or sometimes even there are job openings in flea market sites, but you could just now come into osstem.com and you press hiring, and then the clinics that are hiring will be shown. Then you can submit your application to those dental clinics that are hiring. And there will be some fields that you fill out, and so you could easily apply for a job. So from the patient's perspective, or a person who's looking for a job, they can go in osstem.com and submit their applications. And dental common sense to get the patient's dental IQ. Well, we have the TV. And we have the TV for the general population. So we upload the content in the video format to provide, dental common sense. Osstem could upload it directly, or the dentists could upload their content as well. So this is going to be the look and feel of Osstem platform. So that was web-based. And also you could download the app on your phone. For patients and for clinicians, they could use this. So you could download it on your Android phone or iPhone, and you could install the app on your phone. And with the installation, you could get this Osstem icon with our mascot. And if you press this, then you can see the dental clinics that are open right now, and you could find out which hospitals will be open at a certain date and a certain time. And if you input that information, you could see that hospital information, and which hospitals will be open on weekends at a certain hour. And you could enter in your symptoms, or you could enter in the name of the departments and show which hospitals could treat your symptoms, and you could do the booking. Rather, you're supposed to send your text messages, and then the dental clinic will check that, and if need be, there will be a phone call made. So in one click, you could make the appointment, and the confirmation message will come to you. And there are different text messages. Regularly, you could have these interactive messages, but if you get a confirmation message, then the format is set. That's given by the dental clinic, and once the booking is made, you're alerted. And the dental clinic could send you videos or images and texts to the patient. And so this could be an example of, what to do after they get an implant surgery, and the dental common sense to provide more knowledge. So this is similar to what I showed you earlier in the web-based platform, and which clinics are hiring. It's the same as web-based. You could select the dental clinic, and you could submit your application documents. So this is the patient's Osstem platform to find the dental clinic, make the booking, and to be provided with the dental common sense. So this is a very convenient function for the patient. And the Osstem platform for the clinicians, the dentists, so they alert the patients about their office hours and tell them which services are provided. And, there could be also multilingual support. Maybe their clinics serve patients speaking either English, French, Chinese, or other foreign languages. So if you put in your respective languages, then they can tell you that, they can be helped in their language. And they also put out hiring information and also their dental information. And this is in the format of a mini home or a mini website. And so we are going to produce this template for you. So with single click or like double clicks, you can enable this. Let's say the patient sends a text message to the dental clinic, then you can receive it at the hospital end, and then you could reply, that the booking has been made. It will be in the SMS, and then in the appointment window, this will be confirmed. And so this will be in a different text format, and this will be managed in a separate mode. And, you send out these alerts to the patient, and this is a promise card. And so you manage the patient's visits. And so, this is an official message sent out to the patient, and there will be alerts reminding the patient about, when the next appointment is due. So, these will be the types of messages to be sent. And pathfinding. So if you tell the patient, the different routes through which they can visit the clinic. And also, you could create this e-health questionnaire so that the patient could fill it out before they come to the appointment. And the e-health questionnaires will be managed separately in the clinic systems. And QR could be used to make the registration when the patient comes to the clinic. And so the patient could use their mobile phone to, register. And these will be rolled out incrementally in the dental clinic. If there is information that can be revealed, then the patient will be given this information about their oral conditions and also be informed about the next treatment schedule. And so this is the, greetings given out on holidays, on birthdays. And so difference is this is all free. This is web-based. So the Kakao Talk, they used to be paid services, but, these are all free messages that can be given, so you can save that much cost. And there is much more interactive communication, which has been made more convenient. And you could also get documents from the job applicants, and you could have this interactive dialogue with a job applicant who's interested in your clinic. So you could get the resume from that job applicant. And so you could get their CVs through the system. And this is, you could suggest an interview to that job applicant, and you could, tell them the confirmation message that they got in. So what help would this Osstem platform be to the dental clinics? The dental clinics that are open in the evenings, they will benefit a lot. Even if you're open at night, not all patients know that they are open. And so you provide service during the night or during the holidays. So you're now more visible. And if your hours are in the mini homepage, then the office hours will be disclosed. So, the patients who want to come to your dental clinic, they can come on the day or a few days later when you're open. And so you could mark all the treatment appointments, and you could alert the patients, and you could also provide information about what type of services you provide and the departments that are in your clinic. And you could have, different symptoms that are entered by the patients. So you could have you could have the patients look you up through either entering their symptoms or the department that they're interested in. And you could provide more services to the foreign patients by telling them in which languages you'll be able to offer your services. So that there will be more multilingual services that will be more promoted. And so once again, which dental clinics are hiring, and you will be able to select excellent talents. And if you want to provide some, knowledge about the dental health, we have Osstem TV. So people come to our studio to actually shoot a video, but you could upload your own self-generated videos on this platform. So how to use this platform at the dental clinic's end? You have to create your own mini homepages. And so we have this upgraded version, and you click on the mini home icon and you could create this homepage. And this is roughly what it looks like. And there are elements that you need to enter. And so if you go through the process one by one, this is very easy to follow because this is a template. And so your dental clinic information, upload image, services, amenities, greetings of the doctor, and office hour. The office hour is very important. So if you input this correctly, then this will be correlated to the information on the map. So if you're open, your clinic icon will be bright and shining, but if you're closed, then it will be grayed out. So you have to be very accurate about your office hours and the departments and the symptoms to be treated. Then the people can look you up in this platform. And foreign languages, if you're serving in these languages, you can check the boxes. And so you can also select the keywords for your clinic, and through the searches, your hospital will come as one of the results, and you could send out recent or latest information and hiring information. And if you upload that information in your mini homepages, then the interested job applicants will search that for you. So once this is created, you could have the preview function and you could complete your home page. So if you create this in the PC on web, then it will be automatically created in the app as well. And our Osstem employees will help you with this design. And once you're done, you should have this downloaded. This is like a promise card that you exchange with the patients. So if you enter the information through the booking site, then the patient will be alerted and the schedules can be managed, and the patient can get the confirmation on their machine as well when the appointment hour is near. And we had many different functions on Dental. We had Osstem News, the mall, education, job, software, and hospital interior. And we added the map and mini home, and also the messenger talk function. So these have been new features that were added. So finding the dental clinic, as I explained. So if you open the map, you can see right away which clinics are open. And mini home, you have to create, and talk, it is already integrated. So we used to call it Dental, and now the name has changed to Osstem. So it's going to be under that name. So with this Osstem platform, you can have better communication with your dentist, and your clinic will be exposed, and it will be good for your business, and you will have easier time hiring. And it has to be, to use together with one click, so that you can use all these detailed functions like the e-health questionnaire, and you could have the patients register with the QR code. So if possible, you could start right now, today. This is all ready to go. Of course, we are still working on the functions, and so we will get your feedback and try to refine, and maybe we could add or adjust the features so that we can enable the functions that are much more user-friendly. And so please download and try this out. And in the booth, we will be providing you with advice on how to create the mini home. And so with that, I'd like to thank you.
Regarding Osstem app, Chairman Che gave us a presentation for about 30 minutes. General public like me and the dentists like you would find it a very useful app. Sometimes I search for a clinic on the internet, and I was looking for that kind of function, and I believe you all feel the same. And we do not attempt to make the platform itself, but Osstem has done it. In a word, all-in-one or grand integration. That would be the description for Osstem. Osstem is #1 company in Korea, and it is not complacent, but continuously make efforts to improve. Please give another round of applause to Chairman Che. So Osstem app introduced by Chairman Che will guide you to any clinic that can provide the service that you want, and the recruiting information can also be linked, and the dental common sense can be increased on the part of you and general public. Scan the QR code on the screen and download the Osstem platform. Get a stamp at the Osstem platform booth on the first floor, and you will receive a portable toothbrush kit. And then you will be able to hear explanations about the app there. If you cannot download the app readily, on the fourth floor, there is the Osstem platform booth in the product exhibition zone where you can get the help for app installation. In English and Chinese, simultaneous interpretation is provided overseas. Osstem Meeting 2025. So let's go into the third session. 3 speakers will talk about one subject in depth. Let me introduce the moderator, the chair, Dr. Kim Gi-sung from Namsang Dental Office. Please welcome him with a big round of applause. He graduated from School of Dentistry, Seoul National University, completed a residency in prosthodontics at Seoul National University Dental Hospital. He's a certified prosthodontist, former president of a Korean Academy of Aesthetic Dentistry, former president of Seoul Implant Clinic Research Group.
Welcome to the discussion session. I am the moderator. I am Kim Gi-sung from Namsang Dental Clinic. Every year, we have this discussion session, which is drawing a lot of attention, and it's an honor to be chairing. And this is one of the highlights of Osstem Meeting 2025 Seoul, and we have many wonderful speakers, and please welcome them with a big round of applause. Yes, having watched the Osstem meetings, probably you're reminded of one word looking at the speakers, live surgery speakers. And looking back, they have performed excellent surgeries, and we remember them. So I'm sure you're wondering, yes, we watched that live surgery, and so what happened? What was the final outcome? So we are having this discussion to go over the past live surgeries. And today, we'd like to take you on a journey of live surgeries with one guide, case-based follow-up results. I'd also done 3 live surgeries, so let me start with my experience. So it was an honor to be having the live surgery in 2018 Moscow World Meeting. And I was the first prosthodontist to do the live surgery, and I was not as nimble as Dr. Bae, and I was so nervous. And you can look at the video and see how unsteady my hands were. And so, you know, Dr. Bae was giving the compliment of, oh, you're good for a prosthodontist, but I was very shaky. But once the guide barrel touched the guide, my hands became steady, and I was able to perform the surgery stably, and this is the outcome. 5, the mandible was in 2018, and immediate loading for maxilla. And so as a result, 7 years have passed, and as you can see now, they are well functioning. And the panoramic view, and in doing the live surgery, the bone density and bone volume were very good. So this was a surgery that could not fail. But in my memory, Dr. Son Young-hee, you had a very difficult live surgery. So maybe you could walk us through that. Yes, hello, I am Son Young-hee. The case I did was back in 2022. It was both 22 and 24 maxillary anterior, and for the 2022 surgery, it was this. So the mobility of the bridge was big, and for 21 to 23, so immediate provisionalization was done for this case. And doing the implant for maxillary anterior, there's one thing I'd like to mention. Labial augmentation was done for both live surgeries, and which membrane or which graft material would produce the stable result. So I had given that a lot of thought. Of course, in implants, the position is important. So for both cases, I used one guide. And whichever graft material is used, well, we all think of that question, but unfortunately, up until now, the consensus is that the best material or best membrane does not exist. It is always case by case. That's the answer that we get. So in implant treatment, there are different materials, and as we're well aware, autogenous material is the gold standard, and we all know why it's the best, but because of the several reasons, sometimes we cannot get as much autogenous material as we want whenever we want. And for maxillary anterior, there could be remodeling, and to respond to that, we could also use xenogenic or alloplastic material. And for both cases, I used xenogenic. And if you use xenogenic or alloplastic, it could also be up to your personal preferences. And looking at the journals, and for maxillary anterior implant, long-term stability is determined by buccal bone thickness. And so implants, you have to have the bone volume and do the placement right. So hand-free, instead of that, guided surgery is the preferred method. And as much as possible, labial bone thickness should be guaranteed. And so what I did was, in 2022, during the live surgery, I used AOS collagen. And AOS collagen, it lumps together, so you could put in as much volume. And in 2024, for the teens, I use particulate bone, and for the 20s, it was AOS collagen. So xenogenic material. And the two did not have much difference. And BIOS collagen. So the two materials had similar outcomes according to this journal. So I did use xenograft materials, and I got fair results. And looking at the membranes, so we have this stereotype of resorptive membranes for small defects and contain defect, and non-resorbable membranes for large and non-contained defect. So that is our usual thinking, but in practice, looking at the literature, there's not much difference in bone regeneration for both membranes. And sometimes when we use non-resorbable membrane, we always have this exposure issue. And according to literature, we see that the exposure for non-resorbable membrane was 22%, and collagen membrane, it was only 7.5% exposure. So looking at this, for non-resorbable in the clinical, we should lean toward resorbable membrane to get stable results. So with that thinking, I used collagen membrane for the two live surgeries. And when doing GBR, the internal volume is changing, and periosteal releasing incision is necessary. And the reason why I'm showing you this video is we know that we need to do severing, but in the flap, severing the margin is better to get the placement. So that's why I'm showing you this video. And so instead of the type of membrane, it's all about a matter of how to fix the membrane. So how did you do that? As for the barrier membrane, you could just, cover it and you could fix it, and they have different results. And looking at the literature, just covering and collagen membrane using the bone tag to fixate, it has significant difference in regeneration. So in 2022 and in 2024, collagen membrane base, I used the bone tag to make a pouch. And then I closed it up. So that was how I guaranteed stability of the membrane. And this produced the maximum augmentation for maxillary anterior. So this is the easiest way that's available right now. And so in 2022, the surgery was complete. And post-op, the panoramic view and PMMA immediate provisional restoration. And this could have ended happily, but now follow-up. January 2023, number 23 was misplaced. So after live surgery, if you come across this, you are kind of, at a loss. So you had a lot of bone and the membrane was stable, but what happened? I guess I must have done something wrong. At a certain point in time, I must have done something wrong. And after immediate loading, what leads to failure? There are these risk factors. If you're a smoker, if it's the maxilla, the bone density, and the implant length, and it's related to BIC and the number of implants. The higher the implants, then the success rate goes up. And for delayed loading, immediate loading, the failure rate is 2.7 times higher. And so in my case, I used 11.5, but I should have used something longer. Then I think it would have been better, but I don't think it's meaningful at this point in time. I don't think it's your fault, Dr. Son. For immediate loading, as you're well aware, there's the patient factor, especially number 3. Eccentric loading is, so the patient factor and careless mastication, I think, could have been a factor. So don't blame yourself too much. But at this time, I did blame myself. So, as a stopgap measure, numbers 2, 23, 4, and 5, I cut the prosthetics. And for 24, I used the implant for number 24 and finished with number 4 bridge. And in February 2023, the prosthesis was delivered, and as you can see, number 1, according to the CT image, we have enough labial bone, and it went through remodeling process. So how will it turn out to be? So September this year, 34-month follow-up, and we see that there is stable maintenance. And I used ARS collagen for augmentation, and ARS collagen did serve as a very good graft material. So that was in 2022, the challenging case. And now I'd like to ask Dr. Park, in 2023, live surgery, yes, in 2023, I used one guide. And so the topic was when one guide met narrows and shorts. And this is the pre-op. So this was a relatively young patient, but had high blood pressure and had cerebral infarction and was wearing a pacemaker and was on anticoagulant, Lixiana. And so we did tooth extraction, but when the case was referred to us, the prosthesis was possible on the maxilla, but for the mandible, we had to remove the lingual torus. And the lingual torus surgery For patients with systemic physical challenges, it was very difficult. So we used the one guide. And this was the pre-op virtual planning. And as you can see, a total of 6 implants were placed. Short implant for posterior and for anterior. A narrow diameter of 3 by 10. And so this was a fast forward editing. And I believe that guided surgery, just like Dr. San, it does make the complex surgeries much more streamlined. But with the help of one guide, medically compromised patients could be done the flapless surgery. So it can be minimally invasive and it could be much safer. And the anticoagulant was stopped for just 1 day. And for narrow diameter implant, it's 1 ms. It's another variation, and so it was placed using the 1 ms kit. And narrow diameter implant, or NDI, most of the shapes are not tapered, but they are straight. So 1 ms drills are also in straight lines and not tapered. And another thing is for NDIs, as you're well aware, the diameter is narrow, so it is compensated by the length. And so these NDIs are lengthier than usual. So, and as you can see, 1 ms drills are used and shorter drills are used as pilots and used initially. And then you use the longer drills in the later stages. And for I think mandible and anterior is the hardest, corticalistic, and this is the toughest region in the mouth. So 1 ms or 1 guide kit and NDA variation, 1 ms, did help in that surgery. And as you can see, by steps, you have I'm showing you irrigation step by step. Overheating is my biggest concern. And so phase by phase, you drill and you use the shorter drills as pilots, and 1 ms takes much more time than you think. And another thing is NDIs, you have like 1 piece and 2 pieces. I prefer 2-piece NDIs. It's because 2-piece NDI, first, you can get the insurance reimbursement for the elderly patients. And if you don't get the initial results right, you can submerge. And the third benefit is, since I'm a surgeon, I'm not really confident in prosthetics. So in this case, you could just plant the prosthesis and you could worry about it later. And during the surgery, there was this one episode, and there was the earphone that I had, and it kept popping out. And my wife said, is your eye closed? Is your ear closed? Because I never listened to her, so I felt that I was anatomically at fault. And these live surgeries are very challenging. And in the morning session, Dr. Bae did wonderfully, but bone density assessment is very difficult. In guided surgery, assessing the bone quality is very difficult. This is another case. 24 and 25 implants will be placed, but in 24 and 25, there's the impacted tooth to the superior, and the implant that got in the way, the teeth are harder than the bone, but it came out as D2. Even if it was in the way of impacted tooth, the bone density came out D2. So is it because of the software issue, or is it because of the relationship between the two? And so bone density assessment was challenging, and for this, it was in D3 for this patient, and D4. Sometimes, there's the intra-patient comparison, but I don't do intra-patient comparison. In the guided surgery, we don't do patient-to-patient comparison. And I think you could have the same problem in the bone volume and not healed, but healing ridges. Bone volume assessment is also very difficult. And what do you think, Dr. Kim? Yes, I do agree. In doing the guided surgery, it feels like I'm doing surgery in handcuffs, and I don't get the tactile sensory as much. And it was an edentulous patient, and there was immediate loading for the cortical bone. You do the drilling and copy entered, but this did not enter. And in doing the initial drilling, it was a patient that used a denture, and because of atrophy, there's cancellous that becomes fatty, and I was worried about not getting the initial results. But the initial drill could not go in, and you judge with the bone debris. But when I do the bone density, I look at the cortical bone and look at the millimeters, and I look at the resistance of the cancellous bone using the full depth drill, and the cortical was too thick and I could not proceed. Guide barrel and the guide hole, there could be the friction, or is it really because of the bone density? So these are some confusing elements, and it was the same for both sides. And it was not the friction of the guide. And this was a live surgery, and doing the pre-op planning, I thought about whether to do the immediate loading. It was number 30s in the left. And for 36 and 37 cancellous, I was worried that it could not get the stability, and if it falls out in the mandible, but the drill could not go in. And it was the same for the 40s. I thought the bone density would be good for 45, but in number 47, I was worried about the bone density. But the irrigation tube even popped, and the pressure was so high. So looking back, the house field unit is used for the planning, and we are informed about the bone density, but I think this is the limitation of CBCT. The house field unit that we learned from the textbook, and we judge the bone density, but this is going to be more accurate for medical purpose CT. And the house field unit only exists in grayscale, and you cannot really assess bone density accurately, and there's opinion on that. But we need to rely on CBCT. And so in the clinical setting, we need to use CBCT. So we could measure the relative bone density, and probably in the implant studio, I don't know which algorithm, but to the patient, I think we could be misinformed by using this.
As we saw in the morning, depending on the bone quality, implants can be inserted and should be taken out. Clinically, how do you assess the bone quality? I don't report all the reports, but at the beginning, before initial drilling, I mostly use a flattening drill, and I sense the strength of using flattening drill when I enter. So I make the determination of the bone quality based on the resistance from that. Regardless of the implant length, so we always use initial drill for guided surgery, and I prepare some sets of that. If initial drill is encountering too much resistance, if it became blunt, I change it to the new set of the drills, and that's the approach I use. In my case, personally, as I showed you, our cone beam CT and planning software, how they match with each other, they tend to underestimate the bone quality. So I use a final drill to make the determination. Cortical, cancellous bone, qualities are sensed at the same time. For live surgery, immediate loading is required, so primary stability is very important. In my case, right before final drill, I control it with a bone chip using RPM. But if it is not live surgery, if the primary stability is a bit lower, I just place them. And the templates can be pushed. How to stabilize the template, that would be very important. How do you do that? As you can see, I believe stabilizing the template is very important. And I try to use residual teeth. During surgery, anchor screw is used first. So it is used to fix the surgical template, and the anchor teeth would be extracted. After the extraction, the template would be fixed again. Anchor screw can spin a little bit, so Osstem recently provides anchor pins. Anchor screw should be rotated in. Anchor pins have bigger diameters, so after some drilling, it can be used to fix the template. So primary stability, if it is good after implant placement, and implant driver or implant anchors are used a lot. As you can see, number 45, there was some problem in this patient. But I thought it could be used as anchorage, so I fabricated 2 templates, and implants were placed except number 45. After extracting number 45, implant anchor and anchor pin, the second anchor pin, were used during surgery. When I design a surgical template, at least the tripod fixation is very important. So they need to cover a large area. Tripod fixation is my preference. And wrapping around is a better expression than adaptation. What do you think, Dr. Kim? As you said, when there are residual teeth, tooth-supported area should be used using first and second templates. For guided surgery, some deviations can occur. There are many sources of deviations during surgery. Errors and deviations occur during drilling. If there is residual teeth, and due to mucosal tension, even though they are fixated laterally, the vertical tilting cannot be prevented. So as Dr. Park said, the most front and most rear points and the 3-pod fixations is what I prefer. And we also need to think about the vector. If the horizontal fixation is used, if we rely too much on that, the anchor pin is touching the guide, and that they can make bodily movement. So the guide can make angular deviation. Therefore, in order to prevent that, as Dr. Park said before, the guide hole to place an implant to prevent the tilting, vertical anchor should be used. And if it is a mucosa-supported case, through the guide hole, the vertical anchor should be used for drilling, not just relying on the lateral fixation. When implant is placed for primary stability, for immediate loading case on the upper jaw, 6-degree tapered one is what I prefer. Lingual and palatal wall can deviate the implants, so the guide hole can be distorted. So I prefer to use zigzag placement of implants. One by one, implant anchors available so they can be fixated in the guide hole. Before that, the fixed driver was used, and on the other side, using the handpiece, the implant was placed. So small errors can add up to big errors. So we need to try to reduce the small errors in the first place. So the accuracy of guided surgery. There are many clinical tips available. That's what we discussed. And then switching gear, let's go to Dr. Park, the live surgery. You use the short implants, right? The last one, number 46, was a short implant. The short implant is another variation of one guide. 1485 kit is used to place it. The kit has the flat tip of the drill, like a cast, and for better cutting, it is tapered. 1485. The name means it is exclusively for short implants, 4 millimeter to 8.5 millimeters. I like short implants. When implants fail or GBR in large quantity fails, it can be used as rescue implants. Second, important anatomic structure can be avoided. Third, still primary stability is high, so that's why I like short implant. TS3, diameter 4.0, and 6 millimeter long implant was placed here. This is post-op, immediate post-op result. If you compare it to the result of surgery, it's almost similar and identical. Post-op panorama. But surgery was done in the mandible, but number 21 in the maxilla, the implant fell off, and the final prosthesis was delivered to the mandible, and this is a year 2 follow-up, and the RPD on the maxilla, and this is the immediate post-op, and final prosthesis were delivered, and the patient want live surgery for the maxilla. And the patient is not very healthy recently, so I refrain from doing it. Dr. Son, I heard that you like short implants. What do you think? Short implants is something I prefer as a practitioner, and clinical results are available. 6 millimeter, up to 6 millimeters. The short implants can be used conventionally. And when GBR fails, I believe it is a good idea to use short implants in such situations. So perio or oral surgeons of vertical augmentation can be done wonderfully so. They may not like short implants, but as a prosthodontist, I like short implants. Vertical augmentation is not something I approach easily. There are so many cases, successful cases observed clinically. Short implants need to be splinted, but in the posterior region, when implants can be submerged, 5x6 can be used as single cases. Let's go to the complete edentulous patients.
And Dr. Kim, you have done a lot of live surgery for full mouth edentulous and guided surgery doing edentulous. CT data and the surface data alignment is getting very difficult. So how do you do it? In 2023, the patient that underwent a live surgery, it was a 65-year-old male and had been using denture for 20 years, was fully edentulous. And interestingly, the mandula and maxilla and mandible, we could get full stability. So on one day we did the restoration and was using a denture, and this is without denture. Ridge width was very good, height was very good, and restorative space was also sufficient, and FP1 could be suffice to do the restoration. And if you do the guided surgery, if it's edentulous, we don't have the alignment reference, so this is challenging. And in Dr. Kim Gi-sang and we had devised the protocol for edentulous treatment, and Osstem provides this protocol for alignment. So this is a denture user, and VDCR information, if it is sufficient, then copy denture is what I used. The Nobel Guide, it had used the double scan, so it's a variation of that. And the copy denture would, you take a CT and you change that to STL, and we have intraoral scanners. So you could use the scanner first and scan the denture of the patient. And the final denture, it has a metal frame, and so you cannot take a CT scan. And so if you use the intraoral scanner, you could get the scan, you could get the image for the denture, and you could fabricate the copy denture, and resin marker would be placed. So this is the radiological stent, and wax rim could be done. So MMR and VD, the information could be sent to the dental lab. And so the patient would take a CT scan with this in the mouth, and the resin marker would be recognized, and the denture would be once again scanned. And so the interior of that would be scanned, and including the VD. And this is the surface scan data. And doing the alignment, you could get very good results. And so there is no fixed reference, but if you could use the denture, of course, inside the denture, there's soft reliner or light body. And in the alveolar ridge, you could get the direct information, and through intraoral scanner, you can get the image from the alveolar ridge. And so in order to plant the screw without the invasive surgery, we could do it very quickly. So yes, you talked about the edentulous alignment, and I guess different surgeons have their different ways. And what about you, Dr. Son? Yes, I have not dealt with many edentulous patients. There weren't that many fully edentulous patients, but I like the traditional way. So as for myself, I use the fixation screws, and I think this could be a helpful way also. Well, I guess I'm very old school. I don't feel confident scanning the maxilla and mandible, and for a fully edentulous, I try to fabricate a model, and then radiologic stent or radiologic template is created so that the interim process is done. Since I have that detailed information, I can always hold it in my hand and check it, but I think you both have very good methods. In Osstem, what is recommended is Osstem Center will be making the guide, and we receive this and take the CT and then take the bite and do the alignment also. But personally, just like Dr. Kim, I prefer a denture scan. And so, Trio 6 is come out. Scanner, from 3, you can scan the dentures. And so this could give us a lot of information, because it also gives us vertical information. And so let us move on. So for prosthetic design and planning, and 12 and 10, and there was deficiency, and contouring augmentation was also planned. And after placement in the maxilla 3 and 4, 5, 6, and 4, 6 in the mandible, so immediate loading, delivery with the fixed restoration, and 12-week in the GBR site, there was gingival recession. but the length was okay. So for the soft tissue management, we did not have other procedures. And Dr. Na, our prosthodontist, likes this to remove all the abutments and scan healing abutments. And the copy dentures were used to take the impression. And at the fixer level, we had taken the impression and we could remove the wax rim step. And Dr. Na always says in the denture, there's a lot of information, and having that denture information could help you find the right decision. And if you want to get the VD up, or if you want to just MMR, you could be more favorable using this wax rim. And so this could be a way. So that's why he uses scan healing abutments. So the second fixed restoration for prosthetics. And so in this case, through the guided surgery, we could place the implant in the right position, but we have to do certain things in an analog for long-term stability for both sides. There's no gingiva, and in this case, we did APF and FGG, but and this was allogenic that was used instead. And we had the healing process, and this was 30 weeks, and we had enough depth, and we see the stable results. And the alveolar ridge had some irregularities. Alveoplasty was added, and final prosthetics was delivered. And so this is the panoramic view after the delivery of prosthetics. After the guided surgery, I look back, and if I did it manually, would I have been able to plant this? And after the guided surgery, after the panoramic view of the final prosthetics, I feel very proud. Yes, well done. And young doctors who are doing the implants, I pity, because we just had to place them well in our times, but soft. So, and now you have to think about the aesthetics, the pink and the white and gray aesthetics. So, you're living in a much more challenging times. And in that sense, one guide is going to be your helpful colleague. And so every 6 months, we look at the so we have converted to the maxillar stability. And so, yes, within the given time, yes, we could use one guide for the placements, and I think it reserves to be in the Guinness World Book of Records. And within the given time, you placed many implants with one guide. And Dr. Son, you have overcome some challenging situations. Yes, this was a live surgery I did last year, and looking at this, I thought to myself, will this be doable within a year? 3 implants were misplanted, and as you can see, temporary, and this had been broken, so they had been restored several times. And this was the pre-op state and panoramic view. And if he did the CT scan, this had been malpositioned and labial bone loss. And the remaining teeth, this did not have enough thickness, the bone. And number 23, there was root wrist perforation. And so I have revisited this case. And so what was I thinking when I made the treatment plan? First was I wanted to minimize damage to the remaining bone. And if possible, I wanted to place implant within the remaining bone. And I wanted to place the implant deeper. And that's my usual thinking. And I wanted to preserve the labial bone. Preserve and try to, augment the labial bone. And so these were the methods that I chose. remove implant with EIR kit. That would be less damaging. And implant placement using one guide. And to preserve the remaining bone, NDI, narrow diameter implant would be used so that bone preparation amount could be reduced and sufficient labial bone augmentation. So this was the one guide treatment plan. 3 implants and remove all the other implants. And KS3 was selected, and it is deep connection, so it has good performance with NDI, 3511, 3510, and 3511. So these were the 3 implants to be placed. And was it Tyson? So everybody has a good plan until they're busted. So I had a very good plan up to this point. So in removing the implant, nothing goes as planned. Removal body was not working, and if you can't get the connection, you cannot remove. So number 13, labial bone was missing, and I turned it reversely to remove this. And number 11 implant, the removal body was attached, and thankfully to the connection, EIR kit was used to stably remove this. And so I was happy up until this point. And number 21, the connection was different. It is number 21, yes. So I had to use trephine burr. And with the different connection, you have no other option. And so they were removed. And so 3 implants were removed. And as you can see, the methods were different and the damage to the implant was different. EIR kit was least damaging. And looking at the defects, EIR kit, the labial bone was preserved, and the other areas, the labial bone was gone. And so I deviated much far away from the plan, and placement of the implant. And pastoral 13 millimeter was used, and placement of the implant. Number 13 didn't have much of a problem, but as you can see, number 11, a problem occurred. What problem do you think? The torque was high. The first event, it does not disengage. In surgery, if you get the guide stuck, then, it's very challenging. And you take the drill out and you take out the template. I only had 1 hour. And if everything comes to a stop, then you go crazy. But I did remove it, and it required a lot of force. Oh, well, looking at the case, I thought it was quite interesting because personally, unless I reach the torque limit, no mount driver or motor driver, I try to go as high. And so I do get stuck a lot, but recently, having done surgeries, the anterior of the patient or the full mouth, where you have to do it fast, or when the initial stability is bad, taking it out and hand torquing, I don't like that method. And traditionally, 2/3, and then you had shift to hand mode. And in the guided surgery, I don't think you need to follow that convention. So yes, I do get stuck a lot. And when the no mount driver gets stuck, the handpiece could get, it could get hurt. And so it shows that it has good torque. So you use the Kelly or hemostat to kind of shake it off and try to take it out. And one guide template, it doesn't have mental sleeve. It is resilient. So with just a tweak of a different direction, you can take it out. And so what I'd like to say, this is no mount driver with less clearance, I would like to ask the R&D lab to make that drill for us. What about you, Dr. Kim? As was said, for no mount driver, handpiece driver, and the guide hole, we have gap of 0.1. So guide barrel has 1 ms, longer 1 ms. So I use the handpiece for 70% of the time. But if there's high torque, then I may have misjudged the bone density. So I use a handpiece to up to 70%, and the gap given 0.4 millimeter, I use that drill. So when one guide was developed, this had been pointed out as an issue. There are smaller gaps for other brands, but still you get these, drills getting stuck. But no mount driver, 80% placement, and in the rest, you take it out and you adjust the final depth. But in this case, Dr. Son, you didn't even go in full depth, but you got stuck. But I am weaker than Dr. Park. I can't just take it out easily like Dr. Park. Maybe you don't know the tip. So implant engine is removed, and no mount driver. There's this connector that is available from Osstem, this connector and the torque wrench. It's not a conventional torque wrench. If you connect them together and turn it counterclockwise, then you can take it out easily. And so implant driver final depth is adjusted. If you're aware of this, then I think this could be helpful to you. Yes, please continue. Well, I wasn't given this. And this is the second event. It was number 23, and I tried to tighten it with my hand, but it got misplaced. And so I was really frustrated, and, it was a live surgery. I was only given an hour, and I tried to, come up with a solution. Initial stability had failed. Why? Apex perforation, and in the first video I talked about 13 millimeter full depth. I went in 11.5 millimeter, but still I think there was misdrilling, so it was entirely my fault. So yes, I could not do the placement. So ARP was done, and site preparation could only be done, and I had to end the surgery. And as was just mentioned, I used bone tack and stabilized the graft site and ended the surgery. So this was the post-op number 11 and 13. I did the implant placement, bone tack, collagen membrane, and in the teens, it was collagenated bone graft. And this is the augmentation volume. And in 2025, February, 1 MS kit was used to place the implant in number 23. So it must have been very easy. Yes, it took only 5 minutes. So May, 3 months after final prosthesis was delivered. And looking at the panoramic view, I was surprised once again. Number 11 was the connection seated well, and yes. And this is the CT scan, and the final follow-up was last week, September 23, and we had this panoramic. Bone level did not change, soft tissue did not change, and so it was a 1-year follow-up, number 13, 11, and number 23. Particulate bone and collagenated bone in all these sites. We had the bone volume that was very steady. So this was the follow-up of last year's surgery, which was quite challenging. Yes, this was quite eventful, but at the end of the day, it was a happy ending. So lastly, Dr. Kim, in 2025, you did this surgery, And you have done a lot of edentulous treatments, and now there is a new concept and you're adopting a new protocol.
This is not entirely new one. In 2025, in the first half, in February, I did the live surgery, and in April, I also did a live surgery in the world meeting in one patient, 67-year-old male, upper and lower. Condition was like this, number 46 implant, that was the exception, but residual teeth, the abutments for RPD were decided to be extracted. The change in the protocol, it's not really a change, but something overlooked is carefully looked at. We used to place implants based on bone, but I believe I was lucky with this patient. Sometimes the condylar position is not good, and some patients chew with the anterior teeth, and the CR could not be found. If you are lucky, the prosthesis can fit, but otherwise it will not be fitting. Habitually, the patient used the anterior region for chewing, so CR is an issue. To prepare the guide, extractions were made, and CR guidance was tried with the immediate denture. The habitual bite, the habitual positions need to be considered to come up with a bite. And in the textbook, the CR position was reproducible, and CRCO should be stabilized. So the habitual denture can reveal the habitual bite. So in this condition, large FOV CT should be taken to identify the condyle position. Based on that, guided surgery can be started. In the mandible, it became stable, and the important references are usually in the facial scan to come up with the occlusion and VD. So scan data is used to determine the occlusal plane based on this virtual patient. As I said before, denture is used for merging, and diagnostic workup is made for planning prosthesis. In the mandible, surgery was done in February. Short implants were placed, and Smart Builder was used for vertical augmentation. If implants are to be placed consecutively at number 6 and 7, and if vertical platform discrepancy is 2 to 3 millimeters, that would be a problem. So for consecutive implant placement, the platform needs to be harmonized. So number 7 was not to be seated deep. That platform should be in line with number 6, the platform. So autogenous bone was used for grafting, week 4. Number 37 had the GBR, and for the remaining implants, immediate loading was achieved. And maxillary live surgery was planned. In the upper, one casket was used. So the residual bone was limited if it is less than 6 millimeters. Sinus membrane was detached using hydrolift, and from 6 to 6, 12 unit PMMA provisional restoration was made for immediate loading. So do you use something else? It is kind of a twin kit. I'm a prosthontist, so sinus is the most challenging surgical area. One case came out in 2017. After that, one guided series among the brothers. I like that the most. Using one cast, I performed many cases, so I'm writing a paper on that. And one cast 2 kit will be released soon. That I like that better. Bone compaction drill. The name would be changed to CAS2 drill. One CAS2 will be the new name and to be released in the second half. And I've used it for about a year, and it is better than one CAS1. In the upper, life surgery was done. 12 unit bridge was mounted. 6 implants were used, even though 12 implants were placed. Number 37 in the lower, smart builder was used in the second surgery. The vertical augmentation was not huge, so bone was regenerated properly. As said before, skin healing abutments is the most favorable approach by the prosthodontist. So seamless DR abutment is used recently. 4, 5, 6 were connected with DR abutments, and the skin healing abutments for DR abutments were prepared. And using the denture, the impression was taken. This is second. Number 33 were mini implants and custom implants plus PMMA. Bilateral 4, 5, 6 DR abutments were used. The cementless PMMA type restoration. Number 46 was placed in another clinic. It is good, but screw acts as a whole direction. As Dr. Park said, the white aesthetic is very important, and that makes great improvement after the secondary surgery in the maxilla. Fixed restorations was delivered last week using all the implants. Currently, this is how it progressed. Initial visit, and this is the recent situation. The final prosthesis later would not be very challenging. That was a beautiful case. I know you are very good at performing surgery. Dr. Nagi won. I think it was a blessing for you to meet him. Wonderful, even temporary prostheses were made. So let's have a look at the Osstem meeting lab surgeries up to 2025. Actually, this is similar to playing Go. Sometimes we lose, but we need to review what happened to make improvements. So I believe audience may have some questions, and let's open the floor for questions first. If you have any questions, please raise your hand. Please bring the microphone to the person who wants to ask a question.
The final prosthesis for full mouth prosthesis. Could I ask a question about the full mouth prosthesis? Emergency profile for alveolar bone resorption, there was a lot, and the shape of the prosthesis. There are many people who are saying that they get like the remaining food stuck in their teeth. And looking at the prosthesis design, I think the profile was convex. The emergency profile, yes. So, what do you think about that? The teens and the 40s. Well, implant placement depth was sufficient, and CAD/CAM abutments, the biologic width, and the emergency profiling was not bad. If it's splinted, well, number 45 and number 46. Number 15 and number 16, the emergent profile, the angle is visible. after delivery, the patient did not have any issue. And as for the design, there was confirmation from the prosthodontist. So which part looks convex? Number 46. It does look convex, but that is due to the implant. It was leaning toward the buccal, and it does look like that, but the emergence profile comes from bottom to up. For a full mouth prosthesis, that region, if it is abundant, then it's better. Instead of sloping, then if it has the full body, then the patient feels at comfort. But and in any type of prosthesis, you get the food get stuck in between, and the patient should be able to manage that. And that, I think this is manageable by the patient. And from edentulous, we went to this fixed restoration. So I think we can leave the management of those remaining food in the teeth to the patient. Yes, we'll take the next question.
I'm not good at prosthetic work. I work on it hard, but it's not easy. And actually, prosthetics is very challenging. The last question talked about the X-ray. Dr. Kim, and the maxilla. Usually, how many implants do you place? In my view, 8 or 6 implants would be okay. But there are 10 there, and there were 10 and 12, even 12 in other photos. Depending on bone quality, it can vary, and it can also vary depending on patients. But in that case, do you use all screw retained, or do you use 2 on each side, screw retained or cement case? So in this case, how many implants do you prefer to place? You place the 10 in maxilla. I understand the number of implants in the mandible, but why 10 implants in the maxilla? 8 would be good, and even 6 would be okay. I'm wondering. Good question. When I perform surgery, the fixed segment restorations, then 8 to 10 implants would be my choice. Age should be considered, and when number 7 occlusion was lost, and the patient was in the mid-60s, and the arch was pretty good, and the patient was in the 60s, not 70s. So in that case, 1, 3, 4, 6, 7 would be the implant size. For number 1, incisive foramen is too big, and sometimes we cannot place in one. So 3, 4, 5, 6, 7 would be the size. If the patient is old and a long time ago, number 7 occlusion was lost, then the number can be reduced. So sometimes you use 11 and 21. Sometimes I place there and sometimes not. If the arch form is too V-shaped, cantilever would be interfering if you place 3 and 3. So assume that I don't know about it. In edentulous patient, for number 1, the alveolar is receded, and it has a tendency of a crossbite. When implant is placed, it will come out. So in the lateral incisor, in number 1, 2, or 3, you can place implants, and 4, 6, 7 would be the implant sites. And Is it hybrid type? Yes, SSRP type. Screw access holes are there, so they are segmented. The occlusal surface was not shown. So are they all cement type or screw type? Screw access holes are there. What about in the maxilla? In the maxilla as well. It is a PMMA, but in the final prosthesis, SSRP will be used, so access holes will be there. So please bring up the last prosthetic photo. Between teeth, it's like a banana lying down, face down. Pink porcelain or resin can be added. Gingiva embracer it can be made. Did you think about that? FP3 type soft tissue reproducing a pink porcelain case, restorative space height, depending on the height. The exposure can be different when a patient smiles. In the 12 to 13 millimeter was the incisor length, so pink porcelain was not really necessary, determined by the prosthetic department. Emergency profile was also mentioned before, so lack of teeth spaces. I don't think food will be impacted there, but it would be hard to care about that. For full arch rehabilitation, PMMA is used for a long time. Using ovate pantic, the papilla is reproduced, and the food impaction is also evaluated. So after that, when gingival level is stabilized, the final prosthesis would be delivered. But now, the temporary crowns are so are they temporaries? Yes. The panorama zirconia is not visible. As for the number of implants, how many do you place in the edentulous case? Actually, when 2, 3, 5, 6, so 6 in the mandible. And if the patient can afford, I would like to place more. Dr. Park, you are not practicing, so what do you think about the number? Regarding Dr. Kim's question, I do prosthetics even though I'm an oral surgeon. I agree with Dr. Son, but number 7, I don't do it. As you go toward the posterior region, there is no bone, so short arch up to number 6 and 3 segmented prosthesis, 3, 4, 5, 6, or 1 or 2 can be added in the front side for the full fixed for the maxilla. Bone quality is good for mandible. 3, 4, 6, and a couple of more. Screw type. Digital can be confusing, but the DR system itself is something to be connected to implants. And the screw type, which was complicated and we discarded before, is brought back again. There are reasons for that. As for the abutments, after surgery, abutments were connected and superstructure was worked on. So immediately after surgery, there's not much bleeding, so it works well with one guide. Emergency profile, it is temporary. And I don't know what you think, but slender shape transitioning to gingiva. The pink porcelain can be added to make it aesthetic. As a prosthontist perspective, in 1 or 2 cases, in a aesthetic case, we can do it. But for full mouth cases, a full zirconia is used. So the polishing should be added. in terms of convenience of prosthetic work, if the lip line is not high, full zirconia would be much more durable. Thank you.
If it's not pink, then we cannot open the space. But if it is pink, then you could still do it with it closed. And you cannot have it open. Yes, for sensitive areas, yes, we could have the pink. Yes, thank you. Yes, we will take more questions from the floor. Hello, thank you. Bone quality assessment. I have a question, but it turned out different from expected. And is this usual or? So this was unusual for you, right? Looking at the case, the implant around the implant and the adjacent area, it only shows the surface density, but if you back out, you don't know what will happen. So that's the impression that I got. So that was the question that we wanted to ask. We have Dr. Ha from radiology. So Hounsfield and CBCT, how they match? Should we not take that measurement for granted? Yes, I'll talk about that. Looking at papers, there's talk of you cannot take those numbers for granted, but we have two different structures, the CBCT and so from cone beam CT, the basic measurement is grayscale, but it is converted to a Hounsfield scale, and this is because at MFDS in approving the CBCT, it is CT. So the reproducibility and accuracy of Hounsfield should be guaranteed. And every 3 years, you get the checkup, and this is also under one of the checkup criteria. So from cone beam CT, it does have the gray scale value, but you can be converted to Hounsfield score. So you could have reliability to a certain degree, and you can confirm it. I check it sometimes, and in the very black area, you can check the Hounsfield unit. It has to have -1000, and look at the muscle area, because it's confusing. So if you scan the muscle area, then it should come out to be not 0, but slightly higher than 0 and less than 100. So if you get that range, then you can say that this is reliable. And what I want to say is, if the numbers are far off, then it's not calibrated properly. But looking at the recent CBCTs, MDCT values, it's trying to match the MDCT values. So you could, have some conviction in CBCT. But to my knowledge, MDCT or medical CT, they undergo calibration. But for cone beam CT, it is not calibrated. Is there any difference? Yes, there is a difference. For MDCT, it is not as accurate, so you have to take that for granted for CBCT. And as you said, you could have some distorted values from CBCT. And maybe this could help, because 3 years you have to get the CBCT checked. And if it's distorted too much, then you have to get it checked again. And if you don't get the accuracy and the reproducibility, then it's not approved. So we have to call up the vendor and have it adjusted. So that is as good as calibration. And so you cannot have absolute reliability from CBCT, but it is usable. When we use it, it could be helpful. So we could have some conviction. And listening to this talk, what I felt was, in most patients, what we had predicted is what actually happens. And, sometimes we have these unexpected events. And this is because of mainly we assume that the bone density will be uniform. And that is our preconceived notion, but the patient condition could be completely different. If you look inside, some areas are very dense and some areas they're not as dense. So in going in, there are some deviations, and that can only happen. And the biggest, precaution is the bone density seems high when measured, and the reason it could be because of inflammation. And the high density, because of inflammation, is not favorable. If it is too dense, then it could act against us. So we have to be very cautious about those cases. Thank you very much. And now I would like to pull up a question from online from Dragonfly. Ossbuilder was used for vertical augmentation. Vertical augmentation bone. What kind of method and material did you use, Dr. Kim?
I like Ossbuilder because it is simple. For vertical augmentation, the buccolingual bone should be accumulated and stabilized, and flap management is challenging. And membrane application is very difficult. The Smart Builder, Ossbuilder, is preformed in 3 dimensions. Autogenous bone needs to be harvested if that can be done, and fixed. And a lot of resorption can occur after remodeling, so xenograft should be used. And on top of it, Ossbuilder should be used, and anchor builder is used on how much the bone would be, how much it would be raised. I usually use 1.5 to 2 millimeters, and they can secure biologic width superiorly, so they can protect the bone graft vertically. Dr. Son, I agree. I like to mix autogenous bone. I don't do layering, but I mix it with xenograft. It's a matter of preference. Ossbuilder is used to simplify procedure, and it can shorten time. That is the advantage. And if I use other methods, things would be different. It would become a very challenging. Vertical augmentation is really challenging. There are many failures, but as an oral surgeon, I agree with Dr. Son, but there are 3 points to pinpoint in vertical augmentation: autogenous bone, block bone, and depending on a situation, bioactivation. RHBMP-like material is necessary. I do not represent oral surgery, but it is a difficult procedure, and that is affected by teeth and others. But these 3 factors need to be considered. It may be controversial, but so last question.
How can you check whether the path is inserted as planned? And do you do just CBCT after surgery? So is there a way to check during surgery? Dr. Son had shared his episode when guide barrel is stuck in the guide hole. That's because that is the initial sign of deviation, but I don't think there is any way that you can check during procedure. Yes, even I, who did not drill right, I could not identify the problem. Before CT, how can we confirm the position? There is no way of finding out. So provisional or temporary, if you're planning it for that day, you should leave some room. Yes, I think you should accept the placement position and revise it in prosthetics should be the solution. What about you, Dr. Kim? Yes, during surgery, there's no way of finding out. As was just mentioned, if there is misposition, then the implant driver or fixer driver will get stuck. But if it is placed, then there's nothing you can do about it. And right before the surgery, within the guide, there's the CT checker. And so right before surgery and right after surgery, I take the CT scan. So you can only just compare before and after. Thank you for that question. And also, it kind of threw us off. Yes, in the interest of time, we will have to close the Q&A. And please approach us personally during the break if you have any additional questions. And now we have to select the best question to give out gifts. And from the floor, I would like to, I don't know your name, recognize the first questioner and Lemon Tree, online participant. You are selected as the best questioner. Thank you for your participation and thank you, panelists, for your wonderful talk. Thank you very much. And as we close, why don't we go around and say a few comments? Dr. Son first. Well, I did a few surgeries, and in my surgeries and looking back, I think it was a very good chance for me to revisit what had happened. And these were some moments that I don't want to welcome again, but this is inevitable part of our work. And when similar conditions come up again, I think I'll be able to resolve them better. Thank you. Yes. In doing live surgery, I hope that this will be the last one and I will never do it again. That's what I think about. But, it's the mouse's destiny to eat the rat poison, not thinking that it will be the poison for them. So during the live surgery, I was able to find out what, I had not known and getting the right position for the placement. And, I was very relieved that I was able to perform a good surgery, and I'd like to thank Osstem for giving me this good opportunity. And personally, I have a huge respect for Dr. Kim and Dr. Son and Dr. Kim, and thank you. It's an honor for me to be sitting in this panel together. And live surgeries, as you're well aware, you cannot do it well just because you're a good surgeon. The shooting environment, the patient factor. So in that sense, Dr. Bae in the morning and Dr. Park, who will be doing the live surgery in the afternoon, cheers and kudos to them. And during the discussion session, this has not been just made up off the cuff. And we have had these previous meetings involving so many people, and it requires a lot of work beforehand. And so Osstem people and viewers and audience here on site and online, thank you very much for your support. Yes, Osstem One Guide System is celebrated its 10th year, and we have gone over the live surgeries. And this will conclude the discussion session. Thank you very much.
In the discussion session, Dr. Kim Gil-sung, Dr. Son Young-hui, Professor Park Chang-ju, and Dr. Kim Yong-jin, thank you very much. This concludes the session. So let me announce the winners of Osstem TV login viewer event. 600 people will be lucky to get the gifts. 600 winners, names and the numbers. So the bulletin board of Osstem TV will have detailed information about the winners. So we will have a break until 3. And please make sure that you visit the various event halls. After the break, Dr. Park Jung-chul is going to talk about the live surgery under the title of immediate implant placement using one guide system and sinus bone augmentation with LCR. And we will come back shortly. Thank you.
Introducing the ultra-wide implant. Ultra-wide implants are perfect when placing an implant immediately upon extraction of a molar. Ultra-wide implants with a diameter of 6.0 and 7.0 can be placed immediately without GBR in a socket where a molar has been extracted. Also, 6.0 and 7.0 ultra-wide implants are easy to place without having to wait for an extraction site to heal after the removal of a failed implant with a 5.0 diameter. Try the ultra-wide implant for immediate molar implant placements. Introducing the OneCast kit, the digital sinus surgery kit. If you use the OneCast kit, you can digitally pre-plan the exact implant position and drill length required for the sinus surgery. Place the one guide template first, then use the drills with rounded apex together with the stopper in order to perform safe drilling. You can also perform hydraulic lifting and bone grafting while the template is still in the mouth. Try the OneCast kit for safe and precise sinus surgery. Introducing the 1MS kit, the implant surgery kit for anterior region with narrow bone width. In the anterior region with narrow interdental space and also in the narrow bone width, place the one guide template. And then you will be able to place MS implants with the most narrow 2.0 millimeter diameter and TS3 3.0 implants exactly in the planned position by using 1MS kit. Try the 1MS kit, the implant surgery kit for the anterior region with narrow bone width. Introducing the 485 kit, the kit for placing short implants. The 485 kit has drills with round design apex, which minimizes damage to the inferior alveolar nerve when performing surgical drilling. The 485 kit allows you to place 4 to 8.5 millimeter short implants. Only 3 drilling steps are required when placing implants with the 485 kit. When placing short implants, try the 485 kit. Introducing Magic Align. A digital clear aligners can be corrected accurately and conveniently, crowding, space, and deep bite, which are various encountered in clinical. Magic Align can be corrected maximum 5 millimeter crowding cases within about 10 months using less than 20 step aligners. And maximum 4 millimeter of space case can be corrected within about 5 months using less than 10 step aligners. Also, maximum 4 millimeter of deep bite case can be corrected within 10 months using less than 20 step aligners. And maximum 2 millimeter of open bite case can be corrected within 5 months using less than 10 step aligners. Anterior cross-bite cases of less than 2 millimeter can be corrected within about 3 months with less than 5 steps. Protrusion cases of about 4 millimeter can be corrected within about 10 months with less than 20 steps. Magic Align uses Magic Foil, an excellent elastic 3-layer composite material. Therefore, more than 15% better orthodontic retention than the 1-layer material and less deformation due to aligners from put on and take off. So, effective orthodontic treatment is possible. Effective orthodontic treatment is possible due to less deformation of the aligners from put on and take off. In addition, the magical line is trimmed based on the patient's unique gingival line without covering the gum. So, the patient can put on easily and accurately at once. Magic Align provides diagnostic analysis files and 3D setup simulations to help establish accurate treatment plans. In addition, orthodontic treatment can be carried out according to the initial treatment plan by applying the Magic Setup system that checks and supplements the teeth movement every 12 weeks. Start orthodontic treatment with Magic Align that can correct various orthodontic cases accurately and conveniently. Introducing the E-Star Z series. E-Star Z is a zirconia block made by Osstem implant. The E-Star Z was developed by our R&D specialist at Osstem implant. Our in-house specialist at Osstem implant developed the manufacturing process. Each product is inspected and completed through a systematic quality inspection. E-Star Z is a CAD/CAM compatible material that simplifies the process of creating zirconia prosthetics at the clinic. It can be fabricated in various dental restorations, including inlays, veneers, crowns, and bridges. Multiple prosthetics can be milled simultaneously with E-Star Z. The disc is in 98 mm diameter and has 7 different types of thickness, which means you can select the right disc according to the length of each prosthesis, so that the material can be used more efficiently. Meanwhile, the shape of the block that comes with solid metal mandrel is diversified depending on cases. In particular, if you want to fabricate a long implant or bridges, you can choose block type with the 25 mm height. With the E-Star Z HT, you'll experience natural-looking colors. With 3 different shades, A1, A2, A3, you can replicate the patient's natural teeth color. E-Star ZT has an excellent strength. Thanks to high flexural strength of at least 800 megapascal, you can fabricate stronger prosthetics for the posterior region that is susceptible to high masticatory pressure. Zirconia prosthesis material with natural-looking colors and outstanding strength. Try the E-Star Z series made by Osstem implant. Introducing Digital Film Scanner Fire CR. Provide the pain-free patient experience with a thin film. Get a clearer image with a digital image processing. Fire CR provides you with a clearer image of max 21 line per millimeter. Fire CR enables more accurate and various diagnosis to a variety of cases such as interproximal caries, tartar on teeth, implant placement status, endodontic procedures, etc. Fire CR gives you the more precise and credible result. Fire CR offers 5 sizes image plates for children, adults, bite wing, and occlusion. It is possible to select the plate considering patient's oral cavity and its imaging purpose. Compared to the DR sensors, Fire CR has a thinner image plate to position inside the mouth. And its flexible image plate minimizes foreign body sensation. So the patients can be free from the pain due to the hand pressure during preapical imaging. With only one single plate,
It is capable of shooting more than 2,000 images on average through non-contact scanning. Moreover, Fire CR reduces times to repeat rescanning occurred from distortion or movement of the plate during the scanning process. Reduce the pain in patients. Improve the quality of the image with Fire CR. Great unit chairs designed for dental treatment must be convenient for the clinicians to use, feel comfortable for the patient during treatment, and they should also be easy to clean and maintain. I would like to introduce K5. It's both a stylish and convenient unit chair. In case the backrest tilts downwards, the leg rest goes up. The tilting function prevents the patients from slipping down. It is convenient for the clinicians to carry out treatments and provide comfort for the patients to receive treatments. The K5 also has a wireless foot controller designed to offer an even more convenient treatment experience for the clinicians. Handpiece RPM can be easily adjusted by turning the foot pedal left and right, making treatment.
Hello, we are going to have the live surgery, the second one of today. And Dr. Jung-chul Park will be performing the live surgery. And I'd like to introduce the chair from School of Dentistry at Jeonnam National University. Dr. Oh Hee-gyun. Professor Oh has served as president of Asian Association of OMS, former Korean chairperson of AOCMF, former president of Korean Association of Maxillofacial Plastic and Reconstructive Surgeons. He is currently an emeritus professor of OMS at Jeonnam National University School of Dentistry and is the chief director at Jeongmin Dental Clinic in Gwangju. Please welcome him with a big hand. Hello, everyone. I am Oh Hee-gyun, as was just introduced. In today's live surgery, Dr. Park Jung-chul will perform the surgery, immediate implant placement using one guide system, and sinus bone augmentation with LCR. So we will be observing his live surgery. And now let us meet him through his pre-op lecture.
Hello, I am Park Jung-chul, director of a Seoul Dental Clinic. In this Osstem meeting, I'm very honored to be part of it, and I feel responsibility to take part in the meeting, and I feel nervous. I'll do my best. I would like to briefly explain the patient who will be operated on, a 80-year-old male who has no medical history and does not smoke. On this panorama, you can see that many teeth have been lost. Many teeth need to be extracted and treated. This is a frontal intraoral view. And then the right side and the left view, the maxilla and the mandible. Today, I'm going to perform surgery in quadrant 2. In other areas, they have been treated first. Number 15 also completed the treatment with the flapless surgery using a one-guide system. In number 22, Also, one guided system was used to place the implant, and now he's using a temporary crown. Implants were placed in number 34 and 35 immediately on the heel bridge with the GBR. And we are currently in a waiting period. For number 44, a one guide system was also used under flapless surgery, and treatment was completed. Today, implants will be placed in 24, 25, and 26. The surgical plan is to place implants in number 24 and 25 immediately using the one guide system. In number 26, the lateral approach will be used to perform maxillary sinus bone graft, and for the vertical bone resorption, minor vertical GBR will be done using a resorbable membrane. An intraoral view. Number 24 and 25 are now in a very poor state periodontally, and number 26 is observed to have slight vertical bone resorption. The plan is to place TS3PA surface implants for number 24 and number 25, 8.5 by 4.5 millimeter implants will be placed. For number 26, the 8.5 long implant with a diameter of 5 millimeter will be placed. As for the bone graft material, ACR is planned for the maxillary sinus. Next, for the gap after extraction, collagen will be used for the graft. Next, in number 26, a resorbable membrane, guide, will be used to slightly augment the vertical bone and will be fixed with bone tacks. The membrane will be fixed with bone tacks. Let me briefly introduce a product called LCR to be applied to the maxillary sinus. Many of you know about BA surface, synthetic bone graft based on hydroxyapatite. The BA surface is made of solution and is now made into a solid graft material. So that is the characteristic of the material. LCR is expected to perform as allograft. In the X-ray diffraction, it shows a pattern similar to that of allograft. Also, in the preclinical animal experiments, the amount of new bone formation was very similar to that of allograft. And the clinical study on the maxillary sinus has shown similar results to allograft. In fact, even in my clinical case of about a 3-year treatment, in number 16, the LCR applied to sinus lift also shows similar results to allograft. The inferior maxillary sinus margin at the first visit, post-op 7 months, and post-op 7 months, final restoration. And about post-op 3 years, the new maxillary sinus inferior border was created, and the performance was very similar to that of allograft. So I thought that LCR would have similar performance to allograft. I plan to use LCR for the maxillary sinus today. The surgical plan is to use a lateral approach, and I'm thinking of making a rather large incision. Number 26, there is in that site, bone graft is planned for the slight vertical depression. That would add up to a large incision from number 27 up to the mesial to number 24. Number 24 is a case that can be done without much difficulty if you use guided surgery for immediate placement. Looking at the guide plan, it seems necessary to drill on the slope, so I'm planning to use a path drill for the first drill. Number 25 also has nothing special other than this sinus. Since bone graft using a lateral approach is to be done, there doesn't seem to be any particular problem. As intraosseous anastomosis is observed, there will probably be some bleeding when a window is made, but it will not be a problem with the surgery itself. Number 26 lacks residual bone in the maxillary sinus, so I had some concerns at the time of diagnosis. If you look at the guided diagnosis, there is some palatal bone, so I designed it to gain some stability from the bone. exposure of probably about 2 implant threads is expected on the crest. So I'm planning to proceed with minor bone graft simultaneously. And for number 24 and 25, healing abutments can be connected, while number 26 is planned to connect with 2 millimeter long cover screw to create some more space at the time of GBR. I think the time will be a little tight, but I'll do my best to finish in time. I would like to ask for your support for successful surgery. Thank you. Good afternoon. I'm Dr. Park Jung-chul. Let me start surgery. Lateral approach for the sinus. The flap is raised to make a lateral approach for sinus, and GBR is to be done, so the large flap will be raised. To reduce surgical time, extraction is done first, and the guide, or I didn't fit the guide, but fitting of guide was pretty good, so no issues are expected. Sinus window is to be created. A residual bone at number 6 is not sufficient, so I don't go to crystal. I will have a gap of 3 millimeters. A window is to be made. Dr. Park, irrigation, please. The water hose fell off. So a round burr of 2 millimeters is used to create a window. After opening a window, when membrane is elevated, there's no risk of tear later, but you need to be careful at the beginning. The sequence of raising the membrane. So you need to start lifting the membrane where it is convenient to do the raising. And I use some turrets, smaller one first, and going to bigger ones. And I find some turrets more favorable. And I make sure that the turret is in touch with the bone when I raise the membrane. When you lift the membrane in the meso wall, the membrane can tear easily. So directing can be done in midair. So elevating the membrane would be helpful if you consider that factor when you open a window. When you lift the membrane, the medial wall should be lifted properly. In the sinus, the blood supply, there's a perforating branch in the greater palatal artery, so the blood supply should be sufficient. In order to do so, you need to lift the medial wall so that the blood supply can be streamlined. So that's something you need to consider when you elevate the membrane. The membrane is sufficiently elevated now, almost done. And I'll do drilling and place implants. At number 22, a temporary was planned originally. When you make a guide with a temporary on, so placement immediately following extraction. Number 24 position, there's septum. So a path drill is used first. 4.5 by 8.5 implant will be placed. For number 25, 4.5 by 8.5 implant will be placed. So that is connected to the sinus. For number 15, the bone is not weak. For primary stability, it will be under drilled. For number 26, the residual bone is quite lacking. And 8.5 will be placed there as well. 5.0 by 8.5 implant will be placed there. And the under drilling is to be performed for primary stability. In the sinus, grafting will be done, followed by implant placement. In the sinus, if you use the pen, it facilitates the graft. Today, in preparing the live surgery, the pen type was thought about. Many of them have been prepared to reduce surgical time. This morning, I forgot to bring the pen type bone. It's in my clinic. So the rest will be inserted using vial. Some more, please. Push it in. Fixture. Turn off the irrigation. Please hold this. Turn off the water. BA surface implant is placed. Please hold this. 4.5 by 8.5 is placed. One more, please. As Dr. Kim Kyung-won said in the morning, with a handpiece, I place about up to 80%, and the final depth is controlled by hand. Number 6. Open your mouth. Actually, I cannot see clearly because I'm getting old. So my staff is checking it out for me. One more. In number 6, the residual bone is not sufficient. So if I place it too deep, the implant can fall into the sinus. So I need to be careful in placing it. You can go in a little more. Healing abutment, please. So front 2 will be connected to healing abutments. So press it down. That's okay. Don't swallow it, please. Gauze, please. More gauze. Cotton. Please press it down. Cover screw, please. So cover screw will be connected at the back, and GBR will be done for vertical augmentation. At the back, I will insert the back implant a little bit more. Next, I'm gonna put a little bit more bone into the sinus. So do I push it in? Yes. AOS collagen, please. 1. Cut it in half. The entrance should be blocked with AOS collagen and the one which made a window. One more. Bone. The bone from the window. membrane, please. So you're going to use bone text, right? Yes. Open your mouth, please. The membrane is to be fixated for GBR. Bone text, please. So the patient will hear some tapping sound. One more bone tap, please. Open one more of it. Next, the graft. So when you insert the bone text, the pouch is created. One more AOS. Please cut it horizontally. So I need to add it on the palatal side. Cut it horizontally. On the palatal side, I'm going to push it with the collagen. One more bone tag, please. One more bone tag to fix the palatal side. So the membrane is fixated, and I'm going to suture the site. A releasing incision is necessary because we did the grafting. I'm going to perform a releasing incision. The graft volume is not large, and we have a large flap raised, so I don't need a lot of releasing. The flap is sufficiently pulled. Rather than mesial, the first suture should be made where you don't want opening. So from the vertical augmentation site, modified roulette suture is to be made here.
The membrane fixed with the bone tag, it gives better stability. So having 1 or 2 bone tags is recommended. And then I'm going to finish up with an interrupted suture in the frontal part. I did not do cavity filling, but I looked at one of the journals recently, and Dr. Jo Yeon-nam, when doing immediate reading, there was a journal about cavity filling. In this case, we have very sound bone, and in the implant placement, we had enough buccal bone width, so we didn't do the gap filling. And when the flap was opened, the buccal bone was very sound, and we had sufficient buccal bone. And if the IBP distance had been closer, there would have been more grafting, but it was not required, so this had not been included in the planning from the very beginning. But if there is IBT distance less than 4 millimeters, I don't think that is required. Dr. Park is using the lateral approach for sinus bone graft, and this was a very difficult case, but he has done an excellent job. And so it may look very easy to the audience, but in this patient, the remaining bone was very thin, and lateral approach the bone window thickness, when doing the vertical, it was given at an obtuse angle. But from the distal to medial, the blood supply is coming in direction. So you have to give it an obtuse angle. And then we could have a good blood supply. And so the bone thickness was very thin. And the membrane tearing happens quite often. And in lifting the mucus, he did not hurry, and he did it very calmly, and has lifted the maxillar mucosa, and that was impressive. And the bone quality is weak, and the bone thickness is only 1 to 2 millimeters. But from drilling to implant placement, so he did it very well with caution. So this was a very good job done. So could you say some closing comments? Yes, I was able to complete the surgery within the given time, and I'll see you during Q&A. Thank you. Good job. Let's give him a big round of applause. So to prevent membrane tearing, the bone window was created bigger. So that was one of the tips. And let's now begin the Q&A. As you're well aware, it will. So we will take questions as soon as Dr. Park is ready. And in this case, there was the risk of membrane tearing, and in implant placement, there could be fracture in the thin remaining bone, and the placement could not be done. And initial stability for the implant placement was not secured, so it could be delayed. So these were potential risks, but without these issues, he was able to perform the surgery very well. And now we will begin the Q&A. Should we take questions? Yes, Dr. Park is now on the screen. Oh, sorry. Yes, if you have a question for Dr. Park, then please raise your hand. Oh, yes, please. Dr. Kim Sunju, please go ahead. Thank you for that wonderful word surgery. I'm from Ide, Ewha University Hospital. I have two questions. First is, as for the bone, you used mixed material. First, LCR injection, and then collagen was used. And was there any special reason why you used a mixture? And second is looking at the CT scan, sinus membrane thickness can be predicted, and gathering from the patient's habits, you can make assumptions. In this case, as to whether the membrane was thick or thin, how did you predict? And as was mentioned by Dr. Oh Hee-gyun, in order to prevent tearing of the membrane, you created a larger window. But as for me, if it is shrunk, then for the preservation of the buccal bone, I prefer to have a smaller window. And what do you think about that? Thank you. Yes, thank you. As for AOS collagen, if I had just used the particles, if I blocked the window with AOS collagen, then in creating the window, I thought that would be better. So that's why I used it. And as for making the window bigger, well, yes, you could work with a smaller window, but if there is membrane tearing with the smaller window, then, if you don't get the good results, then it is not good. And what's important is to lift the sinus membrane and to do the bone graft well. So I just thought of making the window bigger. So yes, if you could do it with a smaller window, then yes, that would be better. Thank you for the question. And as for the size of the bone window, Dr. Kim Sun-jung, if there's atrophy, it could be closer to the placement and localize and elevate to save time. So that could be the benefit. And that's why he suggested a smaller window. And Dr. Park said if the bone window was made smaller, then it could enhance the risk of tearing the membrane. And he wanted to prevent that and made the window larger. We'll take the next question.
I enjoyed your surgery. My name is Park Sang-tae. I have practiced in Jungnam-gu area with the lateral approach today. So prior elevator was used to lift the Schneider membrane. In my case, it's up to sinus medial wall that is lifted for bone grafting. But in the faculty seminar, up to the top of implant, the lifting was done in a small scale. What do you think about that, Dr. Park? The graft volume for lateral approach, I tend to lift a lot. Depending on the materials used, it makes a difference. If there is a small residual bone and if there is a need to regenerate a lot of new bone, the bone and implant need to have a large contact. So allograft can go through volume change, so overgrafting is preferable. For a xenograft, it can withstand. However, even xenografts can go through a lot of volume changes. So I believe sufficient graft would be better, but not too excessively. My criteria is that for 1 millimeter lift, 1.0 cc is used. In the molar area, the sinus is more wide, so 0.2 cc is something I think about. So in number 5, 3 millimeter or more bone graft. For number 6, 6 millimeter lift was what I thought about. So 1.5 to 2 cc graft material were inserted. So postal panorama is ready. So put that up on the screen. So a lot of graft material in there. Other questions? Please raise your hand if you have any questions.
Thank you, Dr. Park. I am Lee Hye-jin from Gangnam Clinic. The sinus graft, when it's done, number 4 or number 5 or number 6, about 10 millimeters wouldn't have been better, no? As for the implant length, yes, thank you for the question. The fixture length, well, the reference would be 10 to 12 millimeters, but now the standard is 8.5 to 10 millimeters. And so I don't think a lengthier implant is necessary. So instead of focusing on the length, I'm more focused on the diameter of the implant. So 5 by 8.5 millimeters, I thought that would be sufficient. And looking at the surface, Osstem's BA surface, it's sufficient for osseo integration and it provides good service. So 8.5 millimeter length and diameter 5, I think would have been sufficient. Thank you. Yes, another question?
Okay, this is a usual question. Post-op pain can be caused by soft tissue, so releasing incision may cause swelling. Do you think so? Hematoma, unintentional hematoma, a bruise can appear. So can you have a predictable prognosis? Regardless of the volume of graft material used, bone is generated from blood, so fresh wounds should be created more to facilitate the bone regeneration. What do you think? The first part of your question, I believe that causes the pain. So we need to prevent that. Steroid injection. Recently, I inject the steroid just like you inject anesthesia. And if that is used after injection, swelling can be reduced effectively. And the fresh wounds to create more bone. I don't really understand your question. From blood, a bone is regenerated. Therefore, rather than putting in a lot of graft material, you can induce more blood into the site. What do you think? I think that's good. The scaffold is the blood clot, but the volume or stability is not stable. So the material that can work as scaffold can be better. We put in graft material so it can achieve wound stability with the graft material. Without angiogenesis, new bone cannot be formed. So we need to make sure blood supply is provided. That's why we do cortical perforation.
Yes, thank you. We have a lot of questions in the chat room, and we'll take one or two. Yes, from a nickname starting with K. Bone tag removal is done when? And when is prosthetics delivered after post-op? Maxilla number 26. Prosthesis loading time, I think, was asked. Yes, could I respond? As for the bone tag, in the second surgery, I think they will be visible. So the bone tags in the second surgery will be removed. And sometimes, according to the panoramic view, number 35, mandible, the bone tag, I don't know if you remember the position, but yes, the bone tag in the very bottom was not removed. The bone tag seen in the second surgery And as for the timing of second surgery, the remaining bone is not sufficient. So for now, for about 4 months, we have to wait and then perform the second surgery. And we will perform the second surgery 4 months later, and we will do the ISQ, and then we will determine the prosthetics. And the criteria is 70 or higher in ISQ to do the prosthetics delivery. Thank you. And nickname Sushin. We have many questions, so I'll just select one. Bone window position, and do you use the membrane, or do you just reposition the window? In repositioning the window, I don't use the membrane, but I was doing the vertical GBR, so I was covering the membrane. So I used a larger one to cover it, and in fixing the bone tag, I tried to create a bigger pouch, but the sinus window, for those people with thin lateral walls, in punching the bone tag, it could tear, and so you have to be very careful. And I fixed the bone tag to the superior position. And I don't usually do it this way, but because I did it with GBR, that's why it was covered together. Thank you.
One more question. When bone quality is poor at the time of implant placement, what is the criteria of under-drilling? So D4, one step under drilling, or the half drilling at the last stage. What's your tip for that? As for the under drilling, there are many topics regarding that. Recently, as for the under drilling, 10% or more is not necessary. At the beginning, it looks like it can make bone quality improve, but I don't think so. So one step under drilling is good enough. If primary stability cannot be achieved, I submerge it.
One more question. In lateral approach, membrane tearing can happen often, and depending on the size and location of the tear, the repair method and protocol are different. And Dr. Park, when there is membrane tear, what do you do? Yes, when there is a membrane tear, then first, doing the lateral approach means that there's not enough bone. So when the membrane tears, resorptive membrane. So first, you detach from the bone, and after the detachment, then according to the textbooks, you suture the membrane. But we don't have the thread, and technically it's very difficult, so we don't do that. So we use the resorptive membrane, and using the largest possible membrane, we put it inside and cover the maxillary sinus. And so we create this big pouch in the maxillary sinus, and we don't place the implant then. We place the implant at a later stage. Yes. So in performing the surgery, Dr. Park, so any final thoughts or concluding remarks? Within the time, I tried to complete the procedure, and so I was just intent on finishing it on time, and I was really nervous, but my team helped me out a lot, so thankfully I was able to complete. So I'd like to thank the team support. Thank you for that good surgery, and let's give Dr. Park another round of applause. Good job. And now, From the questioners, I'll be selecting 2 for the best questions. First, from the floor, best question goes to Professor Kim Sun-jun from Ewha Women's University Hospital. Congratulations. And from online, I'd like to recognize the nickname Su Shin. Thank you for asking multiple questions. So congratulations. So thank you. This was it for the live surgery session. Thank you very much. That was a successful live surgery. Thank you, Dr. Park, and thank you, Dr. Oh, for your time. And thank you very much. Another round of applause to the 2 professors. And now we're going to take a break. And the 5th session will begin at 4:20. Please be back at 4:20. After the 5th session, we are going to have a lucky draw. So please stay with us until the end and be the lucky winner. We will see you in a bit. Thank you.
Have you ever experienced the pressure of reoperation because of prosthetic issues such as screw or abutment fracture? Introduce ESR kit designed to solve a variety of prosthetic issues. In case of screw fracture occurs, the fractured screw can be removed by using ESR kit. Connect the SR drill with the fractured screw. After making a hole for drilling on the fractured screw, turn the SR tip counterclockwise and remove the fractured screw. Also, after using the reverse drill, connect the screw holder on the fractured screw. Then, turn the screw holder counterclockwise to remove the fractured screw. In addition to screw fracture, the ESR kit can be used for removing the fractured abutment, repairing damaged thread of implant and screw hex slip. Try ESR kit designed to solve a variety of prosthetic issues. Smart Guide Kit allows clinicians to fabricate a surgical guide without CT scan. Smart Guide is made of thermoplastic resin. Dipping the Smart Guide in the 70 degrees Celsius water for 1 minute. Then, clinicians are able to manipulate the shape of the guide as they desired. When the Smart Guide is shape-shiftable, it is able to extend or reduce its size up to 1 millimeter when the guide pin is connected. Among 4 different types of 3D guides, clinicians are able to select suitable one for clinical case. Also, the Smart Guide enables to maintain the precise drilling path with 7 millimeter sleeves. Smart Guide Kit allows clinicians to fabricate a surgical guide without CT scan. For your implant placement, try Smart Guide Kit now. Have you ever experienced difficulties in finding a right spot for implant placement? Positioning Guide Kit enables clinicians to find both right spot and direction for placing implant without using a surgical stent. Positioning Guide Kit contains both single guides and bridge guides, so clinicians are able to deal with different clinical cases. The single guide is transparent and cylindrical, comes with a diameter of 5 to 10 millimeters. Clinicians are able to put a single guide next to another single guide or close to an adjacent tooth for drilling. The single guide helps clinicians to pinpoint the spot for placement and direction of the implant. The fan-shaped bridge guide enables clinicians to adjust interval from 7 mm up to 12.5 mm.
bridge guide allows clinicians to adjust the interval by the margin of 0.5 millimeter and to drill toward the same direction as previously drilled site with convenience. Positioning guide kit enables clinicians to find both right spot and direction for placing implant without using a surgical stand. Introducing One Fit Abutment, custom designed abutment by Osstem implant. One Fit Abutment has the basic titanium abutment as well as gold-color titanium-coated abutment for production of aesthetic zirconia and ceramic prosthesis. Manufacturing request is simple and convenient with 3 options of impression body, intraoral scan, and design file through an online order system. The product offers various design options for customization based on patient oral cavity and implant placement conditions. Try One Fit Abutment, custom designed abutment by Osstem implants. Great unit chairs designed for dental treatment must be convenient for the clinicians to use, feel comfortable for the patient during treatment, and they should also be easy to clean and maintain. I would like to introduce K5 as both a stylish and convenient unit chair. In case the backrest tilts downwards, the leg rest goes up. The tilting function prevents the patients from slipping down. It is convenient for the clinicians to carry out treatments and provide comfort for the patients to receive treatments. The K5 also has a wireless foot controller designed to offer an even more convenient treatment experience for the clinicians. Handpiece RPM can be easily adjusted by turning the foot pedal left and right, making treatment. The sterile water supply device suppresses formation of bacteria and biofilm in the water line of the unit chair. Always using clean water during treatment makes it much easier to reduce the risk of infections. Let's go over K5's key features again. The patient does not slip downwards thanks to the tilting function. When the backrest tilts downwards, the leg rest goes up. Second, the wireless foot controller makes treatment much more convenient for the clinician. Third, DWCS suppresses bacteria in water line to supply only clean water during treatment. Try the K5, a unit chair designed to add both convenience for the dentist and comfort for the patient. Introducing the SM5, the dental implant surgery engine that provides safe surgery with its accurate torque value and drilling ability. First of all, SM5 provides accurate drilling result thanks to its outstanding chucking force. The implant can be safely placed since the implant is firmly fixed, minimizing unstable vibrations. Moreover, the torque value and rotation speed can be checked with ease on the LCD panel during the surgery. Try the SM5, the surgery engine that has outstanding chucking force and that displays the torque value and rotation speed during surgery. Introducing the 2 key strengths of the SM3, the dental engine that provides strong and stable torque. First, the 20-to-1 gear ratio provides a strong torque of max 80 Newton. Drilling can be easily performed thanks to its strong torque. Second, the SM3 can maintain a constant torque level thanks to its handpiece calibration function. Try the SM3 that can maintain strong and constant torque of 80 Newton. Introducing the upgraded T2 Plus with superior high-resolution imaging, ultra-high-speed scanning, and ultra-low radiation dose feature. The T2 Plus has a 0.05 mm voxel size, which results in superior high-resolution images.
This enables a more accurate diagnosis compared to the T2. With a T2 Plus, patient waiting times can be reduced thanks to a faster scanning speeds compared to the T2. Images are acquired in just 30 seconds. T2 Plus low radiation mode allows for safer scanning with only 22% of the radiation dosage compared to that of the T2. The low radiation mode allows scans for children and pregnant women without any concerns. The T2 Plus offers various field of view sizes for facial imaging, implants, TMJ, endodontic procedures, and more. The T2 Plus allows for customized scanning based on the treatment. The T2 Plus includes convenient and easy-to-use 1-2 software, 1-3, and VSEP. Through consultation, treatment and implant planning will help increase patient acceptance rates. T2 Plus is available in 3 colors: white, blue, and red. You can choose the color that best matches the ambience of your clinic. Introducing the upgraded T2 Plus with clearer images, shorter scanning times, and lower radiation dose. Introducing Digital Film Scanner Fire CR. Provide the pain-free patient experience with a thin film. Get a clearer image with a digital image processing. Fire CR provides you with a clearer image of max 21 line per millimeter. Fire CR enables more accurate and various diagnosis to a variety of cases such as interproximal caries, tartar on teeth, implant placement status, endodontic procedures, etc. Fire CR gives you the more precise and credible result. Fire CR offers 5 sizes image plates for children, adults, bite wing, and occlusion. It is possible to select the plate considering patient's oral cavity and its imaging purpose. Compared to the DR sensors, Fire CR has a thinner image plate to position inside the mouth. And its flexible image plate minimizes foreign body sensation. So the patients can be free from the pain due to the hand pressure during preapical imaging. With only one single plate, it is capable of shooting more than 2,000 images on average through non-contact scanning. Moreover, Fire CR reduces times to repeat rescanning occurred from distortion or movement of the plate during the scanning process. Reduce the pain in patients, improve the quality of the image with Fire CR. With X-ray images alone, it can be very difficult to convince patients since X-ray images don't offer a complete picture of their oral health status. Fortunately, today's product can help you with this very problem. It's the Snap intraoral camera. One of the most important things you need to consider when choosing an intraoral camera is image quality. To help the dentist explain the condition of a patient's teeth and set the correct course of treatment, intraoral cameras need to take clear images inside the patient's mouth, even though it's very dark inside the mouth. Snap uses a 1.3 megapixel sensor, unlike other regular intraoral cameras that top out at 300,000 pixels. That's why it delivers clear HD images that can satisfy everyone. Another important thing of an intraoral camera, which has to take images as quickly as possible, is the focus function. Snap focuses in just 0.3 seconds when you press an image-taking button and snaps images automatically which helps produce clear, in-focus images that accurately show the patient's intraoral condition. Some existing products do have an autofocus function, but they have two separate buttons, each for focusing and image taking. However, Snap has a convenient 2-in-1 button. All you need to do is press the button once to capture fast and in-focus images of the patient's intraoral environment. And finally, an intraoral camera's head and neck line is very important since it has to take images from narrow spaces inside the mouth. Snap has a curved head and slim neckline that gives you a better angle for reaching the teeth when inserting into the mouth, which makes it easier to image not only wisdom teeth that are difficult to shoot, but also female patients and children who have small mouth. From the patient's perspective, this reduces any foreign body sensation and discomfort, while from the dentist's perspective, it reduces stress when imaging the posterior region and makes treatment easier. I was able to actually see which teeth require treatment, and that makes me have trust toward the dentist and left a better impression in my mind. I feel like I want to come back to this dentist in the future, and I'm going to recommend this clinic to my friends and family. Since I saw my teeth with my own eyes, I think I'd be more likely to consent to treatment without hesitating. Intraoral camera Snap helps accurately explain to patients the condition of their oral environment and creates a more credible and trustworthy impression of the dentist in the mind of patients. Introducing Osstem Implants Hysil Plus. Hysil Light Plus is excellent at reproducing fine area. Hysil Light Plus can reproduce 20 micrometer lines without any tears or distortion. The stone model poured from a Hysil Plus impression produces smooth surfaces and separates cleanly. Thus, the user can fabricate accurate and precise prosthetics. Hysil Plus is highly hydrophilic. Hysil Plus has a short intraoral setting time of 2 minutes and 30 seconds. Hysil Plus offers a sufficient working time of 3 minutes and 50 seconds. Hysil Plus has a high elastic recovery ratio of 96.5% or more. Experience Hysil Plus for accurate and precise impression taking. For successful implant surgery, it is important to use a membrane that facilitates creating new bone. Introducing Osstem. Osstem is a collagen membrane that offers outstanding shielding performance and nutrient permeability. These functions contribute to new bone formation. Osstem has a porous structure with cavities smaller than epithelial cells. It serves as a barrier to block epithelial tissue growth while new bone is formed. Therefore, it provides optimal space for the osteogenesis. Osstem also allows nutrients to pass through and facilitates the formation of new bone. Osstem comes in 2 types, hard and soft, as well as 4 different sizes. Thanks to its dual-sided use for all sizes, Osstem can be easily manipulated depending on the surgical sites. Try our Osstem that facilitates the formation of new bone and successful GBR.
I would like to introduce SlowJect Plus. SlowJect Plus is an automatic anesthetic injection device that injects an anesthetic solution at a constant rate. SlowJect Plus has 3 buttons that allow the user to adjust injection rate from low speed to medium speed or high speed. You can also switch between auto and manual modes using SlowJect Plus's one-touch button system. SlowJect Plus only weighs 80 grams, which is similar to a regular syringe. and has a pen-type grip that makes it easier to use when repeated injections of anesthetics is needed. Try using the automatic anesthetic injection device, SlowJet Plus.
Implant prostheses are prone to food infection. Food scrapes stuck between braces are difficult to remove. Removing food scrapes completely from your teeth can be extremely difficult. Use Wapic every day. Thin but powerful jets of water can clean spaces between your teeth thoroughly. You can select between 3 cleaning modes: clean, soft, and massage. You can select any water pressure that feels right for you. Thanks to the massive 320 milliliter water container, you don't have to refill the device with water while you're cleaning your teeth. 99.9% antibacterial silver ion filter keeps the inside of the water container bacteria-free. Once you've brushed your teeth, make sure to finish with Wapic.
임플란트 유명한 게 좋을까?
뭐가 달라도 다르겠죠.
임플란트 세계적인 게 좋을까?
뭐가 달라도 다르겠죠.
치과 의사에게 사랑받는 게 좋을까?
뭐가 달라도 다르겠죠. 오스템 임플란트.
Now we're at the last stretch of Osstem Meeting 2025 Seoul. And before we begin the last session, we have the event. Please sign up for the lucky draw. We are going to draw 6 people, 3 people, third prize, Osstem Dental Family Oral Care Kit, and 2 second prize winners, Butis White Light Dental Curing Light with 2 gels. And final prize goes to 1 person, Samsung Electronics Galaxy Tab S10 Ultra. Please stay with us until the end and be the lucky draw. And after we present with the Achievement Award, we will announce the winners. And we are going to invite back Dr. Bae Jung-in to talk about delivery of full arch provisional prosthesis using Osstem DR abutments. And now we would like to invite the chair, Dr. Kim Kyung-won. Please welcome him with a big hand. Yes, continuing with the morning session, I am back again as chair. And before we begin the last session, Dr. Bae Jung-in, you have done such a wonderful, excellent, stable surgery in the morning. So we were delightfully surprised. And post-op, Dr. Bae has designed the post-op provisional prosthesis using Osstem DR abutment, and he's going to go over the process. And if we have the connection, we will start right away. Dr. Bae, are you ready? Please go ahead.
Let's get started with this session. In the morning, I performed the surgery, and based on the scan data, prosthesis has been fabricated, 2 of them, the lower one and the upper one. The difference between those, this one have only screws visible. This one, around the screws, there's something similar to washer. So can you see the difference? Only screws are visible, but around the screws, some metal insert-like washer is visible. That washer is called link. The prosthesis with the links is to be delivered first into the mouth. Please say ah. So please rise up a little bit. So I'm going to tighten each screw. And so from the center toward the far side, I'm going to tighten little by little. Please open your mouth rather big. And I'm going to hand tighten it a little bit stronger. For a temporary, 16 Newton centimeter of torque is recommended. I think it would be 16 Newton centimeters because I have a pretty strong grip. Please close your mouth, open your mouth, close your mouth. So we didn't take the bite, and now the centric occlusion needs some adaptation, but the first temporary fits pretty well. And let's try the second one, and this one will be taken out. Dr. Bae, why do you make those two? Actually, you need to make one for DR abutments. You can use links, and you don't have to use them. For the temporary, not using the links would be better, but I want to show you how DR would work. So I made those two, but usually you don't use the link. So I made two of them to demonstrate. The second prosthesis is to be delivered, as I said before. This is without the links. So this is the one he will wear when he goes home. Yeah, it is of the same design, but only the inferior connection part is different. Regarding the difference, and I believe you will go over it when you explain DR later. So screws are all tightened, and I'm going to hand tighten them a little bit more. Close your mouth, please. Please lower your head. So the bite was not taken, but the centric occlusion is not deviated. So we check the occlusion. So this is all that I want to show you in the patient's mouth. And I'm not as skilled at the prosthodontics, and it looks fitting very well. So it's not Q&A yet. DR system is going to provide us a brief presentation on DR system for your better understanding of the DR system. After Dr. Pez's presentation, we are going to have a Q&A session taking on and offline questions. Dr. Pez, are you ready? So let me start the lecture. When I did the scanning, the bite was not taken based on the existing temporary. The virtual cross mounting was done. At the top, the bite when temporary was delivered, and on the left below, actually on the right, the bite of the temporary that I fabricated a virtual cross mount. During lunch hour, I designed it over lunch, so it took about 40 minutes. And if you just concentrate on it after taking lunch, it takes only 20 minutes. So the CAD took about 40 minutes, and Osstem DLP Plus and LCD Plus, the printing time was about 25 minutes. Washing and curing about 10 minutes and 15 minutes. Link assembly time 5 minutes, a total 94 minutes. So all Osstem systems, the next day of surgery, usually this is delivered, and you saw the delivered system. Let's have a look at our system in more detail. TSKS type implants are have two types, the cement-free systems. The first, the MUA type. In the prosthesis, the prosthesis is attached as in the link type. The DR system that I used today is a kind of MUA type. What do you think DR means? A digital restoration is abbreviated into DR. So the parts of DR system you may not be familiar with. So this is the picture. So over the placed implant, the base abutment is connected with a 30 Newton centimeter, and a scan body is connected, and it is scanned, and the crown is fabricated. After the scanning, a healing cap would work like a healing abutment. And there are many components for the crown. Below the crown, a link is connected, as I showed you the link before. So it has the hex direction, but it doesn't go into the crown tightly, so it can be falling off. So the gold coupler is used. So below the crown, it is it goes in from the top, and the link and the coupler is tightly connected here, completing the crown. So the lab would make this and deliver that to you. The link has the function of capturing the hex direction. If necessary, non-hex link can be used. This is hex, and this is non-hex links, and the crown is connected to the component below with a 20 Newton centimeter from a clinician after base abutment connection. There's no cement, so easily it can be easily detached, but the crown fabrication is rather complicated. You have to have very sharp eyes. So optimization of this part should be ensured. So summary of parts in the crown, screw and link are connected. So there is actually the milling machine should make that part in detail. And the coupler is engaging with the link and the screw. It prevents the direct screw zirconia contact. Otherwise, there's a friction created between this. So with even 30 Newton centimeters, due to the friction, the preload can be reduced, reducing the efficiency of the screw. With the metal coupling, the metal to metal can be connected, reducing the preload. So lowers the risk of loosening. That is the concept of the development, and how it works in the field is something we need to observe further. The links between the crown and base abutment, it provides hex octa orientation. Of course, there is a non-hex links as well. The base abutment is connected to implant, so it can be fabricated like a tissue level component. So a proposal from a clinician. So inside of this crown, it can be milled, and that can be reproduced by zirconia milling while minimizing areas vulnerable to fracture. And the crown has many components, and it's pretty complex. So development of milling strategies and dedicated tool sets optimized for various zirconia milling systems. So DR system milling center should be found. So then by milling device, the setting need to be developed in the head office, and that information should be provided. When torque is applied here, zirconia or screw fracture should be prevented so that the screw can be designed in that way. That is the most important portion. This link and the crown need to be further developed in terms of the connection. The single crown it can have some rotation or spinning. The base abutment is the base abutment design that distributes the clamping force and occlusal loads more effectively onto zirconia. So there are various variables associated with this. Lastly, the base abutment is one-piece abutment. So we need a strategy to minimize the base abutment loosening. So these are the 4 diameters. Crown would be attached to here. The height is 1.4, and the taper is 10 degrees, and the rest 15 degrees. So if you use 4.0, the taper is 10 degrees, and the rest different. In guided design, the implant angles were designed in less than 14 degrees. The diameter is 3.4, so it's narrower than the implanted diameter. So when it's connected, it is not interfering with bone. The link connection, it's a 2.1 millimeter hex, 15-degree taper, so internal. So the crown connection is external. So this is kind of hybrid connection. So if you use a DR, a full mouth temporary can be simplified. What is simplified? This is non-hex one-piece type, so bone profile is not necessary. So as you saw, a connection is very simple. If you use a stock abutment, the preparation can be needed, but it is not needed. If you use a custom abutment, the design should be made. So the CAD process is made very simple. And I made this just 40 minutes, and the custom abutment would require much more time. So the path compensation, 20 degrees to 30 degrees in the full arch. It is suitable for full arch splinted screw type provisional bridge. So a full arch zirconia splinted would be challenging, but for temporary provisional, this can work very well. Link-free design of provisional prosthesis can be made, so that's what I delivered. This is simple, and this is cement-free, which is a big advantage. On the left, this is designed with a link, and this is without link. In the design without link, the internal thickness can be made thicker. This is better for professionals. So the abutment and crown work like a non-hex external. In my view, zirconia, multiple cases, this structure may be applied, but this is a screw type, so this is not good for prefabricated temporary before surgery. Cementation type should be used in that case. So if you use this for full mouth procedure, provisional and the final abutment prosthesis can be made simple. So this is using the general abutments in the provisional. Going to final, various components need to be engaged and disengaged, so that causes pain to patients. But with the DR system, immediate provisional prosthesis do not need to be disengaged, and that can be used for. This can be used without loosening the abutments. So that has been turned into the final prosthesis interior and posterior regions. So from surgery to final with one DR abutment. So they don't need to be disengaged, and they can be used as a temporary abutment, the healing cap, and smart pack, and the final abutment. So it simplifies workflow for the clinician and greater comfort for the patient. Of course, abutments sometimes need to be exchanged. DR abutment in the same workflow, provisional, anterior, and posterior region. The same here, provisional, anterior, and posterior region using DR. This is not DR, but multi-unit type, but workflow is the same. And so full mouth final explanation has been delivered. Thank you for your listening. Thank you. Actually, we are quite delayed, so we will just take one question from the audience. No question from the floor, so online question. The question is, I believe you explained it briefly. What is the advantages and disadvantages of a link? And you said you don't need to use a link. Why do you have to use a link in any case? So it orients the octa orientation. In a single link should be used. Non-hex octa should be used for multiple cases. So when you use a link, it is made of resin, so the internal structure can be thinned. In zirconia, it's okay, but for provisional purpose, non-link structure is used. So link is not used. For the final, the link should be there. Yes, for the final, if you go for the final, the implant should be divided into 3 segments, and all will be in one piece, and links will be used for this patient. There are many questions, but due to constraint of time, this finishes the presentation. Final temporary and the wonderful presentation have been described by Dr. Bae. Please give him a big round of applause. Thank you.
Yes, from the morning session, thank you, Dr. Bae, for the live surgery, and thank you, Dr. Kim, for the moderator role. And now we have final 2 lectures waiting for us. And we will invite the next chair from the College of Dentistry, Kyung University, Professor Park Ki-ho. Professor Park Ki-ho has graduated from Kyung University's College of Dentistry, earned a PhD degree in the same graduate college, is the professor of Department of Orthodontics at College of Dentistry, Kyung University, chief of Department of Orthodontics at the same school, director of Legal Affairs, Korean Association of Orthodontists, and Secretary General of Korean Digital Orthodontists Association. Nice to meet you, Professor Park. Yes, hello everyone. I am Park Ki-ho from Orthodontics Department at Kyung University, and we have 2 presenters and 1 hour left. And in the 5th session, the speaker that will kick things off, we have 2 speakers, and the first presenter is from Gangnam Severance Yonsei University Hospital, Dr. Judy Jurang Chung, and she is going to talk about orthodontists' adaptation diary on clear aligners. And so let's welcome her with a big hand. Hello everyone, I am from Gangnam Severance Yonsei University, Jeongjuryong Judy, and in doing clear aligners, I'd like to talk about the history of adaptation, and this is a very good opportunity for me, thank you. And I think my adaptation diary will be of help, and with this I'd like to start my lecture. And clear aligners, how I got started, I had already used many devices, and whether they're clear or aesthetically pleasing, I don't think they were, I was doing lingual, and so I wanted something more clearer and more prettier. And in using them, there was no reason why they did not serve their purposes. And through research, there were a lot of effects. So this had been confirmed. So when I used them, the only difference was this required compliance from the patients or not, or whether it was a non-compliant system. And so I compared the clear aligners vis-a-vis the traditional tools. Compliance system requires compliance from the patients, and non-compliant system, everything would be on me. So initially when I adopted and used the clear aligners, I have to go back to the earlier slide, and so it just went off. And the earlier devices, the initial devices, median screw, or so, the tools for children, they require compliance, so they are compliant systems. And so it had to be used by the children, and the clear aligners were introduced, and it could also set the tooth alignment. So there was this need, and the usage became more active. So it was in 2019. And so for the younger patients, it was not for aesthetic purposes, but I used it for their face. So children and how it transitioned to the adults, I'd like to go over that. And of course, there are different types, and I'm not going to talk about pros and cons. And ultimately, we know the pros and cons, and we have to, be very faithful to the treatment. And 8-year-old, and there was crowding, there was no canine spacing, crossbite, and the midline was different every time. And what we need to treat is, we cannot do the tooth arrangement because of crowding. there's the lateral crossbite, and we don't have the stable occlusion. So that should be the treatment that we focus on initially. This is classified class 2, but it's very early stage, and we have to intervene early, and the tooth arrangement is not the focus. And to get the occlusion, we have to get enough space in the arch, and like medial screw, maybe we could expand every week, and there could be this expansion, or it could be attached orally and could expand in a very short period of time. And the difference between the two is the timing and how the orthodontists think, and there could be different opinions. But ultimately, with expansion, the front teeth will interfere, so there needs some arrangement. So even if it's not the permanent teeth, we have to have the system for the tooth arrangement. And so with the adoption of the aligner, it can also help in certain expansion. And after expansion, we could help with the tooth arrangement. So the devices could be replaced with the clear aligners, and we thought, it could be a good option. And so can this be used for expansion? In the children, it is useful, but more than expected, we have to have the setting so that it can be of higher utility. So expansion, pushing to RPM 2 and number 4, it's just new, but expand by 5 millimeters. So it's set to 60, and we started with the expansion, and in 7 to 8 months with compliance, we expanded, and front teeth interference, and after we are done, we got enough space, and there was expansion, but unexpectedly, number 3 came down, and number 4, there is extrusion, number 5 came out, and number 6 came out. So we have this mixed condition, and of course expansion is visible, so you could be happy and you could do the interim assessment. The green is done well, the yellow color is not very good, so you could do the interim check. But the initial setting, was that achieved? And that is not always the case. So let's look at the definition. For example, in 42 millimeters, and it came to 44. So it expanded by 2.3 millimeters. That is the outcome. So there was expansion, and people would say that. But I wanted to expand to 46, but it was only 55% of that. And predictability was low, or reliability was low. Some people would say that. Or comprehensively, some people would say we have achieved only half of the expansion, so let's do overcorrection and try to expand. And some people could interpret it that way. So depending on the expression, the nuance is very different. But I think I'm leaning toward overcorrection. And when you have outcome, this is deemed effective. But it's not as much as we had intended, and it's because of the tooth arrangement. So it's not that we have not gotten that, but we have these extrusions. And from 2 to 2, if we have enough space, then I would have been content. But since I'm an orthodontist, the number 3 extrusion was not pretty, and number 5 began to come out. And I want to, I'm obsessed with the tooth arrangement. So I was not able to end it, and I had to continue and do the follow-up. And I found myself in this trap. And my initial goal was not that I wanted to end it, but I could not really bring this treatment to an end. So that is the issue. So for 18 months, since there's the device, and because you can continue to use it, so, this was complete with the tooth arrangement, and the smile was okay, the teeth were okay, and the growth was very fair. And you could have ended this with the treatments, so it belonged to that category. But initial goal was achieved, but because of the extrusion, I could not discontinue the treatment. The 10-year-old, it's not the end until the end because the growth peak has not been reached. So depending on what we do and how well we do, there could be some more work to do. And there are many more teeth to be arranged. But in the beginning, I guess I was obsessed too much. So if you hurry too much or if you want to hold on to it too long and try to do well, you should kind of give up on that. And so this is a 7-year-old and there was interference and there needed to be early intervention and the bracket was used. And if that works, then we could stop the treatment. And it was several months and I was doing follow-up and then number 3 came out, number 4 and number 5. And the arrangement was mixed. And, I guess, you have to say when to stop. Even if you have a very good occlusion, the lip could protrude and you could extract the tooth to get the arrangement. And we have more of those patients in our clinical setting. So this patient, we did what we could do and then discontinued. Clear aligners for kids, if they're used, then the indication should be clear and our goal should be also clear. And we should be able to stop when it is time to stop. And as for my patients, there was a liner used for the first treatment and it transitioned to secondary and it was about 12.8%. Those who used the clear aligners, it was very effective, but they wanted to come to me for a secondary treatment and it was about 10% of the patients. So even if it's good, fixed appliance still has room. So nonetheless, but what is useful. So it's in this case, AP control, growth modification. So there's lip incompetence, and for early intervention, that would be the indication. So there's need for early intervention. If the lips cannot close, then you have more issues. So it's not a matter of good occlusion or not. The mouth should be able to close, and the devices that we usually use are growth modification devices. And we use twin block for the top end growth, and forward growth was promoted with this device. And so in the short period of time, we came up with this flat profile and the mouth was able to close. And we looked at the differential of the mandible, of how much it grew compared to maxilla. But we all know as orthodontists, we want the skeletal effect, but it has the dental reaction. The jaw has to protrude and maxillar, it had the lingual tipping, and we have to forward progress the mandible and there's flaring, and so we have these dental reactions. It looks like we have good occlusion, but we don't get the skeletal effect 100%, and we have to block the maxillar and also the flaring of the mandible. We cannot control the teeth with our devices, so we know these issues, but we still use them. And how can we forward the mandible? We have these clear aligners, so functionally they are working, but posterior and anterior, the teeth angulation, can they be achieved? So that's our expectation, and the academic papers, they began to come out, and in many cases the posterior angle, you can flare them if you want, and for a mandible you could linger, so you could maintain the forward state or pre and post depending on the setting. Depending on which digital setting you have, you could adjust accordingly. So in that sense, the functional devices that used to have the reactions, we now have a method to prevent them. And the occlusion for anterior was very good, and the mouth could close, but now the growth peak was coming, and we have to prevent the angulation of the anterior, and so clear aligner was used. And so it was worn at night, and this was complete. And we checked the angle of the teeth and maxillar anterior. We let the flaring, and for the lower jaw, what we used to know, we adjusted the angulation a bit, and this is a very good benefit of the device. So for the young patients, the value of using the clear aligners is you can now do new things that was not done before. So dental alveolar reaction could be prevented. So the anterior posterior side effects could be prevented using the clear aligners. And now let's move to the adolescents. Number 7 extruded, and as you can see, number 13, it's cross-bite. So functionally, there's prematurity, and the midline is tilted to the right, and he still has some more to grow. But there was not much growth. But looking at the age of the teeth, it's not has not reached adulthood, and there are teeth in extrusion. And the profile is fair, and it does not seem that there will be much more growth. So in this state, we could do the tooth arrangement and remove the interference of the front teeth. And initially, expansion outcome had come out very well. And, interference, or if there is not enough room, expansion. And we could flatten the profile even more. So we adjusted the torque and expansion, alignment, torque control. For all the teeth that are out, it will have been done well. And if it's not the case, then I have done the setting wrong. But looking at number 5, for the teeth that had been extruded fully, the rotation control is difficult. But if the number 5 had not been extruded fully, then it will be difficult. In the aligners, it's very difficult. So if you start early and complete with number 5, then you cannot do that. So you continue with the treatment. And so after refinement and 15 months have passed, and looking at the left-hand side, number 5 is still in the same state. And to control that, I refined the aligners several times, but I knew it was not going to work. So, it was half finished. And after natural extrusion, if need be, then I could fix the number 5, and 3 years have passed, and was a college student, and there is good occlusion, but rotation was still not fixed. And so when the teeth are all out, they can function. So we have no doubt about that. But clinically, or the newly erupted teeth, there are some difficulties for the clear aligners. So number 5 and number 7 control, it could be working against them. So you could make compensation with that knowledge, and it should not prevent you from using that, but you could have these issues. And looking at the adult, and likewise cross-bite laterally, and there is recession seen in the patient, and the coloration of the teeth. And at a first glance, you need the arrangement to be done. And the teeth, not any major issues, the coloration, but the teeth do not have any medical conditions. It's an adult. And class 3 flat profile. The mouth could protrude, and soft tissue looks fair, but there is cross-bite and deviation is there. The maxilla is narrower than the mandible. And 21-year-old male, if the maxilla is you have to widen or narrow either. We cannot do narrow, so we could do MARPE, or we could use the mini screw on the adult male. And MARP cannot solve all the problems on adults for male. For over 20 years, there is 30 to 40% failure rate. So we want to expand the arch. We could expand the teeth, but suture is not separated. The bone expansion is not something that we can expect from everyone. And to confirm you cannot do anything, you have to rely on predictability. So you can only pray that it will work, but it will not work on everyone. And in the male adult, what we can see arbitrarily is look at CBCT and see the degree of suture separation and stage D. It's at stage D maturation, and we don't. And looking at the rendered image, we could look at the ZMM suture stage. And if you have fine lines, then, we can predict that it is possible. But if you don't see that, there's no suture separation. So you can kind of make that prediction. So in that sense, this may not be feasible. So tooth bone type for MARP, then we will have recession and expansion. So clear aligners, he wanted it. And so for this patient, we did the expansion first. And so yes, expansion was not achieved. And the teeth did not expand, and the teeth bone did not expand. And with that knowledge, so we needed to do something else. And aligner is used for the upper jaw. The suture separation, the bone separation was not achieved, but we did the clean check, and class 3 midline was misaligned and pushing back to posterior. And in the maxilla, it was effective, the treatment. And in the mandible, we have to have good anchorage, and mini screw was added to the regimen. And the aligned position, if we are to use 38, 3 millimeters in number 3 was set, and 38 were all used. And 8 months later, the maxilla, it seems like there is expansion, and it seems like there is arrangement but there was a poor occlusion, and so we can check. After the full session, there was the expansion, and there was a significant expansion. It was not, the suture was separated. And looking at the numerics, there is 80% efficiency, but 7 millimeters in the premolars, we can say that it has a lot of outcome. And even if I put in high torque, we could not get the intended effect, and the occlusion was not satisfactory. So that was number 1. And looking at mandible, it was not satisfactory, and I did not induce expansion, but it did not go toward the posterior, and this was not what I'd expected, and the movement did not occur. So it could be on me or it could be on the patient. So it's either or. And, it could be on me. And for the maxilla, I achieved my intended purpose, and I couldn't do it on the mandible. So I focused on mandible, and I worked on distalization, and I made a setting, and elastics reinforcement was also done. And if possible, you have to set the midline, because this is class 3. And if you want, that was the setting for moving at least 1 millimeter, and there will be mini screw used. And second clean check was complete, and we have stable occlusion. And after that, check the anteriors, and we see that there's a bit of a gap. And second refinement was done boldly, and elastics was also used, and we asked for compliance. And 24 months later, we completed the occlusion. So this was the end of the treatment. And profile itself was very good, so there was no reason to change. And it was just, we wanted to get good treatment outcome. And looking at the Ceph, you don't see much difference. But from this side, lingual side, there was movement, but the lingual occlusion and the overall occlusion was very fair. And the amount of expansion at the crown level or at the root level, if there is bone expansion, then everything would have been convenient. But the crown level movement, there was bodily expansion. So second and third refinement was done with that in mind. So with not enough flaring, we could get the right expansion volume. And as for the mandible, what we wanted is class 3 to become to class 1. So we wanted bodily movement. And so blue is initial and red is final. And in the teens, number 33, number 34, and 35, it looks like translation. There is the bodily movement. And 46 and 47, we had the tip back. So we had the upright, and it looks like extrusion. And number 30, there was good translation. So because of this, AP, in doing the AP movement, should we just move with the crown portion? So looking at this case alone, there are diverse movements that were implemented. And let's look at gingival recession. On the left, the teens, I took it from the scanner, left side clinical picture. So overall, there was significant recession, and there were teeth showing early signs of recession. So we took this into consideration. And traditionally, we would have, just, said okay, but we look at the recession in the scanner. Number 12, it has nothing to do with expansion, but we see that there is recession. And then number 13, maintenance, and number 14, sustain, and number 24, there was also recession. 24, in the initial, we only had the transparent gingiva, but let's say you did MMRP, or will you not get this much recession? You could get more recession. So this is a good thing that we can confirm this. And white spot lesions. So looking at this, we see that there's not much change, and there's good lingual maintenance. So clear aligners for adults. What is the downside? In terms of teeth movement, you can achieve the intended results, and 3D analysis is now feasible. So even if you don't intend it, you have to analyze the outcome. So it has a very good training purpose, and it gives me good feedback. But as a standard, it's very difficult to present the procedure regimen. It's difficult to do it step by step. So you must do it in a more creative way and look at the reaction and then adjust the sequence accordingly. And we call it customized 3D digital orthodontics in a good way. If you can standardize the sequences, then it's no longer customized. But the world is changing, the patients are changing, my techniques are becoming more mature. So you can play more creatively. So, people consider this favorably. So that in itself is not a bad thing. And doing these treatments, did my worldview change? Did my philosophy change? Aesthetics, hygiene, control, mastication. It's favorable and customized. It's on the introduction page of the aligners in Osstem website. But if you don't use it, then you could say that. But if you're actually using it, you could say something otherwise. So I looked at this. And so if you do it digitally, every trace remains. So you can analyze even if you don't want. So don't you get proximal caries? This is a journal I wrote on all my patients, and you can see it from the scans. So all the patients, all 180, in 6 months into the treatment, there were higher incidences. It's not as serious in needing treatment. The caries that were not shown in the x-rays, we see these white shines. And so who is at more risk? It does not matter the aligner type. So those who have the metal brackets, who are using the aligners, the tendency was similar throughout, and one factor was the age, whether the patient is really young or if there were many caries in the initial visit. So it's not the type of device that affects the caries. But nonetheless, up until now, we to analyze. So like if there are 3 or 4 caries increasing in 6 months, it was more happening in the fixed appliances. But it did not really have a significant difference on the proximal caries, at least in my patients. And you get to see the surface and you see these crease lines, and they all remain as digital evidence. And after removing the brackets, you're worried about the increase in crease lines. And so I looked at everything, and the prevalence was not affected. So that was my conclusion. And basically, because of the attachment, the high-speed grinding could have effect. So it's not a matter of attaching or detaching the brackets because, that would be a misleading conclusion. So what is different? What is the big difference? If I get the question, I answer compliance versus non-compliance. So I cannot say this device is better or superior than the other one because the evidence does not point in that direction. I guess I should conclude, or can I talk about my last case? No, your time is up. So in that case, what I showed you was, in using the device of, whether it can work or not, I think that time has passed. Of course, there is utility, and this is a device that I like, and clear aligners will become prevalent. But whether it's the youth or it's in the elder population, we have to analyze the evidence and come up with better ways. So with that, I'd like to conclude. Thank you. Thank you very much, Professor Jung. You talked about the adaptation journal of different patients groups in different ages. And after the next presentation, we will invite questions.
Next presentation will be delivered by Dr. Choi Hyung-ju from Seoul Chikkwa Dental Clinic. The title is Pathway to Effective Clear Aligner Therapy. Please welcome him with a big round of applause. Good afternoon. My name is Choi Hyung-ju, as was introduced. So crowding is seen in the photo, and I'm thinking about using a clear aligner to correct it. So this is a tip for effective clear aligner therapy. Predictable cases with clear aligners and unpredictable cases. First, the introduction. For effective ortho treatment, we had to do good wire bending, and we had to control the wires by hand. And after that, straight appliance. A tip tuck is included in the bracket. And when I was a student, I thought night I would finish ortho treatment. So bracket that was developed quite well. So those who attach bracket well generated good results, but it was not necessarily so. Still, some controls need to be done. And we moved on to clear aligner. And if we think about what we need in this age, treatment plan and compliance from patients should be induced. So we are in a different era. So ortho trend is different. So this is something we can challenge. So reactive treatment was done when you use the bracket. But now, proactive treatment need to be delivered. When patient comes, treatment plan should be established from start to end. As Professor Chung said, all plans should be established first. Some correction can be made in the middle, but when appliances are all fabricated, it is not really possible to change the plan. And if you go abroad or go home, you still need to work. It's not necessarily good, but that is the age we live in. This is a recent paper. Clear aligners on what movement works well and what not. The predictability of tooth movement. And when a paper is to be finished, it takes 2 or 3 years to write it, and that should be reviewed and published. And if it comes out this year, it can be already out of date. So it is important to look at the recent paper, another paper. So gurus of clear aligners got together, and they looked at the 25 statements, whether they agree with the statements through discussion. Generally, those who have dental clinic and those who use clear aligners, opinions are reflected. Clear aligner therapy is abbreviated into CAT. Highly predictable cases with the CAT, spacing, dental expansion, and sequential distalization. So you distalize the posterior tooth one by one to make space. The clear aligner is known to be weak in extraction site, and tipping it can work well with the CAT, and molar intrusion can work intentional or unintentional. Unpredictable with the CAT, low compliance. It doesn't work at all if there is no compliance. And by maxillary protrusion without crowding. So due to the characteristics of the appliance, in adult case would be difficult too. The collapsed teeth, if you move in the collapsed direction, more collapse can occur. So more auxiliary devices or appliances need to be used. A rotation of canine and premolar would not work. So it looks a very easy patient. There's a spacing. The posterior occlusion is solid, and I thought it would be easy. And if you look at the treatment plan, there's no movement in the posterior movement. So no buttons on the mandible, but with the buttons on the maxilla, there's hardly any movement. So you can say the treatment would go very well. The patient then had to go abroad to study, and so I proceeded with the treatment. At 9 months, many improvements were made, but I wasn't aware at this stage. The patient, if you look at 16 and 26 of the patient, the treatment was completed and spaces were closed. 16 and 26, you can see the mesially tipped teeth. It was not intended, and it was not to be moved in the plan. But what happened? Class 3 patient, so upper anteriors need to be prevented from tipping. So torque control was made, but still that happened. Panoramas, mesial tip is created. So when the patient comes back, more correction will be made. The aligner length shortens, so force is also applied to anterior and posterior region mesially. So if we know about this, what should we do? A similar patient, similar age, and the patient also has spacing. So I wanted to apply new technique, learning from the mistake before. So in the treatment planning, tip back, slight tip back, slight distal movement of posterior region. So action reaction was considered. So tip back was given. So in order to prevent the bite going deeper, the anterior deep bite was created, and then mandibular roots were also moved. This is not a desirable movement in the plan, but this is the reflection of what I learned from the previous case. So this was the plan, and what happened at 5 months, things went well. It was finished 11 months. The collapsing of posterior teeth are not visible. It's not open bite. So before and after treatment plan, before the plan and after the plan, and the treatment plan was based on the force-driven setup. On the posterior teeth, it is the tipping and intentional open bite and root lingual torque to lower anteriors. So there's some discrepancy, but this is what happened. Clear aligners advantage is it's based on the AI, and the manufacturer would provide all the solution. Beautiful setup is not the goal. Ugly setup should be made to get beautiful results. What we see during treatment is not what you get. Force-driven versus shape-driven. You need to think about this. Art and science is the dentistry, so reality and ideals coexist. So that gives us headache. So based on that, I thought about clinically favorable cases for clear aligner. You need to use pushing force expansion, molar distalization in the upper and lower, and vertical control. Compared to brackets, amazing results can be achieved with the clear aligners. So let me introduce the cases. He was a soldier. Soldiers cannot get ortho treatment, but these days it's different, that they can take vacation to get treatment, but emergencies can occur. But clear aligners are available, so if the compliance is good, if they can work, there's a crowding, severe crowding, and extraction can be considered to make the determination. Cephalon and panorama photos need to be looked at. Non-extraction is something we can use better with the clear aligners. So non-extraction, arch expansion, and molar distalization was the plan. So the posterior molar class 1, so it can be distalized. So all these was considered possible. The treatment plan, what I want to say is that if you look at the occlusal plane in the maxilla, number 7 goes first. You can expand all at once, but it will reduce the number of appliances, and 62 appliances were used, but it will be less predictable. And I believe that the soldier would wear it quite diligently, as he's nothing to do in the military. So there's a lot of alliances that to be used, and you may have seen this, but at month 7, he couldn't visit because he was in the military. And if they don't fit, I don't really have anything to give him. So at 14 months, there's some space in the posterior region. The canine is okay. New appliance was provided. And so it was finished at 1 year and 10 months with 9 visits. For this result, so with the brackets, it works. But this is the characteristics of clear aligners. Sequential distalization. 2020 paper. Class 2 malocclusion correction with Invisalign. Is it possible? And the people said it's wishful thinking. If you look at the paper, I wanted to give a challenge to it. And many orthodontists said that they can do it, but the paper said to the contrary. On the full class 2, you can observe, and sequential distalization was done. Here, the space is created here. And I was delighted to see that. And sometimes I lose the space, and I learned from it. Screws were placed, mini screws. And then the 2 hang elastics in the aligners, so you can reinforce the anchor to distalize the molars. So this 1 year and 2 months, it was finalized at month 20. Class 1 canine relation is achieved. Sequential distalization is used quite a lot as an alternative to extraction, and this is what the patients prefer. Sometimes it works, sometimes not. Professor Chung said it would be patient's fault or my fault. And sometimes they blame the manufacturer and they call the manufacturers. Sequential distalization, that doesn't work if you aim for large movement. Up to 3 millimeters, clinically it's achievable. And remaining key correction through bite jump using elastics. Anchorage should be reinforced. Mini screws need to be placed, or you need to use elastics. The distalized the molars should not be mesialized. So. High level of compliance, and I asked the patient whether you can wear it 20 hours a day, and if you eat often, that wouldn't work. A large number of stages, so basically it's 50 or 60 appliances, so it takes a long time, and I emphasize the compliance on the part of the patients. So there's a time where the first molar would achieve class 1. So assessment at the stage of achieving class 1 molar should be made. If that doesn't work at that time, you need to start again. Initial, so you can see what happens on the left side. And this is not something feasible, but I had to do this anyway under the circumstances. Number 6, class 2, but this is just a picture, and I need to make it in reality, one by one, the tooth is distalized, and the anchor was made. If you look at here, a mini screw was placed and connected to number 6. After distalization of number 6, indirect anchorage was made to prevent it from moving the other direction. So if I say class 2, sequential distalization can be applied, but for growing patient, it may not be so. Whenever I see this patient, I smile, and our staff was wondering why. The patient had a deep bite and the class 2 growing. I didn't use a distalization, but used the bite jump. The bite jump, this is just drawing whether that can be applicable to the clinic. There's uncertainty. So only 17 appliances were used. So it takes just 4 months, and if it doesn't work, I would go for distalization. What I emphasize here is that the curve of speed was quite severe. This is from the company, but the ugly setup was made by me. After 3 months of treatment, the deep bite has disappeared quite a lot, and all 17 were used. You can understand why I laughed or smiled. This is very speedy results, not achievable with the brackets. The reverse curve of speed, it was quite excessive, and it was finished like this. It took less than a year. It took about a year. So superimposition and growing helped, and the appliances worked well on the patient. Distalization versus bite jump. When there's crowding, bite jump would not work very well, and growing versus non-growing patient, available space distal to the second molar. Functional factor and number of appliances needed to be considered. This is advantage with the vertical problems as well. Deep bite patient. It is difficult to attach brackets to the mandible, and then even you attach them, the bite should be raised. So if with the aligners, the intrusion can be achieved quite well. A lot of intrusion should be made. 6 anteriors could be intruded, depending on the setup by the lab technician. But I intruded 4 anteriors, and canines were left alone, and I alternate sequentially. That's something I wanted to do. So treatment plan can be controlled by a surgeon. So this is what I set up. Even though the company sent me this, I adjusted it to make it more open bite. So when that was made, is it going to be open bite or overbite? So 10 were used out of 36, and 28 out of 36. The bite has opened, improved, and this is the final 10 months. The midline is deviated. I wanted to do it again, but I didn't pay attention to midline, so it was a predictable thing, but I wanted to work again, but the patient was quite satisfied. Treatment in a short period of time, and this may look similar, but you will realize this is a challenging case, especially with the clear aligners. Here, if you look at upper anteriors, you can see the jumping movement. It is not something provided by the company. I ordered it this way for intrusion. the root apex goes into bone, and it can touch the cortical bone, and with force it would move. So intrusion with the proclination or proclination first by intrusion, and the space closing should be done too. So intrusion in 3 steps, space closing in about 2 stages. So like we use a ChatGPT, if we explain what we want in detail, the company provides the solution. At 6 months, the effect is very good. This is not you need to do. It's not something that you should do, but this is a good example, so you can consider this. To intrude the upper anteriors, proclination should be made, and the roots should be in bone. 32-year-old patient. The anterior teeth are worn down, and the patient has open bite, not a long time ago, but maybe the patient needed jaw surgery. But if you look at number 8, it is placed very deep. So the open bite patient, to address the problem, FMA should be rotated in a counterclock direction, the mandible. With the brackets, it's very difficult. But if you use the clear aligners in the lower posterior region, intentionally, the attachments need to be ordered. Without resin in the attachments, the aligners will be protruded. And like a bite ramp or bite turbo, the patient is instructed to bite on it, and before moving on to the next, and it gives muscle training to the patient. And it also provides intrusion force. Was I confident about that? I wasn't. But I believed some improvement would be achieved. So it worked like this. This movement was ordered. Only 20 appliances per week. Then it takes 5 months, and I tried it for 7 months. If it doesn't work, I need to find another solution. So 9 out of 20 were worn by the patient. It's just aligners. Up and down elastic was used to intrude the posterior teeth with the reinforced anchor. So I don't take photos too frequently, but this improved quite well, 15 out of 20. So the mandible rotated in a counterclock direction, and treatment went well, and the goal was achieved. And this cannot be achieved with brackets. So class 2, and the fixed retainer was used. For open bite, clear aligner is good to correct it, but compliance is important. And when you intrude the posterior teeth, are you going to do it all at once, or number 7 first and number 6 next, or number 7 intrusion all finish it first and go to number 6 for full intrusion, or just a little intrusion in number 7 and number 6, and then go back to number 7. So he has a very narrow arch in skeletal class 2 tendency, and then the class 1. There was some deep bite, and if brackets are used, the soldier would be discouraged. So I told him the clear aligners can be the answer because he doesn't have to visit me so often. This was the initial state. And at 5 months, the patient was wearing the aligners quite diligently, at 11 months, and the patient said, wasn't it too quick? But I said, there's nothing more to do, and I want to say expansion worked pretty well, and special efforts were made before, as Professor Chung showed, how many millimeters need to be expanded. For brackets, we don't really think about it, and if some results come, we make a decision on rather passively looking at the results. But here we need to think about how much expansion should we need to make, and how much crowns should be made. So the treatment on this patient went pretty smoothly after struggling with all those stuff with the previous patients, and I gained confidence, and I want to challenge a more complex case. The patient was to leave Korea to study. She was accepted in a famous university in the United States, and she knows ortho treatment is excellent in Korea. Extraction versus non-extraction should be determined. Originally, the plan was to extract, but the patient should leave the country, so I decided on non-extraction. So this is the treatment plan. This is the last treatment plan, but in the previous plan, 8 millimeter expansion should be achieved if we do not want to do extraction. So expander should be, skeletal expander should be used for that. So like the Red Sea separating from each other, so communicating with the CAD designer in the United States in English, we made this. So I was afraid that this was the first time that I do this, but this is Atos from Osstem. Many screws are included in Atos, so you don't need to apply force on teeth, so it goes well with clear aligners. So number 20 appliance. So 36 appliance was used, and she left the country, and I gave her some instructions to wear the appliances. This is 56 out of 61 CBCT. Number 12, the torque was not desirable, so I made some control on that. And she left the country to study, and she'll come back. So I gave you good cases, but if compliance is not good, no matter how hard we try, it doesn't work. And frequent dietary intakers, those who post the food on the Insta, it wouldn't work. So if this is your patient, number 4 or 5 would be extracted, and in the quadrant 3. So number 4 or 5. So let's think about which one to extract out of number 4 and 5. Number 4, the lingual one needs to be extracted, but with the brackets, that is the choice. But with aligner, if that is to be extracted, number 3 and number 5 roots are quite diverged. So number 5 extraction was a good choice, but just like a bracket, I extracted number 4 because I didn't know better. So even though those were uprighted, that's something you need to be careful, and you should not push to the collapsed direction. So this can be used to recover. So a force is applied from one direction, and if you do this, why you attempt to use a clear aligner? But this is used when something did not go as planned. The roots, number 36, the root is moving. With up and down elastics, the roots are not supposed to move, but the long hook on the elastic is used. Then the rotation is created. So I showed you many cases. In conclusion, there are highly predictable cases with the CAT. Advancement of the technology, and if something do not go well, sequential movement or alternative movement of teeth or delayed movement or attachments can be used to resolve the situation. This is a severe mandibular crowding, and when I send an order, first expansion would be made, and then the lower anterior would be arranged. If I don't specify that in the order, everything will be made so that everything can be done all at once. So this is the last slide. When there's a scissor bite, the scissor bite, if you move the teeth, you need to try to avoid the collision. So intrusion should be done first. So if you specify that in your order, that will work well. Thank you.
Thank you to professors. Thank you for your wonderful presentations. And now, Dr. Chang and Dr. Choi, you're both on stage. And now, since we have heard from their lectures, we are going to have a Q&A. And we'll first take questions from the floor. If you have a question, please raise your hand. Professor Hwang Chung-ju, please ask your question. Yes, hello, I am Hwang Chung-ju. I have one question each. First to Professor Jung Ju-ryung. In the youth orthodontic treatment, you talk about the function, but nowadays it seems like even if there are issues with the growth, clear aligners are prescribed. So what should be the indication for the clear aligners? And Dr. Choi, you design yourself, so you do get the results. But I think this is all about overcorrection. So I don't think it's good to have that overcorrection concept in your design. So yes, one question for each of you. Should I go first? Yes. Well, since I'm an orthodontist, phase 2, I want to, pursue as efficient treatment as possible. But when I do recommend early intervention, if there is interference or if there is lip incompetence, if there are clear functional issues, then I put that as priority. And if it's a matter of, lack of space for the teeth arrangement, they come to me. But, you can worry about the teeth later after all of the teeth had come out, and you could even do the expansion in adult. So if you have lip incompetence, then it's going to be AP correction. And if there's anterior interference, and you need to shift the lower jaw or you need to forward it. And if you have such issues, then you have to intervene. And I think you need to have that treatment for those cases. And if they are not emergency, then, you could take into consideration the growth period. And so you have to think about, whether it is really necessary. And if it is necessary, if you could delay the treatment later, or if there is a timely treatment that you need to do it now, then you can balance it out.
For overcorrection, as I said before, there's no set rule. So how much do we need to do? Does it have to be done? So it's controversial. And when I talk to other dentists, some say they never do it, and some do, many of them. So the criteria is based on your experience. You need to review your treatment, and you need to reflect on what you have done. Manufacturers or others do not have set rules for the deep bite, rather than ideal. For the deep bite case, overbite is set only 0 millimeters or 0.5 for open bite, and then weak closing of a posterior region and strong closing of anterior region would be attempted. As Professor Chung said, MA, in the upper anterior angle should be increased, and considering action-reaction. So I believe a better world would be coming on us after research in academia. Do you have any other questions?
Before we go on to the online questions, I have a question myself, Professor Chung, for the cases in growth period. The initial plan was, to improve prematurity, and then, number 3 eruption and number 5 eruption, and the treatment period it was extended. So initially, you had done the scan before the eruption. So after number 3 and number 5 eruptions, you had to do scans. So every time there is tooth eruption, do you do the additional scanning? If there is expectation of eruption, so with the eruptions predicted, this is presented. So unless it's very unexpected, you don't scan every time, But the most frequent scan was for number 5 in the maxilla. And the treatment is going on, whereas expansion is also going. With dental expansion, the tooth will erupt, and there are, certain teeth that get in the way. So if we don't do the expansion, it will not be an issue. But sometimes we need to scan again. And so nowadays, number 5, eruption control is being done. So that's what I heard in the buccal side. Thank you. And Dr. Choi.
High canine in the soldier. Extrusion will not work, but in 1 year and 10 months, the intrusion worked very well. Did you use any auxiliary appliances for that? I don't think extrusion would not work on that patient. In my view, the individual tooth extrusion can work well, but not in multiple teeth. But there was a distal space, so distalization was made as well. So it was not a pure extrusion. You talked about atose expansion. After the expansion, clear aligners were used. No, they were used in combination. Atose expander. How do we predict the expansion amount? Using clear aligners, it would be hard to predict. That's right. So I showed it to you. So do you use that in other patients as well? Yes, I wasn't confident in using it, but MSE and others who can do splitting the maxilla, determining the expansion amount. The dental expansion can be controlled with the dental, but the male patient that I showed you, aligner and the expander would expand the palate, and that would generate good results. I combine them. When aligners do not fit, I would fabricate them again, but it never happened.
Professor Park Jae-wook, as for palatal expansion, it's mixed incision. It's before growth patients, right? Dr. Choi.
So in adult patients without the help of surgery, you just use the palatal expansion device to expand 8 millimeters. I don't think it's easy. After shoots are closed, they don't expand. Screws were placed, and there are devices today, but there's some difficulties in adult male, but it works well among adult females. We have just 1 minute left. Online question to Professor Chung.
Is there a difference between the clear aligner and the bracket about relapse? Any difference? So it was a question from Smile Wave. In teeth movement, I don't think the teeth will know whether it was moved by the clear aligner or the bracket. And biologically, I don't think there is a difference. But retainers, we use the fixed appliance, and you use circum. And if you use clear aligners, you cannot use wires. So you use the clear aligner as a retainer. So it's not. So it's whether it's open occlusion or whether there's a gap in the occlusion. So that will be the biggest difference. So for the clear aligners, you could have the attached brackets, and telling them to use circum. So you could use the Enlight for the remaining period, but I think you should be aware of getting that occlusion. So I think there's that difference. Yes, one last question to Dr. Choi.
Last question to Mr. Che. When attachment are fallen and unaware of it, the patient would come, and the next step would not be fitting zirconia or gold crown. Attachments would often fall. What's your response? Gold crown or zirconia? MDP contained primers can be used. Then they would not fall. When they fall out, the attachment role is important. When attachment is not there, the movement of teeth is not achieved. But rather than that, the patient compliance is more important. When attachments fall off, that should be reattached. Using the original template, the appliance would not work, would not fit. So the attachments can be made again.
Thank you very much. So that was the last session. Thank you for the lectures and the Q&A. Let's give Dr. Jung and Dr. Choi a big round of applause. Thank you. Thank you very much. So that was the last session. Thank you, Professor Park, for chairing the session. A big round of applause. And those who are selected for the online best questions, we will contact you individually. Osstem Meeting 2025 Seoul. We are now nearing the end. We are getting your feedback. So offline participants, you are given text messages. Click on the link and participate in the survey. And 200 people will be given gift icons for chicken. And after the Achievement Award, we will also do the lucky draw offline. We will proceed with the Achievement Award ceremony to introduce to you the past winners. In 2013, Dr. Cho Young-seok. 2014, Dr. Jung Chang-mo. 2015, Dr. Jo Kyu-sung and Dr. Kwon Jong-jin. In 2016, Dr. Lee Kwang-hun. 2017, Dr. Jo In-ho. 2018, Dr. Kim Myung-rae, Dr. Oh Young-hak. 2020, Dr. Kim Ki-sung. 2022, Dr. Kim Young-gyun, Dr. Lee Jong-yeop. 2023, Dr. Oh Hee-gyun, Dr. Park Jun-woo. 2024, Dr. Yoon Kyu-ho. And 2025, first half, Dr. Jang Bum-seok has received the Achievement Award. And this year's achievement goes to, for the second half, it's going to be presented by Chairman Choi Kyu-ok. We will welcome him with a big hand. This year's Achievement Award goes to Professor Park Jae-ok. Please congratulate him with a big hand. Professor Park graduated from the Seoul National University College of Dentistry, completed training in OMS at the University of Zurich in Swiss, and received PhD from the same university. Served as the director of dental hospital at Seoul St. Mary's Hospital, Catholic University. Currently a clinical professor of OMS at Jeongbu Ulji University Hospital. He has made significant contributions to the dental community, especially in the field of OMS, fostering the next generation of scholars and advancing research and academia. Through industry-academia collaboration, he has played a major role in helping Osstem Implant grow into a global enterprise. In recognition of these achievements and his dedication, the company has selected him as the recipient of the Achievement Award for the first half of this year. Professor Park Jae-ok, Merit Award.
Contributions to the research and development of implant dentistry. September 28, 2025. Chairman of Osstem Implant, Choi Kyu-ok. 여러분, 박수 부탁드립니다.
Please give him a big hand. Professor Park Jae-ok has received the Achievement Award, and we will be presenting him with the prize, the plaque, a research fund of 10 million won, and there will be a photo session. So please face the camera in front and please hold up the plaque so that it is visible. Thank you very much. Congratulations, and we will hear from Professor Park Jae-ok. Thank you to Osstem Implant. Personally, Chairman Choi Kyu-ok and I go back to 1991. I came back from Switzerland and I was teaching at Hanguk University as a clinical professor, and at the graduate school, Chairman Choi Kyu-ok was in the graduate school, so he was a practicing surgeon. So that's when we met, and looking back, it was more than 30 years ago. And so throughout the years, unwaveringly, he has held a very good relationship with us. And the company at the time was before it was founded, and he has set up the company, and he has created this world-class implant company. And I believe that soon enough, it will become the number one company in the world. It is the pride of Korea and the pride of Korean dental community. And it's been 2 years since I retired, and such a big prize was given by such an important company. Thank you. And I will continue to make contributions to the growth of the company. Thank you, and congratulations once again, Professor Park Jae-ok. And yesterday and today we had the Osstem meeting Seoul 2025. And now, this is the moment that you have all been waiting for. We are going to do the online lucky draw first. We are going to draw a total of 6 people. Osstem Family Dental Care Kit, 3 people. And Beautis White Light Dental Curing Light, including 2 gels, for 2 winners. And the final winner will be getting the Galaxy S Tab Ultra from Samsung Electronics. And one thing you need to remember is after the online lucky draw is over, we are going to have a separate offline lucky draw. So please stay in your seats. And so this online lucky draw is for the viewers who have stayed with us until the end. We are going to spell out the 5 last digits for your mobile phones. And if there are redundant names, then we will draw 6 digits. And so the third prize winners, please press 890994. Congratulations. One digit is different. 68632. Congratulations. And the last third prize winner, 65665. Congratulations. So we have the 3 third prize winners, and now we will draw second prize winners. Beautis White Light will be given to 49791. 49791. Congratulations. One more. 30511. 30511. Congratulations. And the final prize goes to 40144. Congratulations. 40144. Congratulations. You take home the Galaxy Tab. Congratulations. And we will be contacting you individually so that you may claim your prize. September 27 and September 28, yesterday and today, we had the Osstem Dental Staff Forum and Osstem Meeting 2025 Seoul, and now we have come to the end. The speakers have enlightened us with their lectures and live surgery, and I hope this was a meaningful session for all of you, chairs, speakers, viewers, audience. Thank you, everyone. And with this, we would like to close Osstem Meeting 2025 Seoul. Thank you very much for staying with us until the end. And I am Kim Yoo-soo. Thank you.
하셨어요. 아유, 아쉬우신 것 같습니다. 네, 서울 탑치과병원 이나영 실장님 계실까요? 이나영 실장님 안 계시면 계속해서 뽑아보도록 하겠습니다. 김재성 치과, 심현희 치과 기공사님, 네 축하드립니다. 네, 무대 위로 올라오시면 되겠습니다. 김포 덴텍 박차웅 치과 기공사님 계실까요? 안 계시면 계속해서 뽑아보겠습니다. 네, 상인 라온 치과 배민호 원장님 안 계시죠? 판교 자연치과 유현수 대표원장님 안 계신가요? 네, 지금 가능성이 점점 높아지고 있어요. 싱하치과 임은주 원장님 축하드립니다. 네, 무대 위로 올라와 주시면 되고요. 한 분 더 남았죠. 대전 정용규 대표원장님 네, 축하드립니다. 네, 세 분 무대 위로 올라오시면 되겠습니다. 네, 세 분 구강관리 종합 세트 선물을 받아 가시게 되셨습니다. 네, 이어서 사진 촬영 진행 하도록 하겠습니다. 회장님과 함께 정면 카메라 보시고요. 네, 진심으로 축하드립니다. 네, 이렇게 3등 경품 추첨이 당첨되셨습니다. 저희가 따로 안내해드릴 예정이니까요. 이제 무대 쪽으로 돌아가시면 되겠습니다. 자, 이제 2등 2명, 1등 1명 이렇게 남았습니다. 과연 2등 와픽 2종 콤보 세트를 누가 가져가실까요? 하하 치과의원 강윤석 원장님, 네 축하드립니다. 서울탑치과 봉구 실장님, 네 축하드립니다. 앞으로 나와주시기 바랍니다. 네, 2등 2분 당첨이 되셨습니다. 와픽 2종 콤보 세트를 받아 가시게 되셨습니다. 네, 회장님 양쪽으로 한 분 한 분 서주시면 될 것 같고요. 네, 다시 한번 축하드립니다. 자, 이제 대망의 1등이 남았는데요. 여러분, 삼성 갤럭시 Z 폴드 7을 가져가실 한 분을 회장님께서 또 뽑아주실 예정입니다. 여기에서 나 뽑히지 않았다고 바로 일어나서 나가버리시면 분위기가 굉장히 안 좋아져요. 조금만 더 자리 지켜주시면 너무 감사할 것 같습니다. 아리따운 치과기공소 손은정 치과기공사님 계실까요? 계실까요? 패스. 아니, 없으시죠? 네. 자, 칠곡 스마일 치과 교정과 배정인 원장님 네, 너무 좋아하시네요. 네. 자, 서울 뿌리 깊은 치과 조영진 원장님. 와, 안 계시죠? 가셨죠? 연세 허브 치과 홍준영 치과 의사님 안 계신가요? 점점 더 기대가